Good morning, Per.
Good morning.
Oh my God.
Early morning. Yeah.
That was a short night.
Yes, truly.
And in actual fact, I was also mistaken because I got this message, start at 8 a.m., which would be 2:30. So, and the messages from Fabiana and the organizers were conflicting, so I wasn't sure. And so, just to be on the safe side, I shortened my sleep to something like 2 hours.
Yeah. Oh, it's fantastic. Yeah. Well, I wouldn't say I got much more, but yeah, I'm sure.
It would have been nicer to sleep in the Shangri-La, huh?
Yeah, absolutely. Oh my God. But we didn't have this 17 hours trip then.
That's true, yeah. That was a long trip.
And on Monday, the last restrictions in Denmark will be lifted.
Yeah.
We have more than 50,000 new cases every day. But, but in the whole country, we have 31 patients in intensive care. 31.
Yeah, it's quite amazing. Yeah. Yeah, we have about 100. Yesterday we had 140,000 new cases. Restrictions, I mean, still a little bit not like Denmark. So you will have the natural immunization and herd immunity, probably.
Yeah, they say so. In 2 or 3 weeks.
Touch wood, huh?
Yeah. My whole family has now gone down with coronavirus. They get into the hospital. So
oh my God.
My 2 daughters are down now, and so forth.
Hi, Peter.
Hello, Giancarlo. Good morning.
Sorry to involve you in this adventure.
Yeah.
My God. By the way, I've been asked by the MAGNIMS to suggest a topic, and I thought that the topic of the recent publication by Alberto Ascherio that revitalized the ABV story could be something interesting. What do you think?
Absolutely, yeah,
absolutely,
sure.
absolutely, yeah. Absolutely, yes.
So maybe the topic could be the revitalized EBV story.
Yes,
quite amazing, huh? Quite amazing, yeah.
Quite amazing. No, it was really interesting, I think. And as always, Alberto was very clever, I think.
Absolutely, yeah.
It was it was a very intellectual performance. And I read carefully the study. It was really a very brilliant idea.
Yeah. And then having this wonderful resource of the armed forces biobank, that's of course
amazing. They
amazing.
Have hundreds of thousands young men having a blood test. Yeah.
Yeah, that was unbelievable, really.
Okay.
But and by the way, it is in some way it is in line with the Mystery Solve project that has been promoted very recently by Hans. So
yeah,
it could be a good. We can maybe have one talk of Alberto, talk from Hans Lassmann presenting the project, and so one from the group.
Send a message saying we are starting.
Good morning, everybody. On behalf of the Sri Lanka Committee for Treatment and Research in Multiple Sclerosis and Related Disorders, I would like to warmly welcome all of you to the 3rd Annual Congress. And today we have a program including many symposia, and we are going to start with the SLCTRIMS ECF Symposium in collaboration with the European Charcoal Foundation. This will be on when to start and when to stop treatment in multiple sclerosis. So I would like to warmly welcome the ECF European Charcoal Foundation team, comprising of President Professor Giancarlo Comi, along with Prof Hartung from Germany, and also Prof Sorensen from Denmark, who will comprise the ECF team for this symposium. Thank you very much. Hope all of you will enjoy the academic sessions.
Hello? You hear me? Good morning.
The first speaker is Professor Hans Peter Hartung from Germany. He's going to talk on relapsing and remitting multiple sclerosis, when to start treatment and when to stop in MS.
Dear Chairman, dear colleagues, can you hear me?
Yes, we can.
And do you see my presentation?
Yes, we do, yeah.
Very good. Okay, so it's a great pleasure to participate in this meeting, and I'm very grateful to you for inviting me. We would, of course, from Europe, all like to be with you in person in Colombo, but the obvious reason prevents us. So a very good morning again from Düsseldorf, Germany. So I've been charged to talk about when to start and stop disease-modifying treatment of relapsing remitting multiple sclerosis. And you all know this depiction of the evolution of multiple sclerosis from the preclinical stage to the progressive stage of the disease. And of course, along these trajectories, the crucial question in the management of the patients is when to commence and when to stop treatment. We are, of course, guided by recommendations of various bodies. I just show here the SLCTRIMS year-end guideline, the last published version in the MSJ 3 years ago, but we, of course, are preparing the update that was presented already by Xavier Montalban at SLCTRIMS last year. and there's still probably an update coming up soon of the practice guideline recommendations by the American Academy of Neurology. If you also look at other recommendations, they converge in advocating the initiation of early treatment. And of course, the question arises, when should we start? I think it's clear that the diagnosis needs to be established with high fidelity, applying the 2017 revisions of the McDonald criteria. There's been a long story of accumulating evidence that early initiation does generate better outcomes. I remind you of the CIS trials, of the results of the open label extension of the phase 3 trials demonstrating that later initiation produced less optimal outcomes, but still the decision is one that needs to be tailored to the individual patient and is based on an aggregate of the clinical presentation, prognostic factors, a risk-benefit assessment, and acceptance by both us neurologists and our patients. Now, we've witnessed over the past couple of decades a very gratifying evolution of treatments, particularly for relapsing multiple sclerosis. And as we look from the left to the right, of course, new and more efficacious drugs have entered the therapeutic arena. And this has also prompted a re-evaluation. While we clearly adhere to the principle backed up by a large body of evidence that we should commence treatment early, there is a paradigm shift, a change from the escalation approach using a step-up approach from the more moderately effective treatments to the high efficacy treatments to a high efficacy frontline approach. This is based mainly on multiple large scale registry and observational studies that clearly uniformly demonstrate the benefits of starting with high efficacy DMTs right away. We still await the results of 2 controlled trials, but they won't read out before 2 or 4 years. And I would like now to at least show you some of the studies. I mentioned that clearly underscored that early treatment initiation is important. Here, for example, you see the study from Sweden demonstrating that if you start treatment within a year of making the diagnosis, the odds not to reach EDS4 are highest. If you delay treatment at least for a year, up to 3 years, this probability goes down and is worse for a delay by more than 3 years. On the other hand, if one looks at long-term disability, this is a recently published study combining the Danish MS registry, the Italian, the Swedish MS base, and the French one, a huge number of patients involved. And you see here quintiles of the time period that elapsed from the initiation of therapy, and those patients that had the lowest gap between the diagnosis and the treatment initiation in the long run had the lowest cumulative disability probability of confirmed disability worsening. This is the Swedish, the Danish study, basically showing the same principles. The probability of 6-month confirmed worsening was lower in patients started on high efficacy disease modifying therapy compared to patients with initiation by medium or moderately effective DMTs. And so you can build up a number of arguments for a broader use of high efficacy treatments in early multiple sclerosis. If we take the long-term view, we can look at the results from MS-BASE by Brown and colleagues that found that the initiation with moderately effective drugs compared to those with of high efficacy, the proportion of patients converting was higher in this group compared to the high efficacy group. So much for when to start treatment. Now let's talk about stopping disease modifying therapy. I will talk about relapsing and Professor Comi about progressive multiple sclerosis. Now, there are multiple reasons for discontinuation of DMTs in MS. Of course, there are certain contexts where you temporarily suspend DMTs, for example, when a pregnancy is planned, or when DMTs are switched and you have to respect washout intervals. We focus now on permanently stopping therapy, and the reasons for this action relate to the disease, to the patients, to drugs, and to access in terms of regulatory indication, reimbursement, budget restrictions, insurance coverage. Of course, you would consider this only if the disease is stable. Clearly, one of the questions that patients always ask and are concerned about, do I need to continue my treatment forever? Now, let's try to provide some answers. Some patients may have what has been called a benign cause. There is evidence for a decrease of inflammatory activity as the disease advances. We should, of course, consider stopping DMTs if the risk-benefit balance is no longer appropriate and the risks exceed the benefits. And we need to consider that with advancing disease and age, we face additional comorbidities such as cardiovascular, diabetes, arterial hypertension that elevate the risks of the treatment. And as mentioned earlier, there is the reason of inconvenience, tolerability, budget restrictions. Let's now turn to benign MS. Some time ago, Sean Pittock described patients that after a disease duration of more than 10 years had an EDSS of less than 3, and these were still ambulatory in the vast majority in 10 years of further follow-up. However, the concept of benign MS has been questioned, and I think there is now good evidence that it probably doesn't exist, or only in a very small minority of patients that are genuinely unaffected by symptoms after 15 years. And this study, again, in combination with a number of others, undermine the use of the term benign in the clinical setting. Now, there are a number of reasons why over the past couple of decades, the course of MS appears to be milder. And this has been summarized by Professor Soelberg Sorensen and colleagues. There have been changes in the diagnostic criteria, allowing the earlier establishment of the diagnosis. We have, as I showed earlier, significantly enlarged our therapeutic armamentarium, and there appear to have been changes in the natural history of the disease. I mentioned already the issue of age. If we think about the temporal trajectories of the disease, and here this clearly has to be taken into consideration when using the effective and even more so highly effective disease-modifying drugs. We are faced with the problem that the pivotal trials have usually excluded patients above the age of 55. So we cannot really gauge the benefit-risk ratio in this population. There's also growing evidence to suggest that the benefits of high-efficacy DMTs may diminish over time and with age. Several risks may increase with age, including the risk of infection and cancer. Immunosenescence, age-related effects on the immune system may interact with the effect of DMT in definitely not yet fully understood manner. This clearly warrants further exploration. At any rate, age should be a relevant factor to be included in the discussion when consulting a patient with MS with regard to starting on the one hand, switching, or stopping on the other hand of DMTs. Now, talking about the risks of infections. This is a study from the Swedish registry of more than 6,000 patients where the rate of infections were compared between the general population and various DMTs. And after confounded adjustment, the rate was definitely higher for rituximab, which is the #1 DMT in Sweden compared with all the other DMTs. Cancer is another risk to be considered and carefully factored in to our decisional process. Of course, we know that overall the risk is low, but the impact, of course, is high. The elevated risk was well established for older immunosuppressive medications such as azathioprine or cyclophosphamide. And the increased risk is most likely due to a decrease of immune surveillance as a consequence of disease-modifying therapy. There may be the possibility that the newer, more potent medications may carry higher risks if they very effectively or broadly dampen the immune system. So because the overall lifetime risk of cancer is high, it will be difficult to establish causality beyond doubt. This is a study again from Sweden, pointing towards a possibility that fingolimod may be associated with an increased risk of malignancy. So what happens, and that must be our concern, if we discontinued DMTs? This is a study of some 500 MS patients, about 2/3 relapsing remitting. that were above the age of 50 and had no relapses in the 3+ prior years. And what you can see here is the time to first relapse in stoppers and in stayers. The relapse-free probability does not differ significantly between continuous and discontinuous of therapy. And similarly, time to disability worsening is no different. Now, coming back to this issue of benign MS, burned out MS, I would like to quote the study from the Kaiser Permanente group, which, using these diagnostic criteria for what they call benign or burnout MS, 55 years plus of age, absence of progressive MS at any time, EDSS below 3 or stable residual deficits from older relapse, no relapse in the past 5 years, no MR activity over the past, new activity over the past 5 years, and at least 10 years into the disease. And they looked then at a population of 136 patients fulfilling their criteria. They discontinued them from disease-modifying therapy, and the vast majority of these patients remained clinically stable. Very few experienced a relapse. So they concluded that DMT discontinuation in older patients with presumed benign or burned out MS appears safe. Now, what about the impact on quality of life? This is one study that, first of all, showed that in their population of patients over age 60, some 30% discontinued, and 90% of those who discontinued did remain off DMTs. Patients that continued had a lower quality of life scores compared to those that discontinued. Now, again, we need, of course, to be assured that the disease doesn't reactivate. And there are predictive factors that have been identified, and I just refer to this paper from the Innsbruck and Vienna groups that show that the age at discontinuation, the presence or absence of gut-enhancing lesions, of relapses, and a combination determine the probability of a relapse upon discontinuation. Younger patients, patients with gut-enhancing lesions, relapses in the 4 years prior to discontinuation had a higher risk to experience disease recrudescence. An Italian study from Florence looked at NIDA-3 and demonstrated that a NIDA-3 period on treatment of at least 5.5 years was associated with a low rate and a low risk of new disease activity. Now, there are, of course, the issues of rebound after discontinuation, particularly for natalizumab and the S1PR modulators, that need to be taken into consideration. We see here, and you are all aware of this, that natalizumab discontinuation is associated with a risk of rebound. If we compare this with discontinuation of platform first-line therapies, 2/3 remain stable compared to 1/3 following stopping natalizumab. Now, coming to my conclusions, I'd like to reiterate reference to the practice guidelines. This is from the American Academy 2018, stopping DMTs and RRMS in people who are stable on DMT and want to discontinue therapy. We should counsel them regarding the need for ongoing follow-up and periodic re-evaluation. Again, with the knowledge that I tried to summarize about the risks and predictors of disease recrudescence. Our Canadian colleagues somewhat later summarized treatment optimization algorithms and saying that clinicians may consider stopping treatment in relapsing MS patients above 60 years who've been clinically stable for a prolonged period, and they say 5 to 10 years. And they again address the reasons why one should consider to do so. And of course, they emphasize again the necessity to closely monitor patients regularly if need arises to reinstitute therapy. Now, we are eagerly awaiting longitudinal interventional prospective randomized trials of discontinuing DMTs, the DISCOMS, the DOT, and an Italian multi-center discontinuation study. I now come to my conclusions. DMTs should, that's my personal view, and I think this is backed up by a large body of evidence, started as soon as the diagnosis is firmly established. We are probably currently experiencing a paradigm shift toward high efficacy frontline DMT versus the traditional escalation approach. In terms of discontinuation, there are multiple reasons to consider that, either temporarily or definitely. Natural history of the disease, efficacy, burden of DMTs provide a rationale to abandon DMTs in older individuals who've been clinically and radiologically stable. However, this is a contentious issue, and there may be a divergence of the patients and the neurologist's views, and a number of external non-medical factors go into the decisional equation. Clearly, after withdrawal of DMTs, continued monitoring for breakthrough disease is mandatory, and this is reflected, as I mentioned, in convergent recommendations by a number of neurological societies and bodies, and the results of the controlled interventional studies are eagerly awaited. And with this, I'd like to stop and thank you very much for your attention.
Thank you very much, Professor Hartung, for that excellent comprehensive talk on when to start and when to stop treatment in relapsing remitting MS.
Thank you.
We'll leave the questions and the discussion to the end for the panel discussion, and we can move on to the second talk.
Good morning. We continue on the same theme of when to start and when to stop treatment. So the next speaker is Professor Giancarlo Comi, who is no stranger to our audience here, and he will be continuing, he'll be talking to us on when to start and when to stop treatment in progressive multiple sclerosis. Over to you, Professor Comi.
Thank you so much. Again, it's really a great honor and pleasure to be with colleagues and friends from Sri Lanka. And of course, I also agree with Hans Peter, it will be fantastic to be back there next edition of the SLCTRIMS. So my talk today will concern when to start and when to stop treatment in progressive multiple sclerosis. So, as you know, there are two types of progressive MS, primary progressive, probably 10-15% of patients, and secondary progressive, where we may estimate that more than 2/3 of patients who start with a relapsing course sooner or later will evolve to secondary progressive MS. We have seen in the previous presentation by Hans Peter that this proportion may be reduced by the early treatment of relapsing MS. We need long-term data just to have a clear evidence of this type of effect. What is really different is the mechanistic aspect of relapsing and progressive phase of the disease. We know that in relapsing phase, we have a wave of inflammation coming from the periphery, entering the central nervous system, both with a consequence of focal lesions and a quite diffuse white and gray matter damage. From the other side, in the progressive phase of the disease, we have a process of neurodegeneration taking place inside the nervous system, which is mostly driven by local confined effects in the central nervous system itself. And here you see a bit of cartoon showing which different mechanisms are playing a role in this degenerative phase of the disease. Is still really unclear which one of these different mechanisms is dominating. To make the long story short, I have to only to add a point here. It seems that the glial component of the central nervous system, both astrocyte and microglia, is playing a major role. And this is the story of the smoldering lesions that you can see here, now easily shown by MRI as a rim that is just surrounding the lesion. About 20% of the lesion, a bit more in relapsing MS, a bit more in progressive MS, are really characterized by this aspect. And what happened in this edge of the lesions is the presence of an activated microglia that is in a crosstalk with astrocyte and in some way may really have a key role in the destruction of the axon. And here, what was really evident very recently by Martina Psinter research, the evidence that complement could play a very important role, and also that still we have some role played by the T cells. So this is very important because it's clear that drugs that are really relevant as anti-inflammatory drugs in the relapsing phase of the disease may have only a limited effect in the secondary and primary progressive course of the disease. Here, as you know, the very important change in the classification of the courses was published in 2013, and it was the result of a quite clear reconsideration of the courses. And what was really new in this reclassification was the fact that both for primary progressive MS and secondary progressive MS, there was a subclassification in patients with active course and patients with inactive course. So what made this big difference was the fact that in patients in in an active phase of the disease means with still some evidence of new or expanding lesions in T2 weighted images and or enhancing lesions and or attacks were in a different condition compared to those with inactive type of cause. Of course, the presence of an active cause means that still in this type of patient, there is some residual effect of the wave of inflammation coming from the periphery entering the central nervous system, which we know may be quite susceptible to strong inflammatory treatments. So, of course, this subclassification has a tremendous implication in terms of treatments. What is new here is that in the last 5 years, it started to be more and more clear that this chronic progressive phase of the disease and the underlying neurodegenerative mechanisms are probably already there in the relapsing phase of the disease. It's still not clear when this type of neurodegenerative mechanisms are really taking place, if they are there really since the beginning, or if they start to be operative at a certain time during the relapsing phase. And this type of condition has, again, very important implication, because if these mechanisms, they start to be operating at a certain point, it is probably true that from that time, for that specific time point, there is some irreversible type of future damage that may occur. And I mean, this is, of course, again, with a strong implication in terms of prognostic factors. This evidence of a silent lesion is coming from some recent observations. As I said, the most, let's say, interesting one, and the one which opened the discussion about silent lesion was by the UCSF group. Bruce Clear and others showed that in patients followed for many years, the presence of brain atrophy exceeding what you can expect as a normal effect of age was there not only in those with attacks, but also in those without attacks, meaning that there was some mechanism that was determining the degeneration of the brain tissue that was not strictly related to disease activity and to lesion. This type of observation has been reinforced by another observation, and the observation is that in the reanalysis of some clinical trials, and more recently also from observational studies, it was evident that the proportion of irreversible disability progression accumulation in the relapsing phase of the disease was in more than 50% of the cases, independent from the occurrence of attacks, and the PIRA-consent, progression independent from relapse activity, was indicated as the modality to assess this type of event. So again, some evidence of this type of degeneration taking place already in the relapsing phase of the disease. And as a consequence, the community, scientific community, started now to consider the possibility to review the classification of the disease courses, taking into consideration these recent observations, and the process is ongoing. So now, moving to the treatment aspect, here, of course, you see the list of different type of clinical trials that have been performed, estimating the effect of different interventions in secondary progressive MS and in primary progressive MS. As you see, a lot of failures, with some partial failure for interference and mitoxantrone. I will be back in a minute about this point. And only 2 clear positive results, siponimod for secondary progressive MS and ocrelizumab for primary progressive MS. So the failures for interference were clearly evident, with only a partial exception of the European study in secondary progressive MS, where beta interferon 1b interferon resulted to have some effects, but we have to consider that the population of patients included in this European study was characterized mostly by an early secondary progressive phase of the disease, with a significant proportion of patients with still overlaps of attacks. So probably an effect that was mostly explained by the impact of interferon beta on the residual relapsing activity. Mitoxantrone was also approved in many countries. However, we have to consider that this drug was tested essentially in a large study where only a proportion of patients was affected by progressive MS. So there was not really what we can consider a class 1 evidence of the effect of this drug. And on the top of that, of course, is a drug that can be used only for a short period of time, probably not more than a couple of years, in order not to have to deal with some major adverse effect like leukemia and some heart pathology. So same story for primary progressive MS, where we had a lot of failures. Only with rituximab in a post-hoc analysis, there was some evidence that patients younger and patients with a shorter disease duration had some benefits in terms of protection from the disability progression. Again, this was in some ways supported also by an observational study on a large Swedish cohort, where it was evident that patients treated with rituximab had a benefit also in patients with secondary progressive MS, and a benefit that was clearly there when compared to patients treated with first-line therapies. And I think this is a very important observation, because post-marketing studies also reveal that the injectables, or more generally first-line therapies, essentially failed to have an impact on the progression of disability, both in secondary progressive and in primary progressive study, as you can see here. So confirming the negative results of the clinical trials. On the opposite, there was some evidence that patients treated with more aggressive anti-inflammatory treatments had some benefit. But again, this type of benefit, as you can see here, was mostly due to the effect of these drugs in patients with active secondary progressive MS. So again, in patients who continue to have some evidence of new lesions in the brain or new attacks. So again, something confirming the evidences coming from clinical trials. As I said, two drugs succeed. The first one is siponimod in patients with secondary progressive MS. I think siponimod is one S1P modulator, is the evolution, one of the evolutions of fingolimod. Is really a quite interesting drug, because it has a more selective effect on the class of S1P receptors, with the advantage to have a better central nervous system penetration and then a much higher concentration in the central nervous system, and less adverse effect because it is more selective, targeting just S1P1 and S1P5, with less cardiac effects and also some other less relevant effects at the macular level. The drug, as I said, has also some central effects that are summarized in this cartoon, effects that have been revealed by many converging evidences. Nevertheless, this type of effects that seems to be due to an impact on glial cells, both oligodendrocytes, microglia, and also astrocytes, still is not clear how much of these central effects play a role on the positive results of the phase 3 clinical trials. Nevertheless, they open the possibility that beyond the classical anti-inflammatory effect of this class of drugs, there is also something that may take place in the central nervous system. So here you see the list of these effects, no way to go too much in detail, but one point is really, I think, relevant, and is the evidence is that this drug may also impact the process of remyelination. Again, how much of these basic studies may really translate to something relevant in the human pathology is still far to be known. So I think all of you already know the results of the EXPAND study, very large study, very well performed. Here you see the impact on disability progression. Someone may say that the effect was not so large. There was a 21% reduction on the risk of disability progression for the 3 months confirmed disability progression, 6 months confirmed disability progression with an effect of 26%. Nevertheless, the effect is there, is clear. There's no doubt that it impacts the evolution of the disease. Not only this, but also in the extension of the study, it was confirmed that those who receive immediately the treatment with siponimod compared to those who had a delayed onset of treatment maintain an advantage in terms of risk of disability progression. So again, a quite clear effect. What is to me of very high relevance is the fact that the drug was able also to impact a very strong endpoint, that is the wheelchair-bound condition. As you see here, there was a quite clear and significant reduction in the risk to evolve at the level of 7 of the EDSS scale, quite, I think, important evidence. What is supporting the interpretation that still the anti-inflammatory effect at the periphery is playing a major role is the analysis, subgroup analysis that you can see here. As you can see here, in fact, those patients who most benefit from the administration of siponimod were those younger with less disability at entry, a shorter disease duration. So again, all factors that suggest that the drug was more effective when used in the early phase of secondary progression. Another very important point is the effect on cognition, because the effect on EDSS is almost completely explained by an effect on deambulation. Here, it is good to see that also at the cognitive level, we have a positive effect of siponimod. And here you see this type of effect measured by a single-digit modality test, which is now considered the gold standard among the different cognitive tests. A quite clear effect that is really persisting over time. There is another type of observation that may suggest some impact of siponimod also in the pathology and the mechanistic effects that are present inside the central nervous system. Here you see that a measure of the central nervous system structural damage, that is the magnetization transfer ratio type of MRI analysis. Here applied to the normal appearing brain tissue, normal appearing white matter, and the cortical gray matter. And you can see here two interesting observations. The first one is that in all these type of components of the central nervous system, there is a positive effect of siponimod. But the second very important point is that this effect is really very strong for normal appearing white matter tissue, again indicating that there is some diffuse effect in the central nervous system of this type of drug. I have to say nothing really new in terms of safety. I don't want to spend time from this point of view. The drug, as you know, has been approved now both in United States, in Europe, and now in many other countries. So concerning then treatment for progressive MS, we can see now which is the position expressed by the European guidelines just mentioned in the previous talk by Hans Peter Hartung. So here the recommendation is clear for patients with secondary progressive MS with evidence of inflammatory activity, that means relapses and or MRI activity. It is really indicated to treat patients with siponimod. However, it was also added that treatment with other DMTs used for relapsing MS, that are all those who have been approved for relapsing MS, may also be considered. Let me add here that my personal view is that not all these treatments are recommended. Are recommended only those who are characterized by a more larger effect on the inflammation. So also there is a suggestion to consider, because of this effect of powerful anti-inflammatory effect, to consider also the possibility to treat with anti-CD20 monoclonal antibodies. Again, always taking, of course, into consideration the effect of the drug. And this is particularly true not only in those with an active MRI or clinical attacks, but also in those with a very rapid disability accumulation, particularly if they are younger. What about mitoxantrone, another drug that has had some approval? Again, here the recommendation is to consider such a drug only when there are no other possibilities, when in countries, for example, where siponimod has not been approved. So it's in some way there in order to underline the fact that also some other anti-inflammatory treatments may have a role to play in this type of condition. What about the other drug, the drug approved for primary progressive MS? Ocrelizumab, you know, is active with many mechanisms, and probably here also including some effect on the central inflammation that is linked to the so-called type 3 lesions, those cortical lesions that are mostly present in the depth of sulci and related to the presence of follicles of B cells, something like very small lymph nodes. So the effect of the drug was again there. If you look here, the dimension of the effect is very similar to the one that has been observed with siponimod in secondary progressive MS, a 24% reduction in the risk. And also here, the effect was much clearer in those patients with evidence of disease activity, as demonstrated by the presence of GAD lesions at the study entry. The effect in those without GAD lesions, as you see here, was much less clear. Again, long-term studies have confirmed that early treatment with ocrelizumab in primary progressive MS has very long-lasting effects, and the benefit due to an early intervention are still there after even 10 years. So again, the same story that we have already seen before. I can skip this one. We have, of course, a lot of data that are now accumulating that may again confirm that in the very long time we continue an effect of this drug, and the effect is there particularly in some aspect like the walking ability, which is again a quite relevant type of measure. For progressive MS, there is now a type of measure that is becoming quite relevant, that is no evidence of disability progression, is a bit a version of NIDA applied to progressive MS. If we apply this concept to patients treated with ocrelizumab, again, we have a quite clear evidence of about 50% reduction in the proportion of patients reaching this not evidence of progression when the drug is compared to placebo. So a quite clear effect. And again, here you have also another clear evidence on a parameter that is considered extremely relevant in patients, fatigue. As you can see here, treatment with ocrelizumab was associated with a stable fatigue compared to a progression of fatigue observed in patients in the placebo arm. So again, some evidence that is really very interesting. So of course here the key discussion is about the use of this drug. Is this drug that has to be there only for patients with an active MS, or should we also take into consideration the possibility to use this drug in patients without evidence of relapses or MRI activity? Again, this is one of the studies that try to approach this type of problem, looking at the effect of the treatment on serum neurofilaments. Again, if you look here, it is clear that the effect on serum neurofilament was quite variable from patient to patient, but essentially the effect was much larger in those who started with the presence of gadolinium compared to those without this evidence, again supporting the view that the drug is particularly relevant in those patients with evidence of activity. And this other study showed that in comparison with relapsing MS, where the treatment with ocrelizumab was resulting in a very substantial drop of the neurofilament levels in the serum, in patients with chronic condition like primary progressive MS, and these are patients included, a small group of patients included in the oratorio compared to patients included in opera. You can see here two things. First, that the level of neurofilaments at baseline were much lower in progressive MS compared to relapsing MS, probably due to the much lower presence of active disease, and as a consequence also the effect in the level was really very minor and statistically not significant in primary progression, on the contrary, quite significant in relapsing MS. Again, for safety data are there here because of the older age of patients in primary progressive trial compared to relapsing remitting trial. The problem of infection has to be carefully considered. And particularly the ocrelizumab has to some minor risk also for PML, something that has to be very carefully estimated. So what about and this is just what about the stopping treatment? Of course, here the story is very short because we do not have enough observation to say if the use of siponimod in progressive MS and of the use of ocrelizumab in primary progressive MS, when these drugs are discontinued, may result on reappearance of the disease. There are no data, essentially, so we cannot say nothing about that. We need to have more observation. What we can say here is that the very key point is if we have to continue to use treatments like the injectables in patients that move from the relapsing to the secondary progressive MS. This type of problem has been examined in a couple of studies. This is the French study where it was clear that for the disease reactivation, there is some risk to discontinue injectables in those patients who enter the secondary progressive phase of the disease. This risk is usually present only in the very early phase after the discontinuation. This is more a transitory effect that can be seen in not more than 20% of the patients. And what is very important is this is an effect that is only there for a short time, and there is really no impact on the risk of disability worsening. So it seems that this drug do not really have an impact on the disease course, not in terms of a beneficial effect, but also no negative effect if they have to be discontinued. This data has been already presented by Hans Peter, so I will not consider that. So in conclusion, I think that we have seen that we have to treat patients with secondary progressive MS with the available anti-inflammatory treatments because they may respond to this treatment. The response is much better if the type of disease is still some residual activity. The concept then, and the definite answer to when to start is you have to start as soon as possible. So the same type of law that we have seen for relapsing MS is also working for the progressive phase of the disease. The drug that we have now available, they have some possibility to influence the course of the disease, but this is only possible in the early phase of primary and secondary progressive MS. And about discontinuation, we should not really expect very big problems for ocrelizumab because there is no evidence of rebound with this drug. Vice versa with siponimod, we may expect to see some rebound because this has been shown in relapsing remitting MS, and there are a couple of studies that have also revealed such a possibility. However, we need more data just to try to confirm this observation. Thank you so much for your attention.
Thank you, Professor Comi. I think in the interest of time, we will leave all questions to the end of the symposium.
Yeah, now we move on to the third lecture in the symposium. The role of biomarkers in the decision-making process when deciding on when to start and when to stop treatment in multiple sclerosis by Professor Soelberg Sorensen from Denmark. Over to you, Professor Sorensen.
So, good morning, dear Chairman, dear colleagues. I hope you can see my screen. And thank you for the invitation to give this talk on the role of biomarkers in biological fluids. These are my disclosures. Well, what is a biomarker? Well, a biomarker has been defined as a characteristic that objectively is measured and evaluated as an indicator of a normal biological process, pathogenic processes, or pharmacological responses to therapeutic interventions. There are different kinds of biomarkers. We have the genetic and immunological biomarkers, MRI biomarkers, optical coherence tomography, neurophysiological biomarkers, and evoked potentials biomarkers. And then we have the biomarkers in body fluids that I'm going to talk to today. And these can be measured in CSF and in the blood. There are different kinds of biomarkers. There are predictive, diagnostic, and prognostic biomarkers. There are markers of disease activity, drug inhibitory biomarkers, treatment response biomarkers, risk stratification biomarkers, and disease progression biomarkers. How do we get access to those biomarkers? Well, we can use cerebrospinal fluid and blood. And of course, the cerebrospinal fluid is the compartment that is closest to the CNS, the pathophysiological processes take place. But lumbar puncture is not feasible in the daily clinical practice. So we are more or less have to do with blood, but there is, of course, an exchange across the blood-brain barrier between the CSF and the blood. There are many biomarkers that have been discussed with in multiple sclerosis, and of those biomarkers, only some have been validated, and only a few have been used in clinical daily practice. And these biomarkers are the anti-natalizumab antibodies. This is a response biomarker to find non-responders, and also neutralizing antibodies against interferon beta are used as a biomarker to identify non-responders. Oligoclonal bands in the CSF is a diagnostic biomarker, but in fact also a prognostic biomarker. The anti-aquaporin 4 antibodies are used as biomarker in NMO spectrum disorders. Then we have the anti-JC virus antibodies. This is a risk stratification biomarker for PML in patients treated with natalizumab. And then neurofilament light, that's a prognostic and treatment response biomarker. So just a few words about the current algorithm for treatment of multiple sclerosis. And how can we use biomarkers? Well, today I will primarily focus on the prognostic biomarkers, and they are used in the decision making when we are discussing whether to start a treatment with a moderately effective DMT or a highly effective DMT. And also we have the treatment response biomarkers. And this is what we use when we are monitoring people with MS and discuss whether we should continue treatment unchanged, if we should switch to another moderately effective DMT because of adverse effects, or if we should switch to a highly effective DMT because of breakthrough disease. So today we are using the time that we want to treat to target, meaning that we aim at achieving NEDA, no evidence of disease activity. And we have to take an individual approach. So when we start treatment, we define the patient's MS with the MS prognostic and the lifestyle and goals. And then we have to choose our therapy and to take into consideration the patient's preference, your own choice. And for this, we can use prognostic biomarkers. And then eventually we would have to have shared goals and shared decision with the patients. Then we start treatment with either X, Y, or Z, and we do a rebaseline. And what is a rebaseline? Well, a rebaseline is that we make a new MRI after 3 to 6 months. And we do this because when we are starting to assess the effect of a treatment, we want the treatment to have started working And also, if we are switching treatment, we do not want to have any carryover effects from the previous treatment. And then we are monitoring patients at least once yearly with MRI and clinical evaluation, and have to take the decision, is there a treatment failure? And this is based on individual measures, like is there any evidence of activity? Is there an issue of tolerability or safety? How is the adherence to the drug? And for this, we can use, as I shall show you, response biomarkers. And also in the daily clinical practice, we are looking for drug inhibitory biomarkers. So then we are aiming to treat to target, and usually we're aiming at what we call NIDA-3, meaning no signs of relapses, no disease progression, and no MRI activity. But in fact, we could include also a fourth issue, the normalization of the neurofilament light. So if we, based on this, decide that there is no treatment failure, we will continue monitoring the patient. And if there is a treatment failure, we should choose a more effective therapy. So again, when we start treatment, we are looking for predictors of a poor prognosis and use demographic and environmental factors, clinical factors, MRI observations, but also biomarkers. Now, of course, as you know, the MRI biomarkers, but also biomarkers in biological fluids, the presence of oligoclonal bands in the CSF, a high level of neurofilament light chain in the serum or CSF, or high levels of chitinase in the CSF. So the first decision making is how to initiate therapy. Can the patient be treated with a moderately effective therapy, which is the case for most patients today, or do we have to choose a highly effective therapy from the start? And I think that this approach is getting more and more common. I think more patients should probably start with a highly effective treatment. As Hans Peter Hartung showed, this is a more effective approach. So the prognostic biomarkers in the CSF are many. A lot of biomarkers have been studied, and some of these can distinguish between patients who after 2 years will have no evidence of disease activity and patients with evidence of disease activity. And they include neurofilament light and heavy, glial acidic protein, CXCL10, osteopontin, CXCL13, and CCL22. And as I said, the presence of oligoclonal bands is primarily a diagnostic biomarker, but in fact, it is also a predictive biomarker. And here you can see the risk of EDSS worsening in patients with oligoclonal bands is higher than in patients without oligoclonal bands in the CSF. And also, if you look at patients with CIS, the risk of worsening to EDSS3 is significantly higher if oligoclonal bands are present compared to absent oligoclonal bands. And in fact, you can see that the risk given by the oligoclonal bands is the same magnitude as having 10 or more lesions in MRI. So if we look for neurofilament light in the CSF and use this diagram and see the overlap to patients who suffers evidence of disease activity, there is a considerable overlap. And in fact, CSF neurofilament light measurements at the time of diagnosis showed an overall sensitivity of 75% and a specificity of 98.5% for detection disease activity. Also, a study showed that chitinase 3-like 1 glycoprotein was a prognostic factor in the present in high CSF. It was predictive for reaching EDSS3 in CIS patients, both in univariate and in multivariable analysis. So what about the prognostic biomarkers in blood? Well, this has become possible to look for the serum neurofilament light with the use of a highly sensitive single molecule ELISA called single molecule array, or SIMOA. This has made it possible to reliably detect neurofilament light in the blood. And as you can see here, serum neurofilament light in the blood at baseline predict relapse-free disability progression in a prospective longitudinal MS cohort. Patients with a high concentration of neurofilament light are more prone to have progression compared to patients with a low concentration of neurofilament light in the blood. And also, if we look at a very long observational study, we can see that the association of serum neurofilament light level at baseline is associated with the percentage of brain atrophy over time already after 1 year and continued throughout the years through 10 years of observation. So, in fact, when we start therapy, we have to decide the initial therapeutic stratification. And we use for this risk factors with MRI, molecular bands, clinical characteristics, but could also use neurofilament light concentration in the blood to decide whether we need to start a highly effective treatment in patients. And then the next decision is, of course, that when we are monitoring patients, is are we going to maintain therapy unchanged? Is there a need for a switch to another treatment at the same level of activity, or is there a need for escalation of activity? So switching to a drug at the same level of efficacy is usually done if there are issues with tolerability or safety. Whereas if we are looking for problems with efficacy, we should choose escalation to a drug at a higher level of efficacy. So again, with a suboptimal treatment response, patients should be escalated in efficacy of the treatment. Also, we have, during many years, used drug inhibitory biomarkers in daily clinical practice. This was first done with neutralizing antibodies against interferon beta. These antibodies appear in a proportion of patients, and if they are present, they will bind to the interferon molecule and prevent the interferon from reaching its receptor, and therefore we will then have no induction of interferon-inducible proteins. And as you can see, neutralizing antibodies are present in a large proportion of patients, but at varying proportion between 5% up to approximately 40%, depending on the interferon beta preparation. And already from the first trial of interferon, the interferon beta 1b trial, it was obvious that if we look at a time when antibodies are present, which usually occur in after 1 year of therapy, we can see that in patients who are antibody positive, the annual relapse rate is almost double as in patients who are antibody negative, and in fact, the same as we see in placebo-treated patients. And the same was seen with interferon beta 1a in the PRISM study. Again, in year 3 and 4, the annual relapse rate in negative patients were only the half, almost as in patients who are antibody positive. And in fact, we can see that it is the antibodies that make this change in efficacy. Because if we check a longitudinal study in which some of the patients at a certain time became antibody positive, while others remained antibody negative, we can see that before 1 year, when antibody has not yet appeared, there are no difference in the annual relapse rate between those patients who will become antibody positive and those who remained antibody negative. But then after 1 year, when patients become antibody positive, now the annual relapse rate in the antibody positive patients are the double of the that's seen in antibody negative patients. We also know that antibodies tend to disappear over time. And after some years, when the antibodies had disappeared, we can see that now there are no difference in the annual relapse rate between those patients who at a certain time were antibody positive and those who remained antibody negative throughout the treatment. Also, with natalizumab, there is a risk of neutralizing antibodies, and in the pivotal trials of natalizumab, it was shown that 9% of the patients developed antibodies, and in 6% of the patients, the antibodies was permanent, whereas in 3%, they were transient. And if we look at the effect of the antibodies, we can see that those patients who were antibody positive had an annualized relapse rate that was similar to that seen with the placebo patients and much higher than the annualized relapse rate in the antibody negative patients. So if antibodies occur, we have to discontinue treatment with natalizumab. Also, biomarkers can be used for risk stratification. And this is also done when we treat with natalizumab. Then we use antibodies against JC virus as a risk stratification of PML. So if a patient is negative for JC virus antibodies, we can treat patients with natalizumab, but have to do 6-monthly tests for JC virus antibodies. And if the patients become antibody positive, we would have to consider, at least after a year, to switch the patient to another therapy. And if we start treatment in a patient, we would then see if we have antibodies, and now it's possible to look for antibodies concentrations. So if we have antibodies with a high index or a high concentration, we would not start treatment with natalizumab. However, if there is a low concentration of antibodies, we could consider starting therapy, and then because the risk increases after 2 years, then after 2 years, we would have to discuss and recommend the patients switch to another therapy. Then there are the treatment response biomarkers. And neurofilament light in CSF was shown to be associated with relapses. And here we can see a study where they followed patients, and patients with a low concentration of neurofilament light without relapses, and there was a higher concentration of neurofilament light in patients who relapsed. And the same was the case if we look at patients without MRI activity the concentration in CSF or neurofilament was significantly lower than in patients with MRI activity. Also, long-term follow-up of patients have shown the value of measurements of neurofilaments, both in the CSF and in the serum. And if we look at the proportion of patients who reached EDSS-6, meaning losing gait, unsupported gaits at 8 years, and then stratified the patients by the brain parenchymal fraction, meaning its brain atrophy, and the mean levels of neurofilament, we can see that for CSF, patients who had a low brain parenchymal fraction change, meaning a low atrophy, in these patients with a high neurofilament had a higher proportion of patients reaching EDSS than in patients with low neurofilament concentrations. And in fact, the same was the case if we look at patients with more atrophy. There was a higher proportion of patients reaching EDSS-6, but again, it was higher in patients with a high neurofilament compared to patients with low neurofilament. Looking at serum neurofilament, we saw the same pattern in patients with low grades of atrophy. There was a much higher proportion of patients reaching EDSS-6 when there was a high concentration of neurofilament compared to patients with a low concentration of neurofilament. And also with patients with a more atrophy, again, there was more patients who reached EDSS-6 with high concentration of neurofilament compared with low concentrations of neurofilament. And also in this study, they looked at how the levels of neurofilament light reflected therapeutic decisions within 4 years after diagnosis. So they used serum neurofilament measurements at baseline, after 2 years, and after 4 years. And they could see that high efficacy DMT was initiated more often in patients with high serum neurofilament levels, both at baseline and at 2-year follow-up. And also, if they looked at the baseline neurofilament levels, they correlated with the number of medication switches during the first 2 years, and also during this between 2 and 4 years. Higher neurofilament light concentrations had more switches of treatment. And again, looking at neurofilament at 2 years follow-up, we could see that there was a significantly increase of patients who had to escalate the DMT from moderately to a highly effective therapy between 2 and 4 years in patients with high levels of neurofilaments compared to patients with low neurofilaments. That was a more patients without a class switch. So, as you can see, we used neurofilament when we are initiating patients, but we can also use neurofilament as a biomarker in monitoring patients. On treatment, we would monitor patients every 6 to 12 months and see whether patients are stable or if there are signs of clinical disease activity or progression. And in patients with disease activity or progression, it is recommended to switch to a higher efficacy therapy, based, of course, on MRI also, but also on comorbidities and so forth. But then if we look at clinical stable patients, it is suggested to use neurofilament to decide whether it is necessary to do an MRI. If the patients have a low neurofilament light in the serum, it is not needed to do an MRI. But if there is a high concentration of neurofilament, patients should have a brain MRI. And if this brain MRI is active, we have a patient with a high neurofilament and an active MRI. And these patients, we should consider to switch to a higher efficacy therapy. In patients who have a stable brain MRI, we have then a high neurofilament light concentration, but a stable MRI. So we might look for other reasons why we have this high neurofilament light. It could be we do a spinal cord MRI to see if there is activity there, or we could look for other reasons for increased neurofilament light. And if we don't find any reason, we should do a close monitoring with repetitive evaluation to consider whether we need to switch to a higher efficacy therapy. So in conclusion, regarding the daily use of biomarkers in biological fluids, only a few today are used in daily clinical practice. We have neutralizing antibodies against interferon beta and natalizumab to identify non-responders. And we use measurements of antibodies against the John Cunningham virus as risk stratification for PML in patients treated with natalizumab. With the establishment of highly sensitive single molecule Simoa, it has been possible to reliably detect neurofilament light levels in the blood. And measurements of neurofilament light increases the diagnostic accuracy, predicts the disease course prognosis, and when measured longitudinally, predict ongoing MS disease activity and disability. And serum neurofilament light may contribute to the choice between a moderate or a highly effective drug as the initial treatment, and to the decision regarding treatment escalation in patients suspected to have a suboptimal therapeutic response. And thank you for your attention.
Thank you very much, Professor Sorensen, and that concludes the symposium. Now it's open for discussion. The panelists, all three panelists, will be eager to answer any questions and discuss further with regards to the topic of starting and stopping treatment in MS.
Dr. Senanayake, can I start asking Professor Soelberg Sorensen?
Yes, yes.
Peter, thank you so much. I think really the neurofilaments is probably becoming an extremely interesting and also practical type of tool to monitor the disease. My curiosity is to know if the proportion of patients who have a high level of neurofilaments but no evidence of MRI activity could be something related to the sudden, what is called the silent disability progression. So, and what is your view about this possibility? And as a quite clear related question is if the neurofilaments can be then a very important measure for the monitoring of progressive MS, where we know that MRI is not really informative.
Well, as I presented, there are studies now that have shown that neurofilament is actually a measure of the silent or non-relapse related disease worsening in relapsing remitting MS. And so I think that neurofilament is both a measure of relapse activity, but also a measure of silent disease worsening because of probably what will lead to atrophy and so forth. So I think it is an important additional tool we have had for the assessment of whether the disease is really stable or not.
Thanks.
I would like to ask Hans Peter also, what do you practice stopping treatment in Germany? Is any rules when you stop therapy, or how it is decided if you're going to discontinue therapy in a patient? You are muted, Hans Peter.
Sorry, always the same error. I was saying that there is no generally agreed upon approach. I mean, many people follow the principles that I discuss, but oftentimes sort of in dubio pro, there is the attitude, let's just continue if of course the patient is doing all right. Let us not risk a disease recrudescence. And it really often depends also on the view of the patient.
And the same thing is, I mean, often we have the question, when a patient on a disease-modifying therapy go from the relapsing, remitting to the secondary progressive phase, what are we then going to do? Should we continue with the drug the patient is on, or should we now consider switching to siponimod? That is the only drug has been approved for secondary progressive MS.
Well, Pierre, I mean, this is really a very important point. We have, I think, a lot of secondary progressive MS who are still treated with first-line therapies. Then the key question is what to do when it is clear that the patient has entered secondary progressive MS. So I think here there is two possibilities. Of course, if the patient has evidence of MRI activity and at the same time of some evolution of the disability, it is clear that you have to shift the patient to siponimod. But there is also the possibility, for example, to have a patient treated with fingolimod, and the patient has no MRI activity. However, the patient is evolving and having a disability progression. So in this case, my personal view is that you may also consider to shift to siponimod, with the only possibility that the better possibility of siponimod to concentrate in the CNS, and with also some minor differences compared to fingolimod on the central mechanism, may give some a bit more possibility, but of course is quite far from scientific evidence. And what I used to say to the patient is, let's see what happens in 1 year of treatment, and then we will decide. And if we don't see anything really, then probably it's better to discontinue because you may have the problem. However, when I discontinue some patients treated with fingolimod, waiting to shift to siponimod, in a couple of patients, I had a disease reactivation. So I had what has been clearly described in patients in natalizumab evolving to secondary progressive MS. So again, you must be very flexible, because there is a lot of different possibilities, and the risk, and just to end, and the risk when we discontinue a person treated with natalizumab, my personal attitude in secondary or progressive MS is to have a period of treatment with ocrelizumab or rituximab in order to eliminate the risk of a disease reactivation. And then I wait and see, and then maybe later I can discontinue. But if the patient is treated with natalizumab, now always I have at least 1 year of treatment with an NTB.
Yeah, and I think, I mean, we also sometimes discuss, do you think that, that there is an effect of anti-CD20 in secondary progressive MS, because we know that is in primary progressive MS, so one would anticipate that this would also be a case in secondary progressive MS. And I think that the Swedes have showed it rather with rituximab, that there is an effect in secondary progressive MS.
Yeah. We are open to questions from the floor, if any.
Can I ask about rituximab? You mentioned that in Sweden it's the main DMT use of rituximab in MS. So, what is the regime that you follow in when you use rituximab as a DMT in relapsing MS as well as in secondary progressive MS? How frequently do you use it?
I should say that we had a long experience using rituximab at the time in Europe and in Germany off-label for a number of also legal reasons. We once ocrelizumab was approved, changed at least de novo to Ocrevus, but we used similar induction treatment, starting with 2 infusions 14 days apart, and then 6 monthly intervals. With regard to Ocrevus, now given the circumstances of COVID-19 and some issues, and also based on evidence that maybe repopulation occurs later than at 6 months, we kind of extend the interval, but that's an individual decision. I don't know how you are dealing with this, Giancarlo and Per.
Well, I mean, we are not allowed to use rituximab when there is an approved drug, but currently we are making a nationwide study where patients who are going on anti-CD20 get the possibility to go into a randomized trial where patients are randomized either to ocrelizumab or to rituximab. And this has been actually designed as a non-inferiority trial. So I guess we would get an answer whether rituximab is as effective as ocrelizumab. And I can tell you that this study is supported by the hospital owners for some obvious reasons.
No, very interesting, Pierre, and I think it's a very important information, of course, to have this. So what we used to do here is first in secondary progressive MS, where we are not allowed formally to treat with ocrelizumab, we use rituximab. So exactly as you suggested, Pierre, sometime we try to this drug in not only when we have to move from we have to discontinue natalizumab or fingolimod, but also sometime when we see some activity, maybe some more active secondary progressive MS, then maybe we prefer to go to rituximab. Because we consider that the anti-inflammatory effect of rituximab is superior to the anti-inflammatory effect of siponimod, and this is based on the studies that have compared fingolimod and rituximab. So this is first. Second, concerning the dosing interval, we also had some delay in the retreatment in this period because of the problems. The interesting observation is that in treatment of NMOSD patients with the rituximab, when we delayed the treatment, we had, let's say, some patients who reactivate. And when we look at the response to rituximab in NMOSD, we saw that the variable that was most treated associated with the occurrence of attacks was exactly the delay in retreatment. This was explaining about 2/3 of the failure of rituximab. So in that condition, delaying was risky. We didn't see such an effect in multiple sclerosis, which is interesting, probably because of the different mechanisms of the disease. But for this reason, we extend also a bit the intervals there. And in some cases, we extend also to 1 year. So without really major impacts, at least. But of course, the numbers are not so high to allow this as a definite type of evidence.
So do you measure CD19 to guide you when to retreat, or is it just extended?
Well, we measure. Usually, yes, but sometimes even if we start to see some reactivation, we still delayed. This was just because of the problem. Sometimes, for example, we expect to see the reappearance because it's the time where we decide to vaccinate those who didn't receive the second or the third. So we use this strategy. When we see the reappearance of B cells, then we vaccinate. Again, it's not really evidence-based. It is only, let's say, immunological-based decision, but it's just a theory. It's not an evidence.
So.
On that same question, can I ask now that there is, you said there's a trend towards going on to high efficacy treatment as initiation or induction. Would you recommend starting patients at diagnosis with rituximab instead of fingolimod or interferons?
Well, as the situation currently in Denmark, in Germany, we are not allowed to use when an on-label drug is available, an off-label drug, or there won't be a reimbursement, and there are sort of forensic issues if something goes wrong on the off-label use, then litigation may follow. I personally, reading the data, would in actual fact carefully weigh between kind of slightly less effective drug like fingolimod and CD20 depleting agent. I'm more proactive, so I would, if there's no contraindication, at least discuss with the patient the possibility to start right away with an anti-CD20 monoclonal. But again, this is still not formally proven. There is data from MS based from other studies to look by propensity matching statistical techniques at the relative efficacy of fingolimod versus rituximab, and I think the weight of the evidence would point towards rituximab or ocrelizumab being more effective, and hence I personally would use it. But it depends, of course, on the regulatory environment, on reimbursement issues. So complex decision.
Yeah, Peter, you know, in Sweden, they use rituximab as the initial therapy for approximately 60% of the patients. And in Denmark, we use a highly effective treatment as the initial treatment only in 15% of the patients. And there was a comparison between the disease worsening and relapse in Danish and Swedish patients treated for the first time, and it was impressive, the difference in favor of rituximab compared to patients treated in Denmark, primarily with moderately effective treatments. So, I mean, I think personally that we used to say that we should use a moderately effective therapy because the highly effective therapies are more dangerous and has a worse safety record. But I'm not sure that this is valid anymore, because with the new drugs like the anti-CD20s and cladribine, in fact, at least seen on a period of some years, that don't seem to be very seriously adverse effects compared to, for example, the first-line drugs like DMF and teriflunomide. So I'm not sure that this statement is correct anymore. So I definitely in Denmark advocate for more use of highly efficacious drugs from the start in a larger proportion of patients compared to today.
Yes, I absolutely agree.
Yeah, no, it is interesting. We did a retrospective study in what happened in our center in the last 20 years. And the very interesting observation was that from 2000 to 2005, the percentage of patients who started the treatment with the second line was 3%. In the period 2015-2020, it was 33%. And in 2021, it jumped to 45%. But the good thing is that the proportion of NIDA increased from 20% from 2000 to 2005 to 60% in 2022. So I agree with you, Pierre. We have started to be an opposite view. So we consider not to start with the second line only when you have some important safety problems because of comorbidities or because of potential pregnancy or this aspect. Otherwise, the tendency is now to start with usually with S1P or with natalizumab, and if there is more activity directly with NTB or also in some cases alemtuzumab. So we have a bit shift the approach.
Yeah, we have not come so far. We have gone during the last 10 years from 5% to 15%, but we are still struggling with the reimbursement from payers who are not yet willing to use the second line or high efficacy drugs from start in all patients. So, but we'll get there.
Yeah.
In the event that you start rituximab as induction therapy, how long would you wait before you start the first line treatment, or would you go on with rituximab every 6 months to 1 year?
It was difficult to hear you. I don't know, my colleagues, maybe they hear better than me, but your voice is very low.
The question, in the event that you start induction therapy with rituximab, how long would you wait before starting first line therapies?
Okay.
Thanks. As Peter, that's to you.
Well, I mean, this is still an open question, the kind of de-escalation approach. In actual fact, we currently and over the past years have with rituximab, when ocrelizumab wasn't available, or with ocrelizumab continued and not try to resort then to a less efficacious drug. I would imagine that my colleagues, Prof Soelberg Sorensen and Comi, act the same, but
we do not de-escalate patients unless there are adverse effects or something like that. Then we continue with the highly efficacious drug. But of course, it also is an economical issue, because the second line drugs are in general more expensive than the first line drugs.
I mean, I think I also agree with you for the NTB. Probably the exception is alemtuzumab and cladribine, because these two drugs can be only used for a limited period of time. So the escalation in our center is mostly for these two drugs, where we, after 2 or 4 years, we consider to try to de-escalate. I was very interested to, I don't know if you've seen the recent data on the long-term use of alemtuzumab, where some patients have been treated for 6 or 7 times. We never did in such a way, but it is interesting to see that. And also these patients who went for a very long period of treatment, at the end, they didn't really have a proportional increase in the risks, which is, I think, it seems that the risk is more in the beginning than on the long term, which was a bit surprising.
So Giancarlo, when you say you can only treat with cladribine for a limited period, why is that?
Yeah, this is based on the old data that after the 4 year, you start to have some excess of tumors. That these data have been controversial when they have been re-examined in a different way. However, let's say that the way the data have been collected was not enough reassuring, because many patients have been lost to the follow-up. So still, we have still some problems. And the real problem is that there is not enough evidence that there is no the risk. By the way, with alemtuzumab and with NTB, you have a much better long-term studies. So we know then which is the risk, you can have some estimation. Clearly, for the way it has been developed, they do not have such relevant long-term data.
Thank you very much, Giancarlo. And in the interest of time, I'm afraid we have to wind up.
Dr. Vimsara, can I ask a question?
Yes, of course.
Yes, yes, yes.
Yeah, in Sri Lanka, of course, we have a limited range of drugs available. So we have basically interferon, fingolimod, and Britax, which we use frequently. Now with this new approach, should we just do away with interferon and go straight for fingolimod? Because when you consider the cost, it's more or less the same price. So we're initiating, in your opinion, should we go for fingolimod as a first line rather than as a second line? Would like to know your thoughts.
I would certainly favor that, as to say, if the costs are about the same. I was just wondering, excuse my ignorance, do you use the proprietary fingolimod or do you have already generics available?
We have the proprietary.
But anyway, I would then use fingolimod right away.
Thank you.
Thank you very much, Sina. So we are now winding up, and thank you very much. I would like to thank all three speakers, Professor Comi, Professor Hartung, and also Professor Sorensen, for a very stimulating discussion and for the symposium, and thank you everybody. And now we are breaking for tea, and we'll be back in half an hour for the second symposium. Thank you very much.
Goodbye to everybody.
Bye-bye.
But
මික්සයක් විතරයි. ෆොටෝ මික්සයක් විතරයි තියෙන්නේ. ප්‍රීසෙට් 54ක් තියෙනවා ඔකේ. ඔව් මේකේ මේ මම ඉන්දියාව LED වාගෙන් ආයෙත් ඔය තියෙන්නේ. දාලා තියෙන තිබ්බේ මේ ටයිම් එක අඩු. ඔව් ටයිම් එක අඩු. මේ ලයිට් එක ස්ලෝලි කලර් චේන්ජ් වෙන එක විතරයි ඕනේ. වෙන මොකුත් ඕනේ නැහැ. දැන් ගන්න එපා කියපු ගමන්.
Hi, Dr. Isabel. Nice meeting you here. Hi.
Nice to meet you too. Good morning.
Yeah, good morning there. It's very early there.
It's very early for me. I'm fine. Thank you. How are you?
Fine here. Has been a long time, didn't see you.
Absolutely.
I'm not the speaker, nor am I a host. I just a foreign participant. Somehow they just put my status as a co-host here. Nice to meet you.
Nice to see you too.
Yeah. Hope everything is fine. Yeah.
Good. Good. Thank you very much.
power line එකක් ඇද්ද මොනවා ඔෆ්ලයින් ගන්න නැහැ අප්ලෝඩ් අන්න අපෝ ස්ලෝප් වෙනවා
Hi, Ji-yoon. Can you hear me?
Yes, yes. Loud and clear. Nice.
Oh, good, good. How are you doing?
Yeah, fine. Good. I'm not the speaker, nor am I the host. I'm just a foreign participant. Yeah.
Oh, okay.
Somehow my status there is co-host.
Hi, Isabel. Hi, Dashi. Good to see
Good
you.
morning. Nice, you too. Thank you.
Thank you. Thank you for accepting this invitation. I was asked to, I was asked to recommend well, excellent speaker, and I recommended you. So thank you very much for joining us.
Thank you very much. Pleasure.
Joanna, can you hear me?
Hi, Hi, yes, I can hear you.
Well, thank you very much for joining. So now you are in London and self-quarantine?
I'm in Hong Kong. I'm still in compulsory quarantine.
Oh, okay. Not in London.
No, in Hong Kong.
All right.
It's a pleasure to be here. I'm looking forward to the session.
Well, thank you very much again for joining this meeting. And actually, I'm in my hometown now. Since yesterday, I returned to my hometown. Actually, last night there was a local meeting, so I attended it, and now I'm in my home.
Oh, excellent. Very good.
How's the COVID situation in Hong Kong?
There's been a kind of recently quite a few cases. So they actually shortened the quarantine from 3 weeks to 2 weeks now, partly probably because of the local cases. But
I see.
Yeah, we'll see how it's. They're quite aggressive in closing everything down. So schools are back online, etc. So.
Well, like many other countries, the Omicron variant has been spreading in Japan very rapidly in recent days.
Yes. How is the vaccination situation in Japan? Is it?
Well, the booster vaccines were done in only 20% of the people or something.
Okay. Yeah.
I got the booster shot last month, but far away from completion. So
yeah.
It's too late. Japanese government move is always slow. So the Prime Minister has been blamed very much.
Yeah, it's difficult everywhere, isn't it?
Yeah, very, very. So is this meeting behind the schedule?
I don't think so. I think they went on break at time.
Really?
I don't know when we become online or if we're already to some extent online at the moment. So I don't really know.
Okay.
Probably we'll be on time, yeah. I'm following the morning session. You'll be on time.
Oh, really?
The tea break, I guess. But soon, I guess it will start.
I wanted to join this meeting earlier, but I'm in my home and I had to do something. So just before our session started, I managed to join the session.
You must be very busy. we have Professor Hartung, Professor Comi, and Professor Sorensen did this for the morning session.
Yeah, I wanted to attend the session, but unfortunately, I was not able to do that. Yeah.
Hello, good morning. Good morning.
Welcome back. So we'll move on with the next symposium. This will be on CNS demyelination, recent advances and challenges. And the theme is NMOSD, MOGAD, and MS, recent advances and challenges. Let me introduce the first speaker for the first talk, Dr. Maria Isabel da Silva Leite, from the United Kingdom. She will be talking to us about NMOSD, the features and the mimics. Over to you, Maria.
Good morning. I hope you can hear me well.
Yes.
I start by thanking Professor Fujihara and all the organization for the invitation to be present here. It's a great pleasure to contribute this important meeting. And I say hello to my colleagues and friends. Some of them I know from Oxford and from some international meetings. It's not going. I'm trying to move the slides. I may need to stop sharing and I'll share again in a second. Sometimes it happens. Just a second. It can go now. Okay. It's a pleasure to talk about neuromyelitis optica spectral disease. The topic is quite vast and I try to concentrate on clinical and imagiological features, which are usually the first information you have when you assess the patient, where you eventually make a diagnosis of neuromyelitis optica spectrum disease. And certainly those conditions were similar to that and are relevant differentials. Here are my disclosures. So the NMO spectrum disease or disorders include a number of features, and we usually refer them as NMO when patients have have optic neuritis and transverse myelitis, or isolated transverse myelitis or atypical optic neuritis, or even other manifestations of the brain stem, and I will go through them in a moment. Great majority of patients have aquaporin 4 antibodies, and a smaller number of patients have no aquaporin 4 antibodies, and we call seronegative neuromyelitis optica, but there is an increasing number of conditions who are similar or that have been identified with this syndrome, although they have been present and diagnosed for many years, some of them. And within these, without acuprin for antibodies, we could start by saying now as a more distinct condition, the MOG antibody disease, patients with acute disseminated encephalomyelitis, others with some rare cases of multiple sclerosis, these within the central nervous system or presenting basically only with the CNS disease, and then a number of mimics, which include CNS features similar to those of NMOSD, but can associate with organ-specific or systemic features of a number of types, autoimmune and others, where we can include autoimmune and inflammatory conditions, those associated with malignancy, infections, or others where vascular pathology can be included. I couldn't talk about every single of the conditions, but I tried to organize in a way that is helpful to all of you. Starting by the clinical and radiological features of NMO with acuprin for antibodies. This is a chronic autoimmune condition of central nervous system. It's astrocytopathy, is often associated with other autoimmune conditions or autoantibodies such as thyroid disease, lupus, Sjogren's, myasthenia, presents with severe attacks causing mainly optic neuritis and transverse myelitis, but also brainstem and brain syndromes. This causes significant inflammation and tissue damage in areas affected. Can cause irreversible deficits if not treated promptly. Is a recurrent condition with a high risk of attacks and requires long-term immunosuppression to prevent attacks and disability. And interestingly, quite different from other of these similar conditions, it has no clinical progression and particularly distinct from MS in that aspect. So the optic neuritis is one of the main features well known for many years. It's a severe, usually causes severe painful visual deficit, sometimes altitudinal, which can cause difficulties in diagnosing as a long segment of optic nerve or chiasmatic involvement, and usually posterior. It means that usually the optic disc in the acute phase looks normal. See here, quite a long lesion or affecting the chiasm. Can also present as an acute transverse myelitis, which affects or leads to significant limb and limb motor and sensory deficits and sphincter dysfunction. Usually, we say presents as LETM, a longitudinally extensive transverse myelitis with 3 or more vertebral segments long. More often, cervical and thoracic lesions that it may extend to the medulla, as you see here. It is mainly central, can have T1 hypointensity even in the acute phase. And in some patients, the lesion can be short early on and later to a few days later, a long lesion. Area postrema syndrome can also is very typical of this condition. Presents as intractable hiccups and nausea and vomiting. Maybe presenting an attack of NMOSD with acuprin for antibodies and may resolve spontaneously. There is inflammation in an inflammatory lesion in the area postrema and dorsal part of medulla. These more in the acute phase. Sometimes patients improve spontaneously and the lesion disappears. And so sometimes we diagnose this syndrome in retrospect when the patient presents with the following attack not being diagnosed with this one with NMOSD. Other acute brainstem syndromes can happen, and they correspond to lesions in the pons, dorsal midbrain or fourth ventricle floor, with clinical features that include, again, the area postrema, or deficits related to long tracts or cranial nerves, and rarely cerebellar syndrome. The acute diencephalic syndrome or area affected can lead to hypersomnolence or narcolepsia-like syndrome, lack of motivation, anorexia or hyperphagia, and hypothermia, because the lesions in the thalamus, hypothalamus, and around the third ventricle. Acute cerebral syndromes are also seen in patients with aquaporin 4 antibody neuromyelitis optica syndrome or disorder, and they can present in a wide variety of types, with white matter and subcortical lesions, with long corticospinal tract abnormalities, which are much rarer, or in the periependymal or periventricular areas of corpus callosum. You can see some of the lesions. They don't seem so much with edema and therefore swollen, but they are areas where the astrocytes are and express aquaporin 4. So I'll emphasize again the characteristics of the aquaporin 4 antibody neuromyelitis optica spectrum disease, where the MRI lesions are usually symptomatic. There is no silent lesions in remission, opposition to MS. The attacks are more often associated with one anatomical location. They are recurrent unless promptly diagnosed and treated successfully to prevent subsequent attacks. And if we succeed in doing that, disease may be only monophasic, because it has only the presenting attack. It is rare that patients remain so well for many years, although it's possible. Children more like to have brain and optic neuritis attacks, and therefore they have frequent visual deficits. Non-white populations have a high risk of brain attacks, even adults, and the older adults are more likely to be left with spinal cord related deficits and neuropathic pain, which is a very significant and well-known complication. And what happens to those who are negative for aquaporin 4 antibodies? As you remember, on the left side of my first diagrams, I had only central nervous system syndromes associated with neuromyelitis optica spectrum disorder, but without aquaporin 4 antibodies. These correspond to CNS autoimmunoinflammatory conditions, rarely associated with other autoimmune conditions such as lupus or so, much less, may be preceded by infection or vaccines. They have a variable severity. They may involve several anatomical locations in the same attack, could be more disseminated, wider range of level of recovery from attacks, from very good to poor, and recurrent or monophasic, again with a variable risk of attacks, and where we consider immunosuppression only to prevent attacks if the condition is recurrent. One of these conditions, which we can still say it's under the NMO spectrum disease, but more likely and more we identify this as a distinct condition, is acute MOG antibody disease, which overlaps with acuprin 4 disease in its presentation and sometimes in its recurrence. They are more, in terms of optic neuritis, more likely to be bilateral and have papillitis. The LETM often affects the conus. In the brain, they can have fluffy, more or less lesions in the white matter, but also sometimes in the cortex. In the brainstem, it affects predominantly the cerebellar peduncles and can also, as I said, affect the cortical areas, almost sometimes isolated. Majority of these patients have a remarkable improvement following treatment, but sphincter dysfunction and erectile dysfunction can be left and not recovered for months or years and sometimes forever. Other conditions as well, similar in some ways to an NMOSD or MOG antibody disease, is ADEM, very well recognized everyone as an acute widespread CNS inflammatory demyelinating condition where the features relate to the anatomical areas affected. So all the lesions usually are symptomatic or they present around the same time and can affect the brain, brainstem, cerebellum, spinal cord, and optic nerves. Usually a great combination of them. And to touch on the most, I would say, most commonly talked about theme currently is ADEM or demyelinating syndromes associated or post-COVID-19 vaccine, and they present in a variety of cases. Majority of the patients have present this after the AstraZeneca vaccine. It occurs up to 4 weeks after COVID vaccine, sometimes a bit longer. It's usually monophasic. The majority of patients are seronegative for the acuprin 4 or MOG, but some of them have MOG antibodies, and very rarely in our experience have acuprin 4 antibodies. And the MRI scan shows is similar to ADEM, but can be isolated transverse myelitis with long lesion, have optic nerve involvement, and ADEM is not very different from other type of ADEM. And they can have GAD enhancement more or less obvious. Their severity is variable and variable outcome, but in our experience, most of them recover very well. The other mimic is MS. It's not a surprise, although it's relatively easy to distinguish them, and it varies in number, shape, and location of the myelinating lesions. Is an illness where you more often see silent lesions in the MRI scans, even at the presentation of the clinical feature. The optic neuritis, there is evidence of dissemination in space and time. The optic neuritis can be relatively mild compared to NMO spectrum disorder, more likely to be unilateral clinically, but clinically and evoked potentials can show bilateral involvement. And the lesions in spinal cord more likely to be short, although LETM can be seen as one of the attacks. So it's easy, relatively easy in some aspects, identify MS by the brain lesions, as you can see here. And you will know that even better than I do. There are other conditions where you have CNS involvement similar to acuprin 4 disease or neuromyelitis optica, but in addition, the patients have other organ-specific or systemic manifestations, not always autoimmune, but or inflammatory or others. And I'll give you a couple of examples of those. Usually these are chronic recurrent CNS autoimmune inflammatory conditions. Features are part of a broader autoimmune condition and not associated with them as in the NMO. The attacks may involve one or more CNS anatomical locations, the variable severity and recovery, and may need immunosuppression to treat the underlying condition and at the same time CNS complication. One of these conditions is well-known lupus and Sjogren's and similar conditions. They can have a diverse immunopathogenic mechanism, even in the acuprin 4. The CNS inflammation in these conditions is rare. A proportion of these cases have acuprin 4 antibodies, but not all of them, and usually their outcome is similar to those of acuprin 4 disease. However, others have no antibodies to acuprin 4 and MOG disease and MOG antibodies, and the outcome is more variable and may be poor depending on when the patient was diagnosed and treated. Acute attacks require prompt diagnosis and intensive treatment with a number of immunosuppressive medications. So this is an example of a young lady, 37, that presented with 3-month history of progressive severe rheumatological and systemic symptoms, and the subacutely stepwise developed brainstem syndrome. And soon after, acutely had a myelopathic syndrome with reduced sensation in the limbs and trunk, with a level of T3, paraplegic, sphincter dysfunction. And so this lady presented with quite a few months of very severe systemic first and then neurological syndrome. She had no autoantibodies for acuprin 4 or MOG, and she had abnormal or pleocytosis, slightly increased protein in CSF, and then MRI scan showing T2 lesions, hyperintensive lesions in the brainstem and also in the core, in several areas, cervical and thoracic down to the conus. Here I'm not presenting about the treatments, of course, but she received treatment and didn't recover of the lower cord syndrome. Here, a case of neurosarcoidosis presenting as LETM in a gentleman 57 without past medical history of relevance, and an acute subacute syndrome affecting his cervical cord with limb reduced sensation and weakness and sphincter dysfunction. Presented, so the antibody had no autoantibodies, as I said, had increased, slight increase in proteins in CSF. The MRI scan showed a very long lesion, swollen, quite swollen cord, and had GAD enhancement. These characteristics here, mainly posteriorly in the cord, and with this on the axial gives an anchor. So the patient improved with the steroids, but when a chest CT was done, had lung nodules and the biopsy showed sarcoidosis. Similarly, in some rare cases of paraneoplastic syndrome, you can see similar features which can be associated with small cell lung cancer, thymomas, or others. And neurological presentations of these syndromes can be, again, myelitis, encephalomyelitis, optic neuritis, or others. I'll give you an example of a patient, 59, with an acute spinal cord syndrome, cervical, but 2 years earlier had became blind from one eye. It was thought to be vascular, but in fact was an optic neuritis. And this gentleman had also chronic mucocutaneous candidiasis. So this systemic presentation highlighted the fact that he could have a thymoma, and indeed he had CRMP5 autoantibodies, had interleukin antibodies as well, had a long lesion in the cervical cord, just over 3 segments, and he had a thymoma which was removed. He didn't have more attacks, but he was left on immunosuppression. A patient who had a lymphoma, and after treatment and without being active lymphoma, so it was inactive, developed a subacute syndrome with which was diagnosed as polyradiculopathy in the lower limbs with the clinical and electrophysiology tests. The MRI scan by then was normal, and she improved with IVIG and steroids, which were then tapered down. And when she was at lower dose of steroids, she developed an acute severe leg weakness and sphincter dysfunction with a myelopathic syndrome, which corresponded to a long lesion. She was seronegative for acoprine 4 and MOG, increased protein, no evidence of lymphoma cells, had a long lesion, the cord one longer, and then conus, and also the nerve roots were also enhancing, and the enhancement was mainly surface on the pia. So my final thoughts here and message that CNS autoimmune inflammatory pathologies include a wide range of pictures where NMOSD is recognized, particularly by the association with acoprine 4 antibodies and conditions that present similarly, and they are the mimics or differentials, but are seronegative. CNS may present as an isolated neurological event or as part of a diffuse neurological and or systemic condition, autoimmune, inflammatory, malignant, other features such as demographic, neurological, other organs or systemic features may help to identify the cause of the NMOSD mimic. Certainly tailored diagnostic process is essential to diagnose for the diagnosis and management. And indeed, it's very hard to, in my view, diagnose the mimics of NMOSD when we don't find the clear diagnosis and leave the patients with a diagnosis of seronegative NMOSD. And so we should always keep looking for a more definite diagnosis to more clearly and accurately manage the patients. And thank you very much for your attention.
Thank you, Dr. Maria, for that excellent account on NMOSD spectrum and its mimics. We'll have the questions at the end of the session, and we'll move on to the next speaker. I would invite Dr. Prof Sudarshani to introduce the next speaker.
It's my pleasure to introduce the next speaker, who's my good friend, Prof Kazuo Fujihara, who's no stranger to Sri Lanka. He's been here many number of times, also at our inaugural session 3 years ago. He's a pioneer in this field of neurology, and he was an author in the seminal paper in 2004, which led to the discovery of acoprine 4 from Mayo Clinic. And also, he's the only Asian representative in the panel, in the McDonald criteria panel for MS diagnosis. So, so it's my pleasure once again, Kazuo, to introduce you to this audience, and over to you. You'll be talking on therapeutic advances in NMOSD. Kazuo.
Well, thank you very much, Bim, for the kind introduction. Can you hear me?
Yes, yes.
Oh, okay. Thank you. I really wanted to visit Colombo this time again, but because of travel restrictions in place here in Japan, I cannot visit Colombo. I think I mentioned it before, but my wife was happy that I did not have to go abroad with the risk of contracting COVID-19. But on the other hand, she was very disappointed that I could not visit Colombo to buy excellent Ceylon tea. She loves Ceylon tea very much. So maybe next year I would like to visit your country to buy Ceylon teas for my wife. Otherwise, she will kill me. So let me share my slides. So today, I would like to talk about therapeutic advances in NMOSD. But in my talk, I would like to mostly focus on aquaporin 4 IgG positive disease. These are my disclosures. And as you all know, treatment of NMOSD is divided into 3 parts. Acute exacerbation, relapse prevention, and symptomatic therapy. For acute exacerbation, first-line treatment is IV methylprednisolone, and in some patients, you may start plasma exchange, but I will mention it in a minute. For relapse prevention, before randomized controlled trials results were published, corticosteroid and various immunosuppressive agents were used, and they appeared to be effective in preventing relapse to some extent. We should also note that some disease-modifying drugs for MS, like interferon beta, natalizumab, fingolimod, alemtuzumab, and DMF, can aggravate NMOSD in some patients. So the early distinction between MS and NMO is critically important to choose the right treatment. 2 years ago, as you all know, first ever randomized controlled trials of 3 monoclonal antibodies, namely eculizumab, anti-complement C5 monoclonal, inebilizumab, anti-B-cell, anti-CD19 monoclonal, and satralizumab, anti-IL-6 receptor monoclonal, were published, 2 in New England Journal and 1 in Lancet. I will mention them later in my talk. Due to time constraints, I cannot talk about the symptomatic therapy, but as you all know, some patients with NMOSD, especially those with myelitis, may suffer pain and paresthesia very much. At this point, there's no good treatment to treat pain and paresthesia associated with NMOSD myelitis. But painful tonic spasm is usually successfully treated with relatively low doses of carbamazepine, well, 200 milligram in 2 divided doses or something. Neurogenic bladder and constipation are also a big issue in these patients, and they should be treated as well.
Kazuo, we cannot hear you now.
Can you hear me now?
Yeah, no.
Ah, okay. Well, for some reason, sometimes this happens. Yeah, yes. Can you hear me?
Yeah, we can.
Okay. So again, after 5 days of onset of the symptoms, as you see here, response rate to plasma exchange declined very much. And the important message from the investigators was that perceiving plasma exchange as a rescue therapy only after the steroid failure could be deleterious. So that means you have to start plasma exchange as soon as possible. This idea is supported by a recent systematic review and meta-analysis, and it shows that plasma exchange is effective as a first-line treatment as well as rescue treatment. So again, you have to start plasma exchange as soon as possible to expect the best recovery from the symptoms. These are the proposed mechanisms of action of plasma exchange. Of course, plasma exchange removes some pathogenic substances like autoantibodies and cytokines, but it also influences cellular immunity. For example, it increases regulatory and suppressor T cells. And in some countries like Japan and Germany, immunoadsorption plasma exchange has been used quite frequently. And here's data on the changes of peripheral blood lymphocyte subsets in NMOSD attacks following immunoadsorption. And this slide was provided by Professor Nomura. And as you see here, following immunoadsorption, activated CD4 cells and helper inducer cells declined, while NK cells with regulatory functions increased significantly. So again, plasma exchange changed both humoral and cellular immunities. Let me talk about attack-related disability and relapse cluster in the disease. And the disability of NMOSD is essentially attack-related, and unlike multiple sclerosis, progression independent of relapse activity is rare in NMOSD. And also, once NMOSD patients have a relapse, in the following 12 months or so, they are more likely to experience another attack. So the relapses may be clustered, as you see here. So during this period, you should not taper the treatment carelessly. Prednisolone may still be used widely in many countries to prevent attacks in NMOSD. And here's a data provided by my colleague, Dr. Takai. And as you see here, even a prednisolone monotherapy may be able to prevent relapse to some extent compared to no medication. But as I said, once relapse occurred during the following 12 months, the patient may be at higher risk of experiencing another attack. So, in his analysis, he found that rapid tapering of prednisolone was associated with more frequent relapses in comparison with gradual tapering. So again, in the first 12 months of attacks, you have to taper the drugs very carefully. You may use azathioprine, mycophenolate, or rituximab to treat patients with NMOSD. But here's a comparison of 3 drugs. And this report was by Dr. Michael Levy of Harvard Medical School. And as you see here, change from, so annualized relapse rate change after treatment was the greatest in rituximab and mycophenolate in comparison with azathioprine, but treatment failure rate was the lowest in rituximab in comparison with azathioprine and mycophenolate. Dr. Ho-Jin Kim's group in South Korea analyzed the rituximab treatment very much. And if possible, you had better monitor CD27 memory B cells. And he recommends that in the first 2 years of the treatment, CD27 memory B cells should be kept below 0.05% of peripheral blood mononuclear cells, and thereafter less than 0.1%. With this treatment, they observed a significant reduction of annualized relapse rate from 2.4 to 0.3 on average, and 60% of the patients were relapse-free. In Japan, tacrolimus, a calcineurin inhibitor, has been used relatively common for the relapse prevention. And here's the data reported by Dr. Nomura's group. And they administered tacrolimus combined with prednisolone to aquaporin 4 IgG positive and negative NMOSD patients. And they observed that following the treatment, annualized relapse rate declined significantly, and they were able to reduce the prednisolone doses, and EDSS score became lowered as well. Interestingly, in their cohort, the therapeutic efficacy of tacrolimus was also seen in seronegative cases. Now let me talk about new 3 monoclonal antibodies. As you all know, eculizumab, anti-C5 monoclonal, satralizumab, anti-interleukin-6 receptor monoclonal, inebilizumab, anti-CD19 monoclonal, have been approved in some countries. These are the trial designs of the 3 monoclonal antibodies, and all of them were published 2 years ago. And in all of them, the patients with recent relapses were enrolled. Here's a summary and a risk reduction of relapse by 3 monoclonal antibodies. By eculizumab, 94% risk reduction. And as for satralizumab, 79%, inebilizumab, 77% risk reduction. But all these remarkable efficacy were seen in aquaporin 4 IgG positive cases. And please note that dosing schedules were very different from one drug to another. For maintenance treatment, for eculizumab, every infusion should be done every 2 weeks. For satralizumab, subcutaneous injection is done every 4 weeks. And as for inebilizumab, maintenance treatment is given every 6 months. So the dosing schedules are very different. But let me go back to serostatus of aquaporin 4 IgG. And in satralizumab trials and in inebilizumab trial, some patients were aquaporin 4 IgG negative, but in those seronegative cases, no obvious therapeutic efficacy was seen. So the treatment of seronegative NMOSD is definitely the challenge. As for safety, this slide shows relatively common side effects seen in the clinical trials, and some infections like upper respiratory tract infections, nasopharyngitis, urinary tract infections have been seen relatively common. In eculizumab trial, there's a concern about the increased risk of meningococcal infection because complement is important to prevent meningococcal infection. But fortunately, no cases of meningococcal infection has been reported so far. Let me show you one of my patients who was treated with eculizumab. As you see here, despite the azathioprine and corticosteroid, she had 8 events in a 5-year period. But after she participated in the eculizumab trial, there was no relapse at all. And also, she was able to reduce the dose of azathioprine and prednisolone. And actually, the azathioprine was tapered off. I firmly believe that even during double-blind period, she was treated with eculizumab rather than placebo. Very significant results. And there are some new data reported in recent publications. And as for eculizumab, in open label extension period with median treatment duration of 2.7 years, 94% of the cases were relapse-free and at 3.7 years, and still no meningococcal infection cases were reported. And importantly, 1/3 of them were able to stop or decrease doses of background immunosuppressive treatment. This may be important to reduce the risk of side effects associated with concomitant immunosuppressive treatment. And recently, monotherapy result was reported, and still 96% of them were relapse-free for 2.8 years. And as for inebilizumab, there was a reduced risk of 3-month confirmed disability progression, and mean EDSS scores improved with longer treatment, which is quite important. And very interestingly, in retrospect, serum GFAP level was measured. GFAP is an astrocytic protein. So detection of GFAP in the serum means astrocytes were destroyed. And if the patient's serum GFAP level was higher than 170 picogram per ml at baseline, those patients were at 3 times higher risk of relapse compared to the patients with the lower level of serum GFAP. So serum GFAP may predict the future relapse to some extent. And as for satralizumab, in open label extension, 16 patients were able to reduce the steroid doses, and some of them were able to stop the steroid. And quite soon, a new study, Sakura Bonsai study, will start, and it will evaluate treatment naive patients. So satralizumab will be used as a first-line treatment, and those with rituximab failure. So this trial will start quite soon. As for the biomarkers of pharmacological action of monoclonal antibodies in NMOSD, for eculizumab, this is very important data for us Japanese, because 3.5% of Japanese population harbor C5 missense variation. And this C5 missense variation is close to the binding site of eculizumab to C5 molecule. So with this variation, eculizumab cannot bind C5. So you cannot expect the therapeutic efficacy. I think CH50 may be commercially available in Sri Lanka as well. But if you want to check the therapeutic efficacy of eculizumab, you may want to measure the serum CH50, because CH50 reflects classic pathway of complement activation and reflect the activities of C1 to C9. Usually after dosing in the following day, you should see a significant decline of CH50 in patients treated with eculizumab. For satralizumab, after the administration of the monoclonal antibody, you should see the significantly higher level of serum IL-6 receptor level, as you see here. And for inebilizumab, since this is a CD19 monoclonal antibody, B cells were measured with CD20 monoclonal. And as you see here, after 2 weeks or something, CD20 positive B cells declined significantly. And then it was inhibited stably during the course of the treatment. But recently, in the subsequent analysis, it was found that patients treated with inebilizumab, CD19 monoclonal antibodies, were divided into 3 groups: stable depleters, partial depleters, and early repleters. And the threshold is 5 B cells per microliter. And the stable depleter means the cell counts were less than 5 throughout the treatment. And partial depleters, although cell counts were decreased, but still above 5 cells per microliter. Early repleter means at one point cell counts were below 5, but then increased. And importantly, the greatest risk reduction of relapse by inebilizumab was seen in stable depleters in comparison with early repleters or partial depleters. And also, GFAP was again studied in those patients. And in placebo cases, as you see here, during attack, GFAP, serum GFAP levels increased in comparison with baseline level, which means astrocytes destruction. But as you see here, in patients treated with inebilizumab, increase of serum GFAP levels were not significant. So if your patient is treated with inebilizumab, even if they experience a relapse, astrocyte damage may be milder than the attacks in patients receiving placebo. So how we should position these monoclonal antibodies in the overall treatment strategy of NMOSD, when and how? Of course, it can be used as a first line, but it's a very expensive drug. So you may want to use it as a second line or third line when previous immunosuppressive treatment is not sufficiently effective or due to relatively severe side effects. And thirdly, as I said, once a patient experiences a relapse during the following 12 months, they are more likely to experience relapse. So in that period, you may want to use these high efficacy drugs as an induction therapy, and then you may de-escalate the treatment with more affordable drugs. And some drugs may be relatively safe in pregnant patients. So these monoclonal antibodies may be used as monotherapy or combination therapy. But as in Japanese patients, we have to check the C5 missense mutation prior to the first dosing. I have presented this slide many times, but I would like to remind you that without treatment, the the pregnant patients with aquaporin 5 IgG after delivery may experience severe relapse at a very high frequency. And also, Dr. Maria Isabel Leite previously reported a higher rate of miscarriage because placental cells express aquaporin 4, and in vitro study, by applying aquaporin 5 IgG and complements, you can induce placental inflammation, and in animal study, you can induce fetal death. So to prevent the relapse in mothers and to save life of babies, now we recommend to continue a certain form of immunosuppressive treatment during pregnancy in these patients. You may experience some patients who have been relapse-free for many years, but I think that discontinuing immunosuppressive therapy is risky in NMOSD. A previous French study showed that disabling attack may occur after a long follow-up period without immunosuppression. So they concluded that the benign form of NMO cannot be defined. And recent study done by Professor Ho-Jin Kim's group in South Korea, even after 5 years of remission, if you discontinue immunosuppressive treatments, in about 6 months, over 80% of the patients had relapse. So again, discontinuing immunosuppressive therapy is a bit risky, and should, if you want to do that, it should be done very carefully. As you all know, NMOSD patients may have some other coexisting autoimmune disorders like Sjogren, lupus, myasthenia gravis, and so on. And as for myasthenia gravis, Dr. Maria Isabel Leite previously reported that in the majority of patients, for some reason, myasthenia gravis develop first. And after thymectomy, myasthenia became stable. But then, for some reason, NMOSD develops. We don't know why. And also, some patients may have neoplastic disorders as well, as you see here. So you may have to deal with these disorders as well. In considering the management of the NMOSD patients, of course, some medical factors are important, like drug efficacy, adverse events, comorbidities like coexisting autoantibodies, as I mentioned. But you also have to take into consideration a patient's lifestyle, because the patients, your patients may be hardworking, they may be busy parent, student. How about the pregnancy plan? How's the distance from center and compliance? If they are working hard, they may not come to your clinic quite often. So the dosing schedule may be important for those patients. To summarize my talk, so high efficacy and safety of monoclonal antibodies evaluated in first ever RCT have been reported, and they will definitely change the therapeutic landscape. But as I mentioned, both medical factors and patients' lifestyle should be considered. And there are challenges. There are some responders to monoclonal antibody treatment, and well, seronegative NMOSD treatment has not been established yet. So those challenges should be identified and addressed in the near future. Thank you very much for your attention.
Thank you very much, Kazuo, for that comprehensive talk on current management of NMOSD. We will take up the questions after the third talk, because all three talks are on NMOSD and related disorders. So we'll take up questions at the end of the third talk.
Okay.
So we'll move on to the next talk. It will be on MOGAD, or MOG-associated diseases, clinical characterization and therapeutic challenges. I would invite Dr. Sudarshani Ramanathan. She'll be joining us from Australia. Over to you, Dr. Ramanathan.
Thank you very much. Are you able to see my screen now?
Yes, we can see it.
Perfect. So I'd very much like to thank Professor Senanaik and Professor Fujihara for inviting me to give this talk. I'll spend this presentation talking about clinical characterization and therapeutic challenges in MOG antibody-associated disease, or MOGAD. I'll talk briefly about the evolution of MOG antibodies and how they became known to be clinically relevant. I'll touch on the common clinical phenotypes in MOGAD, both in the pediatric population and the adult population, and then touch on emerging clinical phenotypes that are now being recognized as important. I'll focus a bit on the radiological characterization of MOGAD and how we can differentiate from multiple sclerosis and aquaporin 4 positive NMOSD, and then discuss the intricacies of detection assays and appropriate diagnostic testing for MOG. And then lastly, I'll talk about some of the therapeutic challenges in this condition. So MOG, or myelin oligodendrocyte glycoprotein, is a component of central nervous system, but not peripheral nervous system myelin. It's present on the outer lamella of the myelin sheath in the CNS and on the external surface of oligodendrocytes. So this location, extracellular location, makes it a very biologically plausible target for the action of any circulating autoantibodies, and it's epitopes in this immunoglobulin-like extracellular domain that the antibodies bind to. And the relevance of MOG antibodies has been known for many decades now, since Christopher Lennington's work in the 1980s, which brought MOG to the forefront as a candidate autoantigen in demyelination, primarily because of how unique it was in triggering both a T and a B cell response in animal models of demyelination. And it was identified quite early on that it was really important that detection assays pick up antibodies that target conformational MOG, so MOG in its natively folded conformational state, because assays where the MOG was linearized using ELISAs or denatured using Western blots resulted in very low specificity and very low sensitivity. And so MOG antibodies had very muddied clinical relevance when the wrong assays were used. So it was really the advent of the live cell-based assay, which allowed us to see in which clinical situations detection of MOG antibodies are very relevant. So with a live cell-based assay, MOG or any antigen of interest, the NMDA receptor or GABA or LGI1, or in this case, MOG, is transfected or transduced into HEX cells, human embryonic kidney cells, in vitro culture. And then they're expressed on the extracellular surface. So these HEX cells have MOG, which are overexpressed on the surface, and then incubated with patient serum and a secondary antibody that is bound to a fluorescent agent. And that can allow us to define the degree of antibody binding, either quantitatively using flow cytometry or qualitatively using microscopy. So with the advent of live cell-based assays, since about 2007 onwards, it became obvious that MOG antibodies were very important in human demyelination, particularly in children with ADEM. So this was known from as early as 2007 and onwards, that children with ADEM had MOG antibodies for a significant part. And you can see that some of these children with ADEM had bilateral optic neuritis, which we now know is a very important clinical phenotype in MOGAD. And that when children had MOG antibodies, there was a very strong association with these patients, children not going on to develop multiple sclerosis. They had a different disease. So we can see that MOG antibodies are present in over a third of children who first present with demyelination. You can see the characteristic poorly defined large lesions in both the gray matter and the white matter. And these children can present with ADEM initially and may go on to have recurrent episodes of ADEM or multiphasic disseminated encephalomyelitis or MDEM. Some children have ADEM and as they grow up, go on to present with optic neuritis and transverse myelitis. So kids with MOGAD generally had more ADEM than children with MS, more bilateral optic neuritis, and the presence of typical MS brain radiology was a red flag for MOGAD. These children were often relapsing, and many of them had an infectious prodrome. So this is an example of an 8-year-old girl who presented over a number of years, first with transverse myelitis, then a cerebellar presentation, and then optic neuritis. And it was around this time, this would have been in about 2008 or so, 2009, where she was tested and identified as being positive for MOG antibodies in the serum, and then subsequently was treated with mycophenolate and steroids and had no further relapses after that. So this is a patient of Russell Bales, who's a pediatric neurologist I work with. In adults with MOG antibodies, however, most of what we knew about MOG antibodies until about 2012 was that it was common in children. And it was a really important finding that most adults, almost all adults with multiple sclerosis, did not have MOG antibodies. And if they did, it was very unusual. And it was really a very important case series by the Oxford group in 2013 that demonstrated some adults who did have MOG antibodies. And these were patients who had an NMOSD phenotype, but who were aquaporin 4 antibody negative. And that sparked a lot of interest internationally, with multiple international groups evaluating this. So in our Australian and New Zealand cohort, we looked at 23 adults with aquaporin 4 antibody negative NMOSD and identified 9 of them had MOG antibodies in the serum as determined by live cell-based assay analyzed with flow cytometry. And all 9 of these patients had simultaneous bilateral optic neuritis, which had optic disc swelling, very prominent disc swelling, visible clinically and radiologically. And 1 patient had concurrent longitudinally extensive transverse myelitis as well. And there was a flurry of international literature, all published very close together, that demonstrated this phenomenon was being observed in most centers that were researching this. We demonstrated that ADEM was the most common presentation in children, not surprisingly. And when you looked at adults and children, bilateral optic neuritis was the most common initial presentation, and unilateral optic neuritis was the most common relapsing episode. And then there was a smaller proportion with longitudinally extensive and short transverse myelitis, brainstem and cerebellar involvement, and seizures. And I'll come to talk about that soon. And this is something that's been reproduced in multiple cohorts. And it looks like maybe a proportion of aquaporin 4 antibody negative NMOSD patients do have MOGAD. However, and this is very important, only about 1/3 of MOGAD patients actually fulfill 2015 NMOSD criteria. And there are a number of clinical presentations that I'll discuss that will not fulfill NMOSD criteria. So it's very important that we look at MOGAD as a distinct phenotype, not just aquaporin 4 antibody negative NMOSD, but with the more distinct clinical and radiological presentations that I'll touch on. What we now know is that what was likely referred to as CRION, or chronic relapsing inflammatory optic neuropathy, there's probably a significant proportion of those patients who have MOG antibodies. And Axel Petzold and Gordon Plant's group demonstrated that in a historical cohort of patients. And when you look at the diagnostic criteria for CRION of relapsing optic neuritis with a loss of visual function, seronegative for aquaporin 4 antibodies, optic nerve enhancement, responding to steroids, and relapsing on steroid withdrawal, this paints a very classic picture of MOGAD. So just how common is it? There are a number of international studies that have looked at incidence and prevalence, and essentially what we mostly agree on is that it is much more common than aquaporin 4 antibody positive NMOSD, at least twice as common, and probably more, probably in the order of 3 to 4 times as common. There is not a female predominance. It's almost a 1-to-1 male to female ratio. A lot of the published data is in Caucasian cohorts, but it's obviously present in many Asian and East Asian and South Asian cohorts. So there isn't a clear racial feature in the way of the Afro-Caribbean increase in the incidence of aquaporin 4. And about half of the patients will have an infectious prodrome prior. Initially, it was described as being a monophasic illness, but we now know very much so that it can be a relapsing illness in up to half the patients. And particularly when follow-up is extended, that relapsing phenotype becomes known. So I want to talk now about some of the less common non-optic neuritis and transverse myelitis and ADEM phenotypes. This is a patient that we saw at our center, a 32-year-old woman, and she had her first episode of a seizure. She had a few days prior of meningism, a background history as referred to on the slide. And when she presented to the emergency department, she was post-ictal, but there was no focal neurological deficits. An initial presentation showed slight neutrophilia in her bloods. She had non-specific left temporal slowing on an EEG, and she had both polymorphonuclear and mononuclear cells in her CSF. There was no intrathecally restricted oligoclonal bands, and it looked like a bit of a traumatic tap. You can see here that she's got some swelling in the left temporal pole, and she was initially treated as a presumed infectious where an agent wasn't identified in the spinal fluid. She was empirically treated with antivirals and antibiotics, and she gradually improved and she was discharged. 2 weeks after discharge, she complained of fairly subacute, complete loss of vision in the right eye, no light perception, very clear disc swelling, and a right afferent pupillary defect. And you can see here really obvious high signal and swelling in that right optic nerve, longitudinally extensive swelling. She was treated with steroids and plasma exchange. The prednisone was tapered, and then she had seizures within a few weeks of stopping the prednisone. She was started on levetiracetam. Then she had another episode of optic neuritis, and it was at this point that she was tested for MOG antibodies, which were identified as being positive. She was treated with plasma exchange and mycophenolate, and you can see that her radiological resolution and clinical resolution of her symptoms. So she was an interesting case that highlights this phenotype that's now very well recognized in patients without ADEM of cortical flare hyperintensities or cortical lesions with new onset seizures, and these seizures responding more to immunotherapy than anticonvulsant therapy with good clinical and radiological resolution. It's present in varying proportions depending on the cohort that's reported, but this is very rare in aquaporin for antibody-positive NMOSD, and it's a well-established presentation in MOGAD. And this is one of the first papers that describe this, and you can see these cortical changes that resolve. And this is a child that we described that had a first presentation with seizures and then went on to develop ADEM at recurrent presentation. You can see resolution of this cortical lesion on follow-up scanning and clinical resolution with immunotherapy. The next phenotype I'd like to talk about is the MOGAD and autoimmune encephalitis phenotype. And here's a patient that we looked after, a 58-year-old woman who presented with fatiobrachial dystonic seizures, which are really pathognomonic for LGI1 antibody-positive autoimmune encephalitis. And she had a lymphocytic pleocytosis in her spinal fluid. She had intrathecally restricted oligoclonal bands, LGI1 antibody-positive in serum and CSF, treated with steroids and maintenance IVIG. And she had no further autoimmune encephalitis episodes. And after 2 years of remission, her treating clinician stopped the IVIG, and she presented about 2 months later with a very longitudinally extensive optic nerve lesion and left visual loss. And here you can see when we went back and tested her serum from the episode of autoimmune encephalitis, it was really interesting that her MOG antibodies had been positive throughout. And she had 2 episodes of optic neuritis, at which point she was diagnosed with MOGAD, and she was treated subsequently with rituximab, and she has been clinically well since. So that case illustrates a very important overlapping syndrome of antibody-associated demyelination and autoimmune encephalitis that has been demonstrated, particularly with NMDA receptor antibody-associated encephalitis, which is much more common. And about 7% of these NMDAR patients have concomitant antibodies to neuroglial antigens, and most of these patients actually have MOG antibodies. So we now know that the MOGAD patients can also have an encephalitic picture. Some patients have leptomeningeal enhancement or a meningoencephalitic picture. Some children have this presentation with raised intracranial pressure and bilateral disc swelling that often go down the path of idiopathic intracranial hypertension, but now are known to be the first presentation of MOGAD. So it's really important to have a high index of clinical suspicion with this. And now seizures associated with MOGAD are considered under the heading of acute symptomatic seizures, much like the seizures associated with autoimmune encephalitis. The other less common but emerging clinical phenotypes outside of the transverse myelitis is a phenomenon that we've described and other people have recognized of myeloradiculitis. And what we've noticed was that a number of transverse myelitis patients had very obvious involvement of the dorsal nerve root ganglia with swelling and enhancement and thickening. And this is something you don't really see with transverse myelitis and MS or aquaporin 4 NMOSD. We also reported a number of patients who presented with concurrent CNS MOGAD and acute inflammatory demyelinating polyneuropathy or a Guillain-Barré syndrome-like presentation. And some of these patients we then found had inflammatory peripheral neuropathies concurrent or separated by time from their CNS MOGAD episodes. And a couple of these patients had neurofacin 155 antibodies for their peripheral neuropathy or CASPA2. So that's an interesting phenomenon. Now, radiologically, it is very important to be able to tell some of the obvious features and also some of the more overlapping features. And when you look at the brain, about a third of MOGAD patients may have brain abnormalities, whereas many of them who have optic neuritis and transverse myelitis might have completely clear MRI brain. And when you look at the MOGAD brain changes, they're often quite atypical. They might be large, fluffy lesions with ill-defined borders. You can see involvement of the gray matter. You can see involvement, leptomeningeal involvement over here. And what you really don't see are the periventricular white matter lesions or Dawson's fingers or corpus callosal lesions that are considered very characteristic of MS. So if you have that in a patient with MOG antibodies, if you have the characteristic MS patients, that's a big red flag, and you'd want to go back and check the type of assay that was used. So the presence of fluffy lesions or large lesions, few large lesions, and the absence of MS lesions is really critical. Also, as mentioned previously, cerebellar peduncle involvement, particularly the MCP, is also characteristic in MOGAD. When we look at the spinal cord and the transverse myelitis, longitudinally extensive transverse myelitis is considered classical, but a number of the MOGAD patients also have short transverse myelitis. And so that can be sometimes confusing and overlapping with MS. But you look at the other characteristics as well. And there's a very strong gray matter central dominance in MOGAD rather than the eccentric lesions that you can see in MS. These have been described in different ways as a sagittal line sign here or an axial H sign here. Although this is not always present, really dominant gray matter involvement is important. You tend not to see the necrosis or the cavitation that can sometimes be seen with really severe aquaporin 4 antibody positive LETM, even in cases with a lot of swelling and cord involvement. Most importantly as well is the conus dominance that you see in MOGAD, which has been discussed earlier. We looked quite involved in an involved manner at the optic neuritis changes of patients presenting with the first episode of optic neuritis from MOGAD, from aquaporin 4 antibody positive NMOSD, and with MS. And what we identified was the antibody positive cases were more frequently bilateral and most frequently longitudinally extensive, so median lesion lengths of 23 millimeters. In contrast, the MS optic neuritis was often unilateral and more focal. And what we noticed very strikingly, clinically, we noticed it on fundoscopy that 80% of our MOGAD-ON patients had disc swelling. Radiologically, you can see about half the patients have optic disc cupping that's visible radiologically. And this is really not a feature of MS or aquaporin 4 antibody-associated optic neuritis, or if it is, it's very unusual. And then that posterior visual pathway, so that chiasmatic involvement, and optic tract involvement is very noted and well established in the literature in aquaporin 4. Over 60% of our patients had chiasmal involvement and close to half had optic tract involvement, but this is uncommon or rarely seen in MS and MOGAD. Other features have been described as that optic nerve sheath enhancement, or the picture of optic perineuritis, with nerve sheath inflammation enhancement, and enhancement sometimes even tracking into the orbital fat. We have described other associations of MOGAD, including uveitis, that can be present, and it's a little bit atypical and not really described in aquaporin 4 antibody positive optic neuritis, although there is an established literature of uveitis with MS. So with regards to testing for MOG antibodies, using cell-based assays in general, fixed or live, is important, and it's important that that it's well known that using ELISAs are strongly discouraged because of the lack of specificity and the sensitivity. When you have a look at cell-based assays, live cell-based assays require laboratory expertise and culturing, tissue culturing expertise to be able to do this, and to be done in a lab where results have been extensively validated. Fixed cell-based assays have the benefit that they can be sold commercially and performed in other laboratories. An excellent multi-center study demonstrated that there was actually great correlation between live cell-based assays from different centers that do this a lot, from expert centers, but that agreement was lower with fixed cell-based assays. So the other interesting point of note was that everyone agreed when the titer was really high, but when the titer was lower, it was quite difficult. So what that indicates is, where possible and where geographically access is available, if you have the option of using a live cell-based assay, this is preferable. With fixed cell-based assays, if the titer is low or not reported, or if there is some disconnect from the clinical picture. So if you clinically feel that this really looks like MOGAD and the test is negative, or if you really feel that this looks like MS and the test is positive, then it's well worth it to try and send the sample for testing in a laboratory that can do live cell-based assays, because there's very high specificity of the MOG IgG antibody detection by live cell-based assays. And this is lost to some degree with fixed assays. The other thing that's really important is that the testing should be for serum MOG antibodies, not CSF. It's fine to test for both if that's possible, because about 30 to 70% of patients might be positive in both, depending on the cohort studied. But it's really important that a sample is not tested only for CSF and not for serum. And the reason is because there are a number of patients who will only be positive in the serum and not the CSF. Other CSF findings, such as the presence of cleocytosis or protein levels, are a bit less helpful in discriminating between MOGAD and aquaporin 4 and MS. There's not much there. And intrathecal oligoclonal bands can be detected in as low as 5% to as high as 25 to 30%, depending on the cohort reported. Other things that are important, the question that's often asked is, do the titers predict a relapsing course? And then there's some very nice papers that demonstrate that in one particular patient, when you look at their assays over time, the titers tend to be higher when they're having an acute episode compared to when they're in remission. But there are other studies that equally demonstrate that patients in obvious clinical remission remain seropositive. And so these findings are difficult to extrapolate. And the main point is that clinical disease activity should be what's guiding therapeutic decision-making rather than a titer level per se. The last area I'd like to touch on is management and outcomes and therapeutic challenges in MOGAD, and looking at the disease course and treatment responses, particularly with the relapsing patients. And that can account for close to half of the children and sometimes over half of the adults. And this estimate of relapse is probably to some degree muddied by the fact that retrospective cohorts include patients who were diagnosed at a time when the field was still emerging in adults. So likely now, with increased recognition and earlier diagnosis and earlier treatment with immunosuppression, this relapse rate might reduce. So it's something to look for in future papers. So I mentioned there was a cohort that we looked at of 60 children and adults with relapsing MOGAD. And one feature that we found that was very interesting is these patients often have a early, immediate, really excellent response to steroids. But what is difficult is that they tend to frequently relapse on steroid cessation or reduction. And when we tried to analyze this data, it looked like a large number of relapses occurred when steroid doses were reduced below about 10 milligrams a day adult equivalent, or within the first 0 to 5 months after treatment cessation, particularly in the first 2 months after steroid cessation. And when patients had a longer taper, they tended not to have a relapse, whereas when patients had a really rapid taper, as we might sometimes do with multiple sclerosis patients who have some disability and they're given a quick steroid taper, in MOGAD patients, these were often followed by a relapse. And this has been demonstrated in multiple cohorts internationally that there is this steroid risk. And maintenance prednisone is obviously effective in achieving clinical remission. If each line is a relapse and steroids start here, in most of the patients, you can see they're not having further relapses, except in some cases where you wean it off and they have a relapse requiring reinstitution of steroids. So, you know, out of about 17 patients, only one of them was not responding to steroids. The other thing to note is that some of these patients were previously diagnosed as MS, and they might have had immunomodulatory therapy suitable for multiple sclerosis. And these patients often relapsed when it later became obvious they had MOGAD. When you look at what is the most useful maintenance immunotherapy, all the immunotherapy, prednisone, IVIG, mycophenolate, rituximab, even azathioprine to some degree, when you compare pre-treatment ARRs or annualized relapse rates and annualized relapse rates during treatment, they all reduce it. There's a strong literature on steroids. There's an emerging literature on maintenance treatment with IVIG and rituximab. An important study demonstrated that some patients with rituximab might relapse despite B-cell depletion that would normally be expected to keep, for example, aquaporin-4 antibody-positive NMOSD disease-free, but these MOG patients tend to relapse. So this area is still under study and assessment about what biomarkers might help us identify which patients might be rituximab responsive, because there certainly are patients like that and which patients may not. When you look at the outcomes, patients with MOGAD are described as generally having excellent outcomes compared to patients with aquaporin-4 antibody-positive NMOSD. And that is true to the majority of cases, but we still need to take a couple things into account. A lot of the outcome scores are EDSS, which is very locomotor dependent. So patients with significant visual impairment, which I think we'd all agree really impairs quality of life, may not score very highly on EDSS. So there might be some false reassurance from that perspective. And when we look purely at visual outcomes in MOG antibody positive patients, you can see here, if you just look at the visual functional system score, a component of the EDSS, where 0 is normal vision and 6 is legally blind. And you can see at acute presentation with MOG and aquaporin-4, a lot of them have really impaired visual acuity. At long-term follow-up, a lot of the MS patients do really well with the return of vision. You can see here, not unexpectedly, some of the aquaporin-4 antibody-positive patients have permanently impaired vision. However, you can see the MOG antibody-positive patients, not all of them have gone back to normal or close to normal. And there are some patients that continue to have visual impairment who may not rate very highly on an EDSS. And when we look at retinal nerve fiber thickness serially in patients with relapsing optic neuritis, some of these patients do have retinal nerve fiber layer atrophy. So this might be a helpful adjunct to clinical management to try and determine when treatment escalation is appropriate. The other thing we've noted is that visual acuity often goes back to normal for a number of episodes, and then suddenly there's the one episode where it doesn't. And that might mean that there's some threshold effect of retinal nerve fiber thickness beyond which you lose vision. So visual acuity loss might be a late marker of visual impairment. The other thing we've noticed is that this long-term disability in MOGAD patients is really prominent in those who have transverse myelitis. So complete recovery is uncommon in transverse myelitis. Sphincter dysfunction and sexual dysfunction is very common and persists even though motor impairment might improve. And when you look at who had really, of these 60 patients, no disability at long-term follow-up, it was 40%. So 60% had some degree of disability in one or more of these domains here, despite having MOGAD. And this moderate residual disability has also been reproduced in many cohorts that demonstrate that it may not be the benign disease that it's sometimes felt to be. When you have a look at relapses and the EDSS, initially they tend to go back to normal, but with recurrent relapses, they're not recovering full function. And these appear to be attack dependent rather than secondary progression. So trying to treat them to minimize relapses is a critical part of their treatment. In conclusion and in summary, I suppose, when you think of optic neuritis that is bilateral or recurrent with prominent disc swelling, MOGAD should be on top of the list. When you think of transverse myelitis, sphincter and conus involvement, or recurrent short transverse myelitis or longitudinally extensive transverse myelitis, MOG antibodies would be important to test for. And when you see encephalitis and seizures, meningoencephalitic presentations and ADEM in the brain, MOG should be tested as well. What's also important is that if patients who have been previously diagnosed with MS are not responding or worsening, it's always worth revisiting their previous investigations and radiology. MRI characterization of the optic nerve, as I described earlier, with the disc swelling and the optic perineuritis is important. And then the MRI spine, the gray matter involvement, nerve root enhancement and swelling. And then in the brain, MS radiology really shouldn't be a feature in most patients with MOGAD, and large lesions that are a bit fluffy and ill-defined are where that should be considered. The accumulation of silent lesions in the absence of clinical deficits is really uncommon compared to MS. So my final statement would be that using live cell-based assays, MOG antibody seropositivity is really distinct clinical syndrome that's separate to MS and aquapoint for NMOSD. And they're distinct clinical and radiological characteristics. And while these patients are steroid responsive, there's obviously the long-term systemic complications of steroid use. So maintenance steroid-sparing immunosuppression may be required. Early recognition and prevention of relapses would be critical to improve outcomes in these patients. I'd like to thank our funders who enable our research. I'd like to thank Professor Russell Dale and Fabienne Brilot, who I work with, and we co-lead the Australian and New Zealand MOG study group. And these are the large number of collaborators. We have over 50 collaborators from 45 centres in Australasia, and we currently follow a cohort of about 500 patients. Thank you very much for your time.
Thank you very much, Dr. Ramanathan, for that excellent and comprehensive update on MOG antibody-associated diseases, and especially touching on the overlaps. Now I'll invite Dr. Bimsara Senanayake to moderate the questions.
Yeah, since the first three talks on NMOSD, aquaporin 4 and MOGADs, I thought we will have a few questions and a discussion before we move on to the final segment. So it's open for discussion. Can I ask Darshi about children with ADEM who are MOG positive? What is your approach, Darshi?
So the children with ADEM who are MOG positive are usually treated in a very similar way. So they'll start off with steroids early on. So about a third to half of the ADEM patients, if not more, will end up being MOG antibody positive. So they're initially treated with steroids and often have a really excellent response quite early on. And sometimes that might be all that's required. And the key really is to not stop the steroids very quickly. So give them the pulse of steroids and then subsequently a slow taper. So you'd want to get them down from the toxic doses relatively quickly within the first 6 weeks to 8 weeks, but then you'd keep that taper going probably for about four months or so in some cases. Now this varies quite depending on the center that patients are looked after. There is some division in thought about the children and ADEM, and some people recommend really rapidly tapering the steroids. In our case, we tend to be a little bit more cautious with that because we've found that the relapsing cases don't occur when you take this approach. In children who have ADEM and then have recovered from it and are off treatment for some time, we do find some children in later years go on to develop other demyelinating phenotypes as they get older. So they often have ADEM or recurrent ADEM before the age of 6 or 7, and then they go on to have optic neuritis or transverse myelitis. If it is clear that they have a relapsing phenotype, despite cautious taper of steroids, then they might require further maintenance immunosuppression to minimize steroids on their growth.
What about repeating MOG antibodies after a few months? And if the antibody levels have come down, will you taper off the medication? Or if the antibody titers are the same, will you continue steroids? Although it's a monophasic illness most of the time, will you continue to give steroids?
So generally, we try to go by the clinical presentation because we've noted that there are a number of patients who are seropositive for quite a long time, and I'm talking years after the prior episode. So I would be hesitant to continue steroid therapy until the levels come down. So I think we might take the approach of gently titrating it down and stopping it if they're clinically recovered and improved. If it's still positive, yes, I mean, we would love it for it to be negative when we test it. That would be very reassuring and comfortable. But if they're clinically recovered and after an appropriate period of time that we reduce the steroids or stop it, if they remain positive, we would just keep them on a close leash and review them very regularly and ensure that the parents are well aware that if there's any early symptoms to come to our attention very quickly.
Any further questions? Yeah.
Thank you very much for that excellent outline. In our practice, we don't have access to MOG antibodies, so therefore, what would be your recommendation when we see a child with ADEM? How long do you think that we should give the steroids, because we don't have access to the antibodies to make that clinical judgment at that point?
Yeah, so I mean that's a really valid point. And also the other thing that is apparent to us is also that the access to assays vary geographically. Even when they are available, there are many parts of the world that we can get commercial assays from, but not the live cell-based assays. So I think once again it's going on the clinical picture, and I think trying to have the pulse steroids and then weaning down getting them down below a significant dose within the first few weeks, but then keeping a small amount of doses or going to a alternate day dosing schedule for about 2 to 3 months is probably reasonable. So some of our children are on, a few milligrams every alternate day for a while until we're sure that they've really come off that tail. So I'm not recommending high dose steroids for 4 to 6 months, but I'm recommending pulse steroids and then a reasonable dose for about few weeks to a month, and then stepping it down, but still keeping a very slow taper of a small tail for about 3 to 4 months would probably be our general practice. And as was mentioned before, many of these patients are monophasic, and hopefully that's the last of it. But if they then relapse again, then going back to the steroids and thinking about the need for additional therapy. And a lot of our pediatric colleagues have found maintenance IVIG is very helpful in the long term in maintaining remission. And we've certainly demonstrated in our relapsing kids that the maintenance IVIG does tend to hold a number of them, and then they can come off the steroids. So IVIG would be the other thing that's useful.
regarding rituximab, do you have a cutoff level for the CD19 that you would use to give the rituximab in preventing relapses?
Sorry, is that for my talk for the MOG patients?
Yes.
Or?
If rituximab, would you monitor the CD19 levels, and is there a cutoff that you would use to prevent relapses?
So there was a paper I think I referred to where they mentioned that patients who were B-cell deplete were still relapsing on rituximab despite very low levels of B cells. When we have a look at the supplementary data of that paper and in our own experience as well, some of the patients have relapsed, with just a very small percentage on when you do their B cell subsets. So they would still be below the cutoff that we would consider for aquaporin for NMOSD. And this is not published literature, but this is something that we're thinking about, that pretty much any B cell is too much B cell when you recheck their B cell subset. So in some patients, rather than maintaining a cutoff, because the cutoff varies very significantly when you look at different retux papers, it's sometimes a percentage of total B cells, sometimes it's a percentage of CD20 positive B cells. So I think our clinical practice is more to the point that if we've decided someone is going to have rituximab for a period of time in MOGAD, we tend to treat them. And while we've booked them in for the 6 monthly infusions, from about 4 months, I tend to check the B cell subsets. And if there's any B cell repopulation, I tend to retreat, because when we've had relapses with rituximab, it's usually been between that 4 to 6 month mark. And in MOGAD, unlike in aquaporin for NMOSD, treatment doesn't necessarily need to be lifelong or chronic treatment. So if we say this person's got a very relapsing phenotype, we'd like to give them a period of remission for 2 years and then reassess. During that period of time, I would be checking their B cells within about that 4 to 6 months. And if there's any B cell repopulation, we tend to just bring the treatment forward, and then we reschedule it again for 6 months after, but then we check again for the 4th and 5th month. So I think my answer, which is not based on published literature, but on our anecdotal evidence and looking at supplementary data from other papers, is that probably any B cell repopulation puts your patient at a slightly increased risk of relapse.
Thank you for that. And on that same note, how would you stop treatment? You were saying that about 2 years later you would stop treatment. On what basis would you stop the treatment?
Yeah. That's a really tricky question. I'd be interested to see what the other panelists think. But I think that from in our experience, there are some patients with MOGAD who have a very difficult clinical phenotype early on, where they have a lot of disease activity for a few months to a few years. But I think we've all seen those patients that are disease-free off treatment historically for 10, 12 years even. I mean, I've got a girl who's now in her late 20s, but she had ADEM as a child, and then she had optic neuritis at the age of 8, and then she had nothing else till she came to my attention at the age of 28 with transverse myelitis. And then that's when we diagnosed her with MOGAD. So I don't think that there is a rationale for saying that that patient should have been on treatment for that 20-year period where she was disease-free and very well. So I think our general approach and looking at our cohort has been that in the first presentation, you have a cautious steroid taper, and then hopefully about half of them are monophasic and don't require further treatment. And for the ones that are relapsing after the second episode, we start thinking seriously to try and minimize their steroid burden. What are their other options? And IVIG or rituximab or whatever the case may be. And then depending on the disease severity, so if they've had a terrible transverse myelitis and are really still having disability, I would be much more cautious about stopping treatment. Whereas if they've had optic neuritis that they've recovered completely from, and they've got no retinal nerve fiber layer atrophy, and they've had a couple episodes of optic neuritis and they've been disease-free for a year or two, I do it in conjunction with the patient. We'd have a chat. We'd say, do you want to try and stop treatment or not? Usually the patients want to stop. We accept that there's a risk of relapse, but we also talk about, I usually give them oral prednisone script. They've got their prednisone in their pocket and wherever they go. And if they get a repeat episode, take 50 milligrams and call me and we'll get back on track and decide what we need to do. One of the things is these patients know what their symptoms are. They're very steroid responsive. So you're less likely to damage them in the long term when you trial treatment cessation. However, with transverse myelitis, I'd be a lot more careful because some of our patients have been disabled with just the one episode.
Kazuo, can you comment on this, the management of patients with MOG antibody positivity, MOGADs, long-term management?
Yes, can you hear me?
Yeah.
Yeah, well, it's a very difficult question, and I have to admit that we do not understand what triggers the relapse of MOG. Let me give you an example. A man in his 70s was referred to me with 8 or 9 episodes of unilateral optic neuritis. And he told me that every time my steroid was stopped, or when daily dose of corticosteroid was less than 7.5 milligram a day, I had a relapse. I suspected MOG, and he was found to be positive for MOG. So, an local ophthalmologist referred the patient to me. So I replied to the doctor that this time you should not discontinue corticosteroid. But for some reason, the ophthalmologist discontinued the patient's corticosteroid again. So I said to my patient, well, I don't understand why he did it, but you may experience another relapse. That was 6 years ago. Since then, without any immunosuppressive treatment, although he had multiple episodes of optic neuritis, depending on the corticosteroid treatment. But this time, 6 years, no relapse at all. So again, I must admit that we do not understand what triggers the relapse of MOGAD. That's my comment.
Thank you. Can I ask Isabel a question? Isabel, nice to see you again. And thank you for your talk. With regards to your work with aquaporin 4 on the placenta, would you recommend escalating treatment during pregnancy in patients with neuromyelitis optica?
I understand the question was for me. Tashi, nice to see you.
Yes.
I couldn't understand very well the question because the sound was a bit far away for me. Could you kindly repeat, or someone repeat for me?
Yes. The patients with aquaporin 4 you have found in the placenta of women. So in pregnancy with patients with NMO, do you recommend increase in treatment, immunosuppression during pregnancy for these patients?
No, usually we make sure that they remain on treatment or change the treatment according to the medications that are safe during pregnancy. Let's say if a patient is stable on azathioprine, low-dose steroids, if these are safe for the pregnancy, and if they are stable, and if the dose is according to their weight prior to the pregnancy, they remain on the same doses. We don't usually increase the dose just because the weight goes up because pregnancy. Unless they have an attack during pregnancy, then we have to review whether we need to adjust medication. sometimes if that happens, if they have an attack, we may increase slightly the steroid dose rather than azathioprine because could have more toxic effects.
Thank you.
One final question. Kazuo, you mentioned about serum GFAP levels in AQP4 positive patients as an indicator of severity. Is it the same in the CSF, or do you? How does it cause any overlap with the GFAP encephalopathy?
Well, well, we have not analyzed it yet, but probably there's a correlation between the serum level and the CSF level. When we reported the very high level of GFAP in the CSF many years ago, only the ELISA was a method to measure the GFAP. In that study, we measured the GFAP in the serum with ELISA, but unless the cases with extremely high CSF GFAP level, we were not able to detect GFAP in the blood. But recent studies on serum GFAP have been done with a very sensitive method like CMOR assay. So it's very much dependent on the highly sensitive method to detect the GFAP. And it's very important, and blood can be studied many times and relatively non-invasive compared to the lumbar puncture to obtain CSF. So I think that serum GFAP will be very well informative to imagine what's happening in the CSF. But more studies are needed to see if the serum GFAP levels can be used to choose treatment in individual patients. That's my comment.
Thank you very much.
So thank you, Dr. Fujihara, Dr. Ramanathan, and also Dr. Maria Isabella for participating in this panel discussion, and thank you for all three of you. And we'll be moving on to the next talk. The last talk for this session, it will be on multiple sclerosis, ethical use of off-label DMTs in MS. I would invite Dr. Joanna Lawson from Hong Kong to deliver a lecture. Over to you, Dr. Joanna.
I'm an international consultant and I work with MS International Federation, and I will be discussing the ethical use of off-label disease-modifying therapies in MS. First, to introduce MSIF, we're a global network of national patient organizations. We have around 50 members. They range from large organizations such as the one in the US, the National MS Organization, to smaller ones which might be mainly led by volunteers. In addition to our members, we liaise with another 50 countries where the organizations might be a lot smaller and might not meet membership criteria. So in total, our network is around 100 different organizations and countries. MSIF has 5 strategic aims, and the work that I will be discussing today will fit under the improved access to treatment and healthcare. But of course, a lot of our projects fit within a number of these different aims. And the off-label work, of course, also overlaps with the scientific aim, as well as the confident and informed decision-making, positive changes in attitudes, policies, and practices. There are 2 other things that I really wanted to emphasize before I share more of the off-label work. One is that all of the global work, really the need needs to be coming from the national setting. Similarly, when we have a global project, we need to implement it in the national setting as well. So there needs to be a constant dialogue, really, between us as well as the national MS organizations. The second one is that we are really promoting that the MS organizations work closely with healthcare professionals. And that's another reason why it's such a pleasure to be here today, to talk to you, and I will be very happy to take any questions at the Q&A session afterwards, or I can be contacted later on as well. One of the flagship projects of MSIF is the Atlas of MS, which was updated in 2020. It has 2 different modules. One is around epidemiology, and the other one is around clinical management. The Atlas of MS is a questionnaire that is sent to country coordinators around the world, and then we collect and collate the data, and we make it available for everybody on our website. It can be downloaded in an Excel format, and it's extremely useful for global advocacy work, when we work, for example, with the World Health Organization, and also for members and anyone else who would like to do any national advocacy. And I'd like to share some of the results that we had for disease-modifying therapies to give you an introduction to the off-label work. First of all, barriers for accessing DMTs is very common. Over 70% of countries report barriers for people with MS to access DMTs. Secondly, there is unequal access to DMTs. We have split the data both by income groups as well as the geographical regions. And what we can see is that in low-income countries, only around 30% of the countries have access to licensed DMTs. This is any licensed DMT for MS. And this actually is around 70% for low-middle-income countries as well. The problem is actually even worse when you're looking at the higher efficacy DMTs, as we have defined them here as alemtuzumab, natalizumab, and ocrelizumab. And what we can see there is that in low-income countries, none of the countries that replied to our survey had access to high-efficacy DMTs. In low-middle-income countries, lower-middle-income countries, this was 50%. When we were asking about the actual barriers that are stopping people from accessing DMTs, the most common reason that came forward was that it was too expensive for the government, healthcare, or insurance provider. And also, of course, for people with MS, out-of-pocket costs. So what can we actually do about this? So to tackle this, we formed our International Working Group on Access. They are set with the task of strategy development in order
to look at the aim that I described earlier around access to treatment and healthcare. They will also start and develop different projects, which will be often spin out to a different committee or working group. The international working group has 24 members. We cover all of the World Health Organization world regions. We have people with MS, healthcare professionals, and MS organizations represented. The first project that this group really started with was that we applied for MS treatments to be added onto the WHO Essential Medicine List. Currently, there are no MS treatments listed, and we put together an application in 2018. Unfortunately, none of the DMTs that were proposed were actually listed, but we did get some very good feedback from the World Health Organization acknowledging the need for MS treatments to be listed. They asked for a revised application, which we plan to submit in 2022. As you can see, obviously it was very disappointed to not have any of the DMTs listed, but we did manage to really raise the awareness in terms of the issues relating to accessing DMTs with some nice publications, and also developing our relationships with the different neurological organizations as well as the World Health Organization. An additional feedback that came from the expert panel from the WHO was that we needed to consider also commonly used DMTs, and they specifically named azathioprine and rituximab. And as you probably know, these are off-label DMTs, and this really kind of sparked the work that I'm going to be describing now. So we put together a panel to look at off-label DMTs for MS. There are two clinical co-chairs. We have Professor Yamut and Dr. Viswanathan, and we also have a methodological chair, who is Professor Schunemann. So why look at off-label DMTs? So as I described earlier on, of course, there are issues in terms of accessing on-label DMTs, and we had been requested by the World Health Organization to look at off-label DMTs as well. But the real crux here is that off-label DMTs may be much more available in health systems. And we actually looked at the World Health Organization National Essential Medicine Database, where 137 countries have submitted their national EMLs, and we analyzed them for DMTs that have been used either on-label for MS or off-label for MS. Now, most EMLs don't actually specify the indication, so we don't actually know if these countries are using these drugs to treat MS, but it is an indication around their availability. And as you can see here, it's probably too small for you to read, but the top one here is on-label DMTs, and 31% of the 137 countries listed one of these DMTs, at least one of these DMTs. However, when we looked at off-label DMTs, it was even higher, much more higher. It was 95%. So 95% of the 137 countries were listing at least one off-label DMT. From the Atlas of MS, we also looked at what DMTs the different countries were using. So on the left here, we have different drugs. We have blue, we have on-label DMTs, and yellow is off-label DMTs. And then at the bottom, we have the percentage of countries using that specific DMT to treat MS. And what we found was that off-label use was very common. The first yellow line here is for rituximab. We have 70 different countries reporting its use. And the second yellow line is azathioprine. We have 68 countries reporting using it. We don't actually know the scale of use of these drugs in the different countries, so you might have a country taking azathioprine, for example, but they only have a few people on it, basically because they were started a long time ago. But nevertheless, the use is very common. So what we did was that we set up the MALT panel, the MSIF off-label treatments panel. Again, to summarize the need, we needed to review these DMTs for the EML application for the World Health Organization. And also, we recognized that because these DMTs were so widely used, there was some guidance needed. In terms of context, we wanted to focus on areas where there was a real need, so where the availability or affordability is stopping people from accessing a range of DMTs. And this was specifically chosen because of this issue around the high efficacy DMTs not being as widely available as the moderate efficacy DMTs. We took a very unbiased approach, of course, and the recommendations can be for or against. We would be looking, the panel would be looking at the evidence available, there would be panel discussions, and there would be judgments based on those two points. The aims was really, there was two aims. One was to create a robust and transparent process for reviewing off-label DMTs. And then we would actually review the evidence for two specific off-label DMTs, azathioprine and rituximab. The idea is that this process could be used in the future to also look at other off-label DMTs if that was found to be useful, either by us or by other groups as well. So the first step was really to try and define some general principles for the ethical use of off-label DMTs. So we discussed these, and we have also received endorsement from a number of different organizations, including the World Federation of Neurology, the American Academy of Neurology, the European Academy of Neurology, as well as the regional TRIMS, ACTRIMS, ECTRIMS, MENACTRIMS, as well as PACTRIMS as well. And just to go through these briefly, the main principles that were identified was that off-label use of DMTs to treat MS should be driven by the need to protect people's health. The use should be evidence-driven and considered when on-label DMTs are not tolerated, unsuitable for the best clinical outcome, unavailable, or unaffordable. Shared decision-making, again, especially important with off-label DMTs, and appropriate information to be available for people with MS. Outcomes, effectiveness, and adverse events should be carefully monitored, especially when using off-label DMTs. We also identified some long-term changes that were needed. First of all, we wanted to make sure that there would be evidence-driven clinical decision-making and reimbursement decisions, and so there was a need for guidelines. And this is what I will also discuss a bit further in the presentation. The second one was that the regulation of off-label prescribing in general for MS should be further considered and developed both nationally and internationally. Different countries are taking very different approaches to how off-label prescribing works in the different settings. And the third one is around regulatory agencies and other organizations should be developing measures to facilitate official registration for off-label use of medicines with a positive benefit-harm balance based on adequate evidence. And we have actually seen that both the FDA and the European, in the US, as well as the European medicine agencies, they are both looking at different pathways of actually piloting these kind of approaches of looking at repurposing and off-label use. So in terms of the guideline development, which is what we have been working for the last year or so, we first developed a guideline methodology, which has been published. We are working with the Cochrane MS group, as well as the Grade Center in McMaster University. I'm not going to go through all the details, but the idea very much was that we would be using systematic reviews, which are prepared by Cochrane, and then we will have the experts from the Grade Center looking at guiding the panel through bringing the evidence to a recommendation. This is called the evidence to decision framework. It's considered kind kind of gold standard in terms of guideline development. And the idea is very much that there's a lot of transparency and structure in developing the recommendations. And this should also help when people are looking at the global guidelines and thinking about how they could be set up into the national setting. The protocols for the systematic reviews have been published on the Cochrane Library. You can access them. And actually the rituximab systematic review has already been published as well. We're expecting for the azathioprine systematic review to be published this year. Just to quickly summarize the Cochrane review for rituximab, it included 15 studies, both RCTs and non-randomized controlled trials. They had around 16,000 participants, for both for relapsing MS as well as progressive MS. The key messages coming out from this review was that rituximab may offer moderate to large effects on a range of other medicines in preventing relapses in multiple sclerosis. And this was compared with no medicines, the desirable effects would be even greater. There's also limited information to determine the effects of rituximab for preventing disability, and serious harmful effects are relatively rare in people with MS. So it's very difficult to study, and they're also very not well reported in the different studies. So the panel used this information from the systematic reviews, going through the 12 different criteria for the evidence to decision framework. Again, they will cover all the normal aspects in most guidelines, which is around the desirable health effects and undesirable health effects, quality of evidence, etc. But I wanted to highlight a couple of different ones which I thought are particularly relevant for lower resource settings. One is around resource requirements, so costs. The other one is around health equity. And then there's a question around acceptability as well as feasibility as well. So it's taking a very comprehensive approach in looking at these recommendations. So we will be releasing the recommendations for public comment in the next months. But I can show you some of the PICO questions that these recommendations will cover. So for azathioprine, there was not a lot of evidence available. And so we only made, or the panel only made recommendations for 2 PICO questions. One was around azathioprine versus no DMTs in relapsing forms of MS as first choice treatment. And the other one was azathioprine versus other DMTs for relapsing forms of MS as first choice treatment. For this one, there was only data available for interferon, so that PICO questions focused on looking at the difference between azathioprine and interferon. We didn't have enough evidence to look at switching in relapsing forms of MS, and again, not enough evidence to look at progressive forms of MS. So for rituximab, there was more evidence available, and the panel were able to consider most of the PICO questions that were put forward at the beginning. We looked at both relapsing forms of MS as well as progressive forms of MS. We looked at no DMTs as well as other DMTs. And then we also looked at first choice treatment versus switching. There was only one PICO questions that the panel didn't feel comfortable that there was enough evidence to make a recommendation, and this was around progressive forms of MS as first choice treatment for rituximab versus other DMTs. Just to mention a little bit more about our process here as well. So first of all, we have the MOLD panel, which consists of 17 different members. The members are from 14 different countries and 6 different WHO regions. It's multidisciplinary. We have people with MS, we have neurologists, nurses, psychologists, MS organizations, methodologists, pharmaceutical and regulatory policy experts, as well as pharmacists represented. They made the recommendations, but then we also closely consulted with what we call the Tier 1 stakeholders. So this includes the World Federation of Neurology, regional neurological academies, regional TRIMS, the different WHO departments, as well as our internal groups such as our Medical and Scientific Board and our International Working Group on Access. And we also identified some experts who we knew were using these DMTs in clinical practice at a scale. So these were from India as well as from Sweden. Sweden uses rituximab quite widely. We then also have the second ring of different stakeholders, which is the wider MS community, and we will also be opening up the recommendations for open public comment. So just to show you where we are sitting in terms of the process, we have now got the draft recommendations, and we have completed our consultation with the key stakeholders. We will be opening up for a public comment in the coming months, and then we will be producing the final recommendations, which will be published in a peer-reviewed journal, and then we will be working on dissemination and advocacy activities. So this brings me to the end of my presentation. I'd like to thank you very much for your attention, and I would be very happy to take any questions. If there's not enough time for questions, please also do contact me by email.
Thank you very much, Dr. Joanna, for that important update on the ethical use of off-label DMTs in MS. And this is a very important area for discussion, but I'm sorry that in the interest of time that we will be unable to take up any questions. And you can email her for your questions. And at this time we'll break up for lunch, and we'll be meeting at 2:30 in 45 minutes time, so that we'll keep up with the program. Yeah, at 2:30. Is it 2:30? Yeah, 2:30 for the next session, so that we'll be in line with the program. Thank you very much.
And the off-label work, of course, also overlap.
Check. 1, 1, 2. 1. Test. Test. 1, 1, 2. Check.
පීයක් නෑනේ. පීයක් තියෙනවා. හැන්ද වෙනවා කියන්නේ. හැන්ද ගන්න.
මයිසయ్య මට එකක් අරන් ඉන්නේ. ඒකේ තියෙනවා මචං ෆස්ට් ඩිෂ් එක, සෙකන්ඩ් ඩිෂ් එක, තර්ඩ් එක. තර්ඩ් එක නූඩල්ස් මචං හරිද? ඒකට කලින් තියෙනවා එක. අන්න ඒක අරන් වල මැද තියෙන එක දෙයි මිඩල් වන්න ඕකේ. ඒකෙන් මචං මේ නෝමල් හැදි හතරක් වගේ තිබ්බනේ නේද? ඔව් නෝමල් හැදි නෙමෙයි ෆුල් හැදි හතරක් තිබ්බනේ. මයිසයි චුවර්නේ එලගිරි තදපොර එලගිරි නේ අර වෙහිකල් පාස් එක දුන්නේ ඈ වෙහිකල් පාස් එක දැන් වෙහිකල් පාස් එක වෙහිකල් පාස් එක නේ තාම දැන් ඉතින් අර මලි වෙහිකල් පාස් එකක් දෙනවා වෙහිකල් පාස් එක කොහොමද බලපාඩ ෆෝන් දාගෙන ඔබ බුද්ධ කාලේට යන්න බුද්ධික කාලේට අවක පාස් එක ඔව් අන්තිමට මේ කොහොම පාස් කරා මෝ වෙහිකල් පාස් කරේ දැක්දිලා කාලවරේ මේ ගන්නවනේ බද්දේ කාලවරේ වැඩි ඇස්සියා පටන් ගත්තා මට හරයට යන්නකො දීපන් ඈ නැත්නම් මම වෙහිකල් පාස් ඔක දෙන්න නෑ ඔක දෙන්න මේක දෙන්නේ ඔක දෙන්න බුද්ධික කාලෙන්න වැඩි පටන් ගත්තා නෑ එනකොට ඉරන්නේ ඉරනවා දීපන් මචං මහේෂයි තිබ්බට තායයක් නෙමෙයි ගන්න අර මහේෂයි මෙයාස් කියලා දාගන්න එත් කරා ආව මහේෂයි කිය වැඩි පටන් ගත්තා මේ මහේෂයිට මතක් කරපන් මචං මට කෑම එකක් කියන්න තියෙනවා කියලා මම කියලා සුපෝලිමේ ඉන්නේ බං ඒ ඔව්වා මම කිව්වා පොඩ සීපාරක් ඔව් लेना क्या मानती मैं बोल पे चल मेरे तेल के डी बार काम तेल रेडी नहीं मैं तमाम ठीक है बराम पर दाढ़ी में से कमी का डी बात दिख रहा ठीक है मैं सुनो तुम्हारा दे रहे हो इंदा नीला मैसो आप बेटी का हम नहीं कर क्वालिटी है क्वालिटी मैसो बोलवा मैं टंगे ना मां काम को सरन सरन के बारे में नहीं किरी में के टंगे लग रहा है पर मां तो बाहर के रडा करम नहीं दिया मैं जाम में एक्चुअली इन्ने का ना डूबे अरे वो देने मांगे दा मांगी इवेंट के लगी इधर इस तरह मांगे आलू दूने के बीवा बियर हायर रुपया 5-10 का है बियर हाया है मैं बाइट का जाता हूँ ना हर चिप्स आना मना देखे थे 5-10 का पार ना अंडा लागर है स्टॉप दो मैं करा ना बोल में कोई फेसबुक के फोटो कर रहा हूं ना मैं हो भी हां खाना अलग नहीं ये का है नहीं या उसके माचो अबे
Check. Yeah, it's on. I was start, no? Yeah, yes. You can start. Is my Wattjes name? Yeah. So receive the order. Into your folder, no? We just Good afternoon, everybody. Welcome you for the next session on Neuroradiology Symposium. Our first speaker is Dr. Mike P. Wattjes. He is from Germany, senior neuroradiologist attached to the Department of Neuroradiology at Hannover Medical School, Germany. His primary research and clinical interest included neuroinflammatory and neurodegenerative disease as well as neuro-oncology. And he is going to talk on new MAGNIMS, CMSC and NAIMS recommendations on the use of MRI in MS. Over to you, Mike. Thank you.
Yeah, many thanks for your kind introduction, and many thanks for to the scientific committee for inviting me to this very nice meeting. Just a technical note. So can you see my screen?
Yeah, you can see the screen.
Okay, good. All right. All right. So so my presentation will be on the year 2021 MAGNIMS CMC names recommendation on MR in MS that has been published a couple of months ago in Lancet Neurology. These are my disclosures. So I will start with some introductory slides, and then we will focus on the role of imaging in MS diagnosis, in particular in terms of standardizing the MR acquisition. Then we will move to a very important topic, which is MR treatment efficacy monitoring. So once again, I will focus on standardized MR acquisition on a relevant MR outcome measures. So there is a revised role of gadolinium in this whole context. And we will focus on the so-called disease course adaptive monitoring approach. And then I will close my presentation with some future perspectives. So the imaging perspective of MS is getting increasingly complicated. So initially, MS was considered as a white matter disease with this perivascular distribution pattern in the white matter. However, we are experiencing a sort of shift from white matter to gray matter. So we know that gray matter pathology is extremely important in MS, not only from an imaging perspective, but pretty much from histopathology and clinical perspectives, with special regard to cognition. Spinal cord, extremely important in terms of disability progression. And we know also that the imaging manifestations are occurring outside of the brain, such as in the leptomeninges. So it's extremely difficult sometimes. So therefore, guidelines might really help you to use imaging and to interpret imaging phenotypes in a very standardized way. And there have been MAGNIMS guidelines published a while ago in 2015 by Alex Rivera and myself in Nature Reviews Neurology. And 1 year later, in 2016, there have been guidelines published by the CMSC, the Consortium of MS Centers, a North American consortium. And these guidelines were a little bit different compared to the European MAGNIMS guidelines. And I repeatedly got the question, Mike, why is this the case? So why are the North American guidelines different compared to the European ones? So which guidelines shall we follow? So therefore, I think there was a crucial need to merge different positions and recommendations from different continents to one major recommendation statement. And this has been established with these mentioned 2021 MAGNIMS CMSC names consensus paper. So what was the motivation to meet again or to reconvene and to discuss important topics? So first of all, there have been updates on the MR acquisition. So 3D acquisition is more widely available across the world. And this offers the opportunity of an aberrated scan protocol, so to scan quicker but not dirty, at least for certain indications. And we wanted to discuss whether or not advanced imaging techniques, including ultra high field MR, might be ready for clinical practice. Then a very, very important topic is the role of gadolinium. So you know that there's a huge discussion going on to which extent elemental gadolinium, which is a heavy metal, by the way, enters the brain and gets accumulated in the deep gray matter. So therefore, we had to discuss whether or not we should recommend gadolinium for diagnosis and monitoring purposes. There's an increasing role and relevance of imaging in the prognosis of individual patients, in particular in the early disease course, so whether or not certain imaging markers can predict the disease course. In terms of treatment efficacy monitoring, spinal cord has been increasingly important. There has been new data that asymptomatic spinal cord lesions might be more frequent observed than we anticipated. And there have been new outcome measures introduced, including these chronic inactive active lesions, the so-called smoldering lesions, and also the leptomeningeal enhancement representing the leptomeningeal inflammation being associated with the cortical demyelination. And safety monitoring, I will not focus on this in detail during my presentation, though, this was mainly driven by the fact that we got some new data suggesting an extended dosing interval with natalizumab. There was the question arising whether or not we should adjust the safety monitoring recommendations. And this is very important. This is the first recommendation paper focusing on distinct phenotypes in MS, in particular progressive MS, pediatric MS, and MS and pregnancy/lactation. All right, so a little bit of history. So the MAGNIMS group convened in Graz in Austria, which is the capital of the Steiermark, by the way, in April 2019. These are the participants, a very nice group of neuroradiologists, neurologists, and pediatric neurologists and pediatric neuroradiologists, but also physicists. So we had a very nice balanced group of experts discussing the topics I was just referring to. And then there was a second workshop held in New Jersey by the names CMSC folks and Friedrich Barkov as the representative of MAGNIMS discussed with the CMSC and names folks, the guidelines and the two recommendations were basically merged into one single recommendation statement. And a very important thing is the standardized MR protocol for MS diagnosis. This is presented here, a very easy to apply protocol, easy applicable protocol. You start with the contrast injection. You perform a late echo T2, a flare, preferably a 3D flare, and you finalize the protocol with a T1 post-gadolinium. This is very sexy in terms of standardizing the delay between the contrast injection and the T1 acquisition. It's always longer than 5 minutes, and this is very important. Otherwise, you will not have a chance to detect blood-brain barrier disruption. In terms of magnetic field strength, 3 Tesla is recommended, but not mandatory. So if you have a good 1.5 Tesla magnet, that's more than sufficient. And the spatial resolution is standard. So in 2D acquisition, slice thickness of 3 millimeter in plane 1x1. And if you have a 3D acquisition, we recommend an isotropic voxel size of 1x1x1 millimeter. This protocol has been initially established for adult MS patients, but and this is brand new. This is also recommended for pediatric MS. In terms of spinal cord, once again, we have a standardized protocol. So you start with a contrast injection, and you should perform, and that's very important to remember. You should always perform a double contrast, so either PDT2 or STIR-T2. Followed by a sagittal T1 post-gadolinium. So if you are not familiar, looking exclusively on the sagittal planes, you can initially perform axial T2 images, nicely showing the distribution of the lesions, more pronounced appearance in the lateral and the posterior columns. However, this is not mandatory, it's optional. In terms of magnetic field strength, 3T does not have any added values, so you can easily perform 1.5 Tesla, and the spatial resolution is the same compared to brain imaging. And once again, this is also the protocol recommended for pediatric MS. So this is once again a summary of the double contrast I was just referring to. So never ever exclusively focus on late echo T2. So always perform a double contrast, either PDT2, STIR-T2, or which is a very nice contrast that has been introduced by the NIH. We use this also in Hanover now on a regular basis, which is 3D T1 contrast, phase sensitive vision recovery in combination with late echo T2. Although actual T2 is not recommended on a regular basis, there are a couple of indications when we should use actual T2, and this is in particular the case when we have to differentiate between MS, NMOSD, and anti-MOG or MOGAD. So we know that MS lesions are nicely located in the lateral and posterior parts, whereas in NMOSD and MOGAD, the lesions are more located in the center of the spinal cord, including the deep gray matter. So this is an indication an axial T2 might be very helpful. Optic nerve, also frequently used in at least in Europe at the time of MS diagnosis. Sometimes you can see these very nice information of the optic nerve representing the optic neuritis. However, if you're trying to use this on a regular basis, this will increase the acquisition time by approximately 50 minutes. You need axial and coronal fat saturated T2 and axial and coronal fat saturated T1 post contrast. And it's not recommended to perform on a regular basis for diagnostic purposes. So focus on the brain exclusively. However, there might be some certain indications, and once again, the differentiation between anti-MOG, NMOSD, and MS might be one of these indications when optic nerve imaging can be helpful. Once again, optic nerve not to be performed on a regular basis, only when certain indications are given, like here listed in the table, and you can read this in the paper in more detail. So in terms of diagnostic criteria, there might be the situation that you are able to establish the MS diagnosis with one single MR by demonstrating the presence of contrast enhancing and non-contrast enhancing lesions. But there's also the situation of the scenario that you need follow-up MRs to establish dissemination in space or in time. So for these purposes, we present very strict recommendations. So the first recommendation is that for the initial MR evaluation, you should always perform a contrast-enhanced brain and spinal cord MR, which offers the opportunity to establish the MS diagnosis with one single MR acquisition. In the case you're not able to establish MS diagnosis with one single MR, you should perform another MR without gadolinium and only a brain MR 3 to 6 months after the baseline MR. And if this second MR is also inconclusive, you can perform a third MR, once again, a non-contrast enhanced brain MR 6 to 12 months later. For patients with virologically isolated syndrome, and Darin will talk in a couple of minutes, and Darin is basically the person who invented this concept or established this concept for virologically isolated syndrome. The same acquisition intervals and the same acquisition recommendations are recommended. So there's no differences between MS and CIS patients and virologically isolated syndrome patients regarding image acquisition protocol and time intervals. Another very important topic we focus on is the prognostic value of MR markers at disease onset. So, as you know, there are a couple of markers, including the number of brain lesions, the lesion distribution with special regard to the brainstem and the cortical gray matter, contrast-enhancing lesions, and the persistent inflammatory disease activity in the first 3 years that can help you to categorize these patients into different prognostic categories. And this includes the conversion to definite MS, the long-term disability progression, but also the development of SPMS. So this is old data. I always call it the Bible of Queen Square, very nicely demonstrating, based on the Queen Square cohort, that the number of lesions at baseline predict long-term disability. And this is even more the case if you have brainstem lesions, like shown by the Barcelona cohort. But in addition to this, in particular, asymptomatic spinal cord lesions play an increasing role in predicting the disease course in terms of disability 5 years after the first clinical event. And this is even more an argument to perform a very standardized spinal cord imaging at disease onset. New data suggests that cortical lesions at disease onset have prognostic value in terms of predicting the SPMS. So not only the fact whether or not you see cortical lesions to have an impact on whether a patient will have SPMS in the future, but also the number of lesions, the number of cortical lesions can give you an idea of the time interval the patient will develop SPMS. In other words, the higher the cortical lesion load, the shorter the time interval the patient will convert to SPMS. And persistent inflammatory disease activity is another very important prognostic marker in terms of SPMS progression or conversion. So if you have persistent disease activity in the brain or in the spinal cord, in the first 3 years, the patient will have a higher risk of developing SPMS in the near future. Yeah, in terms of differential diagnosis, you know that spinal cord is a very important marker to differentiate between MS and vascular disease, in particular small vessel disease. You know that small vessel disease do not occur in the spinal cord, whereas MS almost always occurs in the spinal cord. But it is a new kid on the block. We call it the central vein sign. You know that MS is perivascular inflammation. Whereas very nicely showing the perivascular distribution of MS lesions. So in other words, in the vast majority of these MS lesions, you will see a central vein sign when using a double contrast, including FLAIR and SWI. Whereas small vessel disease lesions, these white matter hyperintensities, usually do not show the central vein sign. However, you might have some lesions very near to the lateral ventricles where you have a high density of the medullary veins, and then sometimes these small vessel disease lesions might show a central vein sign. However, on the group level, this is highly significant that MS lesions do show these central vein signs, whereas vascular lesions do not. The next question is, shall we perform these techniques in every patient? The answer is no. It's not recommended on a regular basis, but it can be useful in certain clinical situations when you're not quite sure whether or not this is a small vessel disease patient or an MS patient. However, the image acquisition and also the image interpretation requires a certain degree of expertise and, of course, a certain degree of standardization. Another very important marker is leptomeningeal enhancement. You know that there are B cells in the leptomeninges, and we know that in the vicinity of these, I call it follicles, you see a cortical demyelination, suggesting that there is a crucial role of these leptomeningeal inflammation in terms of cortical demyelination and focal cortical atrophy. And there is data in the literature suggesting that these white spots on the contrast-enhanced 3D FLAIR images represent these areas of leptomeningeal inflammation. There is a little bit of debate whether or not this is really the case. However, these images are quite suggestive that this is real inflammation going on. However, this is not specific to MS. We can see it also in other diseases, so therefore it's not recommended on regular basis for MS diagnosis. So in terms of monitoring, so in the case you are able to scan with a 3D FLAIR, you can abbreviate your scan protocol and you can skip the late echo T2, so you will remain a high degree of sensitivity, but you're still you're quite fast in the scanning. So contrast is very important. Contrast has been recommended for a long time for demonstration of inflammatory disease activity. However, this has changed. So there's only one single indication when contrast is definitely needed. This is the initial workup. For all other indications, gadolinium has to be considered as optional. Why? Because active T2 lesions are a very nice marker showing active disease activity, these new lesions. And if you have a high lesion load and you have difficulties showing whether or not there's a new lesions, you have the opportunity to subtract these images. And on the subtraction mask, you see very nicely these white spots representing the areas of active inflammatory disease activity. You can also see these very tiny lesions you might have missed on the original scan. So you can you can save a lot of contrast, and you're still extremely sensitive in terms of the inflammatory disease activity detection. There are also commercial quantification packages available. However, they are primarily in-house validated, not clinical practice validated, so therefore they are not overall recommended to be used on clinical basis. There are new markers occurring. the so-called smoldering lesions, chronic inactive active lesions, aggressive MS lesions not showing any signs of remyelination, more frequently seen in PPMS and SPMS patients. Slowly growing, showing these dark rim representing ion-laden macrophages and microglia. However, if you want to detect these lesions, you always have to scan with a double contrast, so FLAIR SWI. You have to be very standardized in terms of image acquisition. And so therefore, the panel was convinced that this is not ready to be used in clinical practice on a regular basis. Yeah, leptomeningeal enhancement volume 2.0. So in addition to the diagnosis, there's also some issues regarding treatment efficacy monitoring, because these areas of inflammations do not change over time, and there's no data suggesting that this marker responds to treatment. So therefore, we were convinced that this marker is not able to represent a marker for treatment efficacy monitoring, and therefore it's not recommended. Yeah, cortical lesion is very important. We see an acceleration of cortical lesion, particularly in progressive MS patients, like shown here in this lesion probability map. However, it's very difficult to standardize, to have standardized image acquisition and to have standardized reading procedures. And this has led to the observation that inter-observer agreement is relatively poor. And therefore, we recommend cortical lesions for MS diagnosis. And I told you earlier that cortical lesions are very important in terms of SPMS progression prediction. However, for treatment monitoring, you need a very high degree of standardization, a very high degree of expertise in reading these scans. So therefore, if you don't have this expertise, be careful to use this for disease monitoring purposes. The same for spinal cord, also acceleration in progressive MS patients. However, it's very difficult to obtain good images of the spinal cord. Reading interpretation is very difficult. So therefore, we still do not recommend spinal cord imaging for treatment monitoring purpose. However, you can do this if you have a very good protocol or you have a very good expertise in reading these scans. But on a regular basis, it's extremely difficult, and it might lead to false positives and false negatives in terms of inflammatory disease activity. Yeah, brain atrophy, also an ongoing discussion whether or not we should use this in clinical practice. It's very important, in particular, in terms of cognitive impairment. We know that cortical thickness is the best predictor of cognitive impairment. So a lot of music inside these marker and a lot of clinical relevance. Also in terms of treatment response, we know that certain drugs can slow down the acceleration of atrophy, not only the cortical parameter, but also the thalamus. So it's relevant. However, you need a very high degree of standardization in terms of image acquisition. And there are certain other factors that might influence the volumetric measurements, including lifestyle factors and in particular anti-inflammatory drugs. And therefore, we still think we're not ready to use this as a marker for individual disease progression on a regular basis in clinical practice. However, if you're able to standardize the protocol and if you're able to interpret the data in a very standardized fashion, you can try to use these measurements in clinical practice. If you want to use, it's very important to always perform a rebaselining MR if you initiate a treatment 6 to 12 months after the initiation of the new treatment to correct for pseudoatrophy changes and use this rebaselining MR as a real reference MR for the follow-up MR scans. Yeah, one final slide on the future perspective. So we talked a lot about conventional MR and volumetric MR, and there's one issue left, and this is quantitative microstructural MR, and there's a crucial need to focus on remyelination and neuronal repair, because there are certain drugs stimulating neuronal repair and remyelination So I think that the big challenge will be to implement quantitative MR techniques like MTR, TTI, and while water fraction imaging being capable of monitor and assess the degree of neuronal repair and remyelination. To sum up, I think MR standardization is crucial for MS diagnosis and monitoring. MS diagnosis really should include contrast-enhanced brain spinal cord MRI at baseline. We should consider new markers for lesion differentiation, like the central vein sign. And please do not underrate the relevance of baseline MR for the prognostic classification of patients. In terms of treatment efficacy monitoring, the standard outcome measures are still very important. We have a limited use of gadolinium, so there is only one single indication strictly recommending the use of gadolinium. This is the baseline MR. All other indications consider gadolinium as optional, and all the new outcome measures, including smaller lesions, leptomeningeal inflammation, and so on, will need further validation. And I think, once again, the future perspective is to implement volumetric measurements and microstructural MRI to better phenotype the patient and monitor neuronal repair and remyelination. Yeah, having said this, once again, I would like to thank you guys for your kind invitation to the Congress, and thank you very much for your attention. Thank you.
Yeah. Thank you, Dr. Mike, for very descriptive, illustrated lecture on advanced imaging in MS. If you have any questions, we go at the end of the symposium. I would like to invite Dr. Divakaran to introduce the next speaker.
Yeah, it is my honor to invite Professor Darin Okuda as our next speaker. He's a professor of neurology attached to the Department of Neurology of University of Texas in Dallas. He also works at the director of the Neuro Innovation Program and MS and Neuroimmunology Imaging Program. He has widely researched and written on radiologically isolated syndrome, RIS. Currently, he focuses on end-to-end innovative approaches involving the design, creation, and implementation of software, hardware, and manufacturing methods aimed at improving the evaluation, diagnosis, management, and education of patients with MS. Further, he is a diplomat of the American Board of Psychiatry and Neurology, and is a fellow of the American Academy of Neurology and fellow of the American Neurological Association and member of the American Academy of Neurology Committees on Neuroimaging and Ethics. So again, it's my privilege to invite him to deliver the next lecture on enhancing conventional MRI data by three-dimensional conformational analysis. Yes, thank you.
Thank you very much. Thank you very much for the kind introduction and the invitation to present today. I'm here in Texas, so I'm going to do my best to be coherent this morning. So here are my disclosures. And I just heard a fantastic lecture, and I'll take a different take on imaging for my section. And I'll start off with a piece of artwork from Vincent van Gogh named Patch of Grass. And what's really fascinating about Van Gogh is that he actually suffered from neurological disease and suffered from temporal epilepsy and Geschwin syndrome, and created a variety of works of art. And it's interesting in that he's known to have reused up to 30% of his canvases. And a group in the Netherlands actually used a very sophisticated spectroscopic technique to identify works of art underneath other great works of art. And I think that's the whole goal when it comes to MR imaging. It's really trying to understand if what we're seeing in front of us is something special. And is there another story that can be told? And like a masterpiece that you may see in a museum, is there something underneath it that's right in front of you? You're just unaware of it. I think the same holds true for MR imaging when we look at the brain and when we're looking at lesions. So my goal today is to try to excite you about perhaps another way for us to look at MR imaging data. I think it's fantastic to have new techniques. I think to have techniques that we can easily implement within the clinic to our patients across clinics and across nations is most ideal. And I think right now, even when it comes to brain atrophy, as Mike had mentioned, we're very limited with respect to the effective application of those techniques throughout all of our centers. So just briefly, I'd like to just touch on a few things. And in our field, there are lesions, and then there are meaningful lesions. And here you see the different types of or lesion types that's common to our field: juxtacortical lesion with lesions touching the cortex, ones that actually are or involve the cortex, and then our classic periventricular lesions that touch the ventricle, ones that are located in the infratentorial region, and then the spinal cord. And these lesions are important because they're telling, and they have some degree of specificity with respect to multiple sclerosis. And we also use these conventional measures as well as a means to define success and failure for our patients in clinic. And your T2 lesion burden or your burden of disease has been demonstrated over the past decades to have some degree of meaning as it relates to long-term outcomes. And same with T1 hypointense lesions that really provide more clarity with respect to the degree of axonal compromise if present for a long period of time. And now you see a number of investigators looking at the change in T2 lesion volume or the enlargement of T2 lesions. Same with T1 hypointense lesions. So the concept of slowly expanding lesions is one that people are looking at now that can help to forecast what we're describing as disease progression. So the concept of smoldering lesions, slowly expanding lesions themselves appear to be meaningful with respect to translation to worse outcomes in the future. There've been fantastic work by a number of individuals that aim to improve lesion specificity. And these include the presence of central vessel as well as paramagnetic rims that contain macrophages with iron in them. And there are some groups that have revealed that may have some degree of correlation with clinical outcomes long-term. I think this type of work is fantastic. I think where there may be a partial disconnect is how do we effectively allow for application of the techniques in a variety of centers, and how can we use this at the individual level? So a lot of, when we look at MRI measures in clinical trials, it's pretty straightforward with respect to what we look at. We look at if contrast enhancing lesions are present or not, and do these medications help to suppress them? We look for whether there's a new or enlarging T2 lesions. The enlarging part is filled with a variety of definitions. At times they can be voxel-based, they can be volume-based off of a given percentage from baseline, which changes. It could be 20%, 25%, 40%, and even greater. And then of course your overall T2 burden of disease, your T1 burden of disease, and then these volumetric measures that everyone's excited to look at that serves as an advancement of our MRI measures from long ago. What's somewhat missing is information involving the infratentorial region as well as the spinal cord. And when it comes to clinical practice, things are very different. Contrast enhancement is very easy to see. Enlarging lesions, more difficult to see, not something that's commented on by by clinical neuroradiologists. New lesions are easier. We can see enlarging T2 lesions when they get much, much larger, but the subtle changes are very difficult to detect. We don't necessarily get any data with respect to infratentorial volume changes. We do acquire some spinal cord data if you have a dedicated spinal cord imaging study of the cervical or thoracic spine. And then you receive a general opinion with respect to brain volumes. And at times there's an SWI that's performed that, or a flare star under certain circumstances that may allow for additional information to be provided to the healthcare practitioner that placed the order. Now, I wanted to spend a little bit of time on the impact of perspective, because I think this part is really key as we start to talk about lesions themselves, especially if we want to select them for further study, or even to select them using a computerized tool versus the human eye, or both combined. So the limiting feature of imaging, at least here in our nation, is that we only acquire 3 planes of view. So a sagittal view, a coronal view, and an axial view. And this is the same within the spinal cord and the brain. And so these 3 views may be limiting because we're somewhat providing, or imaging is providing, a forced perspective view for viewers. And that may not necessarily give us all of the information that we really should have. Now, we've somewhat tried to improve upon this by increasing magnetic field strength. So if you improve magnetic field strength, of course, you can get better clarity. It's a higher fidelity metric with respect to what's going on in the brain, but still you're limited by the views that are being provided. I'd like to show this video just for a second, and it's from an artist here in the United States from Brooklyn named Michael Murphy. So I've received permission to actually show this video. And this is a piece called The Immigrant, and it's actually an image of Michael's wife. And the piece itself was really to celebrate the number of great things that immigrants have done here in the United States. And what's fascinating about Michael's work, and if you ever have a chance, please visit his website. He's done work partnered with a number of different agencies that are well known, but you really can't get a full appreciation of what you're seeing unless your eyes are placed in a certain perspective. And this is somewhat my philosophy when it comes to MRI scans. I think that the information we're getting is not complete, and I think our eyes can fool us easily. So I'll show you a photo of 2 tables, and the task here is to tell me which table is the larger table. And this is a visual task that is centered around a given size estimate. And so I would say, well, obviously it's a table on the left. And that tends to be the answer by many. But what you then realize if you, and I've created this video to demonstrate to you that the surfaces are actually exactly the same size. Your eyes are just being fooled by what you see based on the surrounding structures. So is it an elongated lesion? Hard to know. It may be just dependent upon what's around it and what's tied to it. Now, in MR imaging, we live in a world of shades, right? 50 shades, 100 shades, 1,000 shades. And here you see a gray bar in the center of a gradient. And the task is to provide an answer as to whether or not the gray bar is solid in its shading or uniform. So it looks as if there's a gradient there. If you look closely though, without the background, you'll find that there's actually no shading of that center bar. It is just uniformly gray. Now, to provide a more dynamic example of that, here is a video from Dr. Adelson at MIT. And long ago, I had collaborated with him in exploring a variety of things that he's well classified as being reflectance, luminance, and how light plays or how an object is illuminated with respect to other objects. And And here in the left panel, I'll show you a couple of things. This edge here, if I were to tell you that this edge here is the same shade of gray as this edge, you may or may not agree with me, and that may not be super striking. But what if I told you A here on the bottom was the same shade of gray as B? I think you'd have a more difficult time actually believing that that was true. So here it is in real time. It's not a camera trick at all, but it shows you how different aspects of light, how shades surrounding an area of interest can actually be heavily impacted by, or at least our eyes' interpretation of what we're seeing can be heavily impacted by light, by shades around it, even colors around it. So human beings are not great at somewhat deciphering different shades. We're really great at shapes. And if we were, say, individuals from a long time ago, seeing an animal on the horizon that may represent food for a tribe or a group may be more important than the shade of that animal. So humans are really great at looking at shades and not shapes. I'm sorry, shapes and not shades. Now, why is this important? Well, you see a dozen lesions here from a dozen patients with a variety of disorders. And if you're interested in the study of this, or if you have an automated segmentation technique and everyone seems to have their own great version of it, what is the appropriate selection of a given lesion? That can vary based on the technique that you're using. And if you're using the human eye, there needs to be caution just based on the data that I've shown you, because our eyes can be heavily influenced by a variety of things, light around it, shades around it, etc. So now it's been 6 years ago since we actually did this. And this is a slide that was prepared 6 years ago, focusing on a single lesion from a patient with MS in my practice. And back in the day, I asked the question, and the question was, what is the exact shape of the lesion? Do we know anything about it? And if you were to take the 3 planes of view that's constricted, that I'm providing to you, that's a forced perspective view, what is a shape that you think would be related to that lesion, or what's the lesion's exact shape? Very few come up with this lesion shape here. And on the far left, you see a maximum intensity projection, one of our old somewhat improvised solutions or hacks in terms of isolating a lesion in its exact true form. So actually editing in 3D, we developed software back in the day that can edit in 3D rather than editing in 2 dimensions and reassimilating slices. So a very different approach to say how I did it when I was in fellowship back in San Francisco a long time ago. And we actually embarked on a study that focused on shapes. So using a method, spherical harmonics, that's well known for allowing for the comparison of different shapes to a reference structure. And now this is 6 years ago, looking at machine learning platform that aims to differentiate multiple sclerosis from small vessel disease lesions, and came up with a variety of models, support vector machine, linear regression, and the like. And back in the day, it wasn't as accurate as we would like it to be. And we were really uncertain as to why, because we thought, boy, you know, the shapes that we see in people with migraine, headache, T2 hyperintensities, and age-related changes, they just seem very different than those with MS. Why would the system only perform at this level? And there are a variety of reasons for that, and some of them actually involve bias and the complexities of machine learning, as well as segmentation. So this concept of 3-dimensional conformational metrics is one that centers around shape, surface texture, structure. So Stan Prusner, a Nobel laureate who studied prion disease early on, looked at the structure of prion that was pathogenic and prions that weren't pathogenic, and actually did not identify a different structural difference between those 2 groups. When he studied the 3D conformational characteristics of the prion between groups, there is a striking difference. And so this is the approach that's being taken. It seems to be complementary to what we have, and it definitely can provide much more information that, sure, extends beyond just the diagnostic capabilities. And what's really beautiful about it is you can study historic MRI data if it's been acquired in 3D format. So everything that you'll see here is based off for the most part, a 3D MP RAGE that's commonly acquired during all clinical trials. And it's something that's even acquired, at least in our center, clinically in all patients. And it may provide information that's very distinct. It may inform on regions of susceptibility that you may not have appreciated before. So a structure may be changing in volume, and you can see where it's changing in volume, which is great. And so it may provide a number of pieces of information with respect to how tissue is changing that can be helpful if you're trying to define progression, stability, or even improvement if a reparative drug is being used. So you'll see you'll see data related to all of this here. I'll just provide a little bit information with respect to tissue compliance. And so one of the things that we embarked on was, so you have a structure, does it affect physiology around it? And using cerebral blood flow, BOLD, as well as CMRO2, we looked at surrounding structures of a brain lesion. And this really helped to inform on why our earlier machine learning models and systems failed. So lesions are interesting in that they actually tell a story. And tissue surrounding the lesion, and here you see perimeters that extend beyond a three-dimensional lesion. And we studied the physiology within those perimeters. And the farther you get out, of course, you see less physiological activity. The BOLD signal is different, more so when it's closer to the lesion, but also it's really influenced by lesion type. So when MS lesions first form, they actually are very ovoid. They're similar to a grape, but different in that the surface textures are very coarse. So they're similar to a lemon drop. And then over time, they somewhat turn into a raisin. And so if you're trying to do an AI, if you're trying to design an AI platform and you're looking at structure, well, if you include a number of younger patients with newer lesions, you'll see shapes that are more similar to nonspecific white matter disease, just because those lesions haven't had time to transform from a grape to a raisin. So that was one of the very early learnings that happened about a year and a half after our initial work. More recently, we've looked at how lesions actually transition. So you see MRI images from a single patient at 2 time points, and we're going to focus on one central lesion here. This was read by our neuroradiologist as being stable. The imaging studies, the time distance between them is over a year. So gold mesh here in this 3D model is the first time point. Solid blue is the second time point. So over time, for that particular lesion, what you can actually see here is deformation and displacement. So the lesion actually has gone down in volume a little bit. It's also shifted with respect to where it was originally. And that's very different when you compare that to a person with nonspecific white matter disease, where the opposite tends to occur. In solid gold, here is the first MRI time point. Neon mesh in green, teal mesh is time point 2. So it seems to grow pretty uniformly outward, similar to having a given cornfield that's starved of its water. It's going to dry from the center, extending out, and that's consistent with the pathophysiology of small vessel disease, microvascular disease, nonspecific white matter disease, etc. Now, what's interesting about MS lesions is there's a tremendous amount of heterogeneity. Not all lesions actually get larger. Not all lesions actually get smaller. And so we may be making a mistake when we're looking at enlarging T2 lesions, because what we should really be looking at is, okay, which lesions are getting smaller based on the defined criteria for a lesion getting larger. So if your definition is 30% increase in volume, well, what lesions actually reduced by 30% as well for that given patient? So there's a number of effects that are going on well beyond, this hydration shift pseudoatrophy. We've studied people extending out now for 6 years, studying the patterns of change, and we are about to release our most latest work coming up. Now, a few years ago, I think a couple of years ago, we started to look at the brain stem because it's really stable. You can get that area from an MP RAGE, so from a brain MRI scan. You don't need to do a dedicated cervical spinal cord MRI scan. It's not super prone to movement. It is just a little, but not so, as much as the spinal cord. And it's a very attractive place in allowing us to learn more about the impact of disease and how our treatments may actually be helping or not. So this is a pilot study that we embarked on, looking at those who are African American in comparison to those who are white, all with EDSS scores of 0. So everyone was functional. We had marathon runners in the African American group, along with the white MS group. And our goal was to just study the tissue in a very objective way. And we created a number of metrics. And what you see here are MRI data from a single patient that represents composite volume change over time in a 3D conformational way. So at the first MRI time point, you'll see that the ventral surface here is red. Ventral surface is blue at time point 2. So the composite image on the right, whenever you see a red mesh, it actually indicates that tissue underneath that has gone down from the second time point as compared to the first time point. And you would apply the same logic to the dorsal aspect of the medulla upper cervical spinal cord. So you get information about, we can get information about the brainstem, but also the upper cervical spinal cord as well. And there's a massive difference with respect to volume. And there's even a massive difference with respect to compliance. And so when individuals talk about pseudoatrophy, et cetera, you can have hydration shifts and volume can change. What we do see in African Americans is you don't see much of that shift over time. It tends to stay more taut. The tissue just seems to be more taut for some odd reason. And it could be microstructural scarring. We don't know yet, but that's just an observation that we've actually seen. And so there are massive differences with respect to volume changes, both ventrally and dorsally for African Americans in comparison to what you can actually measure texture as well, and to study how tissue transforms over time. And I think what's most fascinating here is that the dorsal aspect of the medulla upper cervical spinal cord was different between African Americans and whites, but not the ventral side. So it may suggest that there is susceptibility there amongst those who are non-white. And we've expanded upon this study, and it's about to be submitted in a much larger cohort. And the goal is to try to identify if 3D conformational metrics can outperform other measures. Can it outperform volume measures? And here is a spaghetti plot just showing you how the dorsal complexity measures actually were much more robust than total lesion volume. We have other works where we've looked at cortical gray, thalamic atrophy, et cetera. You'll see more of that as we move forward. So real briefly after over the next couple of minutes, I wanted to talk about lesion dynamics and our latest approach, which is centered around somewhat studying in a very coarse GPS-like way how lesions move over time, and is there value there? Does it inform on something? I can't show you the results, but I can show you the images here. There may be differences with respect to lesions over time in multiple sclerosis when they're getting larger as opposed to when they're getting smaller. So when MS lesions, as opposed to other lesion types, specifically small vessel disease, when they get larger, where they move in the central nervous system may be very different than those with small vessel disease. Along that same wavelength, when they get smaller, the opposite may occur. So there are differences with respect to lesion behavior based on disease origin. And it likely lens to its original pathophysiology. That's likely what explains all of this. Now, here's, going back to one of the earlier slides I showed you, where you saw the relevance of T2 hyperintensities and the relevance of T1 hypointensities. Well, what's the relationship of those two? And this is early work that we've done. We've since added contrast enhancement in the right setting. But what's fascinating is to study the evolution of these changes over time. Obviously, the blue mesh here is the T2 hyperintensity, and you can see how the T1 hypointensity may change over time. This is in small vessel disease, and these transformations appear very different than if you look at someone with multiple sclerosis. So this is a composite 3D model combining T1 and T2 changes over time in one measure, and you can actually see how displacement deformation has occurred. You've taken out the water content in there. There's been some micro transformational shifts in structure. So this may be an alternate way that's very easily implemented in clinic, provides the healthcare practitioner with more information than what we're getting now. So going back to our original image that I showed you, there's really a lot more that this lesion can tell us than what we see in clinic in everyday practice. And that's the hope and the goal of what we're doing in our 3D conformational metrics effort. So it adds value to conventional data. We can go back historically and identify benefits that may have been missed. We can model multiple time points, which is beautiful. It does seem to inform on selective regions of vulnerability with respect to tissue. And I think it's going to prove itself to be even more valuable over time. It's really helped our patients in our clinic as we've counseled them, because we show them all the prototypes of how their lesions have gone down in size over time in the presence of highly effective treatment. And it's always comforting to tell patients, no, your MRI is not just stable. There are a number of lesions that actually have gone down in size. So rather than telling them that they have one new lesion, how about we also provide them with information that the other 16 have actually gone down in volume? I think that would be very beautiful. So a number of people for me to thank, more so than what I have time for. But thank you very much for your attention. It's now 4 o'clock here in Texas. I hope that was partially coherent. So, but thank you very much. I appreciate the invitation, and I appreciate your time today. Thank you.
Yeah. Thank you, Professor Okuda. It's a very innovative talk. Actually, it made everyone to think ahead. Actually, I think the two talks, both talks gave us new perspectives. Maybe we do have some questions to answer. Anybody want to ask?
Go to Mike. Can I ask a question from Mike, please? Yeah, regarding the optic nerve imaging, now in your lecture you said that optic nerve is not included in the standard protocol. Is that what you meant?
I'm sorry, I didn't get your question. So could you?
Yeah, we do optic nerve routine imaging in standard protocol of MS. I heard that you in your lecture that optic nerves are not routinely required to include in the imaging. Is it what you meant, or?
I'm sorry, I did not understand you correctly. Yeah. So did you ask something about the gadolinium?
Yeah, optic nerve, please. Optic nerve imaging.
Darin, did you hear it?
I think, is it optic nerve? Is it optic nerve imaging?
Yeah. Optic nerve imaging in the standard MS protocol.
Okay.
Okay.
Because you're asking why it's not in the standard protocol.
Yeah.
So that's a very good question. So So first of all, the added value of detecting optic nerve lesions in order to establish the diagnosis of MS is quite low. So optic nerve lesions are not part of the diagnostic criteria. They are not used for demonstrating active inflammatory disease activity. So therefore there's no crucial need in terms of establishing the diagnosis or to establish or to demonstrate treatment efficacy to perform optic nerve MR. So there are certain indications when it can be useful, and one situation is the lesion differentiation or the disease differentiation. So the situation whether you're dealing with an MS patient and a MOGAD patient or an NMOSD patient. So this is a classic clinical situation where optic nerve imaging is desperately needed, because we know that the MOGAD optic neuritis is a completely different one compared to the MS, with more perioptic inflammation entering the perioptical fat. We know that NMOSD has more, optic chiasm involvement compared to MS. So this is a very important indication to use optic nerve imaging. But for and there are certain clinical presentations like atypical optic neuritis. And these situations, optic nerve imaging might be useful. For the rest, it's not recommended, and it would also increase dramatically the acquisition time. A good optic nerve protocol will require 50 minutes of time. So if you would do this on a regular basis, the image acquisition time would increase dramatically in clinical practice. So therefore, this is another, I think, good argument not to recommend optic nerve imaging on a regular basis.
Okay, thank you very much. We have another question from Dr. Binsara.
Mike, can I ask you why you don't advocate contrast imaging at 3 months and 6 months in MS?
Why not to do a contrast?
Yeah.
So in terms of establishing the diagnosis, you don't need contrast anymore, because a typical situation is you have a baseline MR and you can demonstrate dissemination in space, but you don't see any contrast enhancing lesions. So you are not able to establish the diagnosis of MS because of lacking dissemination in time. So therefore, you need a second clinical attack or a new lesion on brain or spinal cord. But there's no requirement that this lesion has to enhance. So therefore, the demonstration of an active T2 lesion, this means a new T2 lesion, is sufficient to demonstrate dissemination in time. So therefore, you don't need contrast to establish the diagnosis. Another question could be whether or not we should perform additional spinal cord to demonstrate dissemination in time. But the frequency of asymptomatic spinal cord lesions in the early disease course to establish the diagnosis is extremely low. So therefore, this is also an argument to exclusively focus on brain imaging to establish the diagnosis in terms of dissemination in time, and not on spinal cord.
Okay, thank you very much. That concludes the symposium on neuroimaging. I would like to thank both speakers, Dr. Mike Wattjes and Dr. Darin Okuda, for that comprehensive 2 lectures and updating us on MS imaging. So thank you very much again.
Thank you.
Thank you.
Yeah, the next program will be on difficult cases on demyelination, and let me invite as chairpersons Prof Kazuo Fujihara, Dr. Isabel Leite, and Prof Sudarshani Ramanathan.
Right. We have two presenters from Sri Lanka, Dr. Udari Samanasi and Dr. Dunya Lu. And then Japanese cases will be presented by Professor Fujihara. So we'll start with the Sri Lankan cases. I would like to call upon Udari to start presenting the first case.
Good afternoon. I'm Dr. Udari Samanasi, Senior Registrar in Neurology attached to Institute of Neurology, National Hospital of Sri Lanka. First of all, I would like to thank Dr. Bimsel Senanayake, my mentor, for giving me this opportunity to speak at the Congress. So this patient is Mr. A, a 24-year-old previously healthy male. So he was apparently well until April last year, 2021, where he had a subacute onset painless bilateral visual blurring, which was spontaneously resolved over 1 month duration, and it was not attended to. And a month later, in May, he had an episode of left hand numbness, which lasted for 2 weeks. And again, that resolved spontaneously. So a month later, this was the first time he attended to a practitioner with a left hemisensory loss with painful spasm, which lasting around 1 minute and left facial twitching. And at the same time, he had unsteadiness of gait with dysarthria. And this was associated with low mood as well. There was no seizure activity. So on examination, the patient had a GCS of 15/15, a left anesthesia, hemiparesis with a power of -4/5 with right-sided cerebral signs. And that time, an MRI brain was performed, which showed T2 flare hyperintensities with T1 hypointensities, mainly involving the bilateral medial aspect of temporal lobes, involving the amygdala hippocampal regions around the inferior horn of the lateral ventricle. And it is asymmetrically distributed. And apart from that, there was involvement of the right corona radiata, which was it was a confluent lesion actually, going into the posterior rim of the internal capsule on the same side and involving the right cerebral peduncle as well, and up to the pons. It showed diffusion restriction, and that was non-contrast enhancing. This was reported as possible autoimmune or limbic encephalitis by the radiologist. So with this was the investigation summary. So the full blood count, inflammatory markers were normal. And the CSF analysis, the protein was 18 with no cells and sugars were normal and the EG was normal. And because of this reporting as possible encephalitis, we did the serum autoimmune antibody panel, which was again negative. And that time CSF oligoclonal bands are also negative. AMA was negative, and also because the patient had a mild upper respiratory illness before the onset of these neurological events. So, and anyway, because of the prevalence, we did the COVID rapid antigen test and the PCR were negative, as well as the viral markers, the CMV IgM, the EBV IgM, HSV PCR, and the virus screener was negative. This episode is managed with IV methylprednisolone pulse therapy for 5 days, followed by oral prednisolone low dose, and this was accompanied with the partial recovery of the symptoms. And then again, a month later, he again came with worsening dysarthria, ataxia, and again left-sided hand clumsiness. This time the MRI brain showed in addition to the previous lesions, a new T2 hyperintensity lesion in the right dentate nucleus of the cerebellum near the fourth ventricle. And also there was contrast enhancement this time in the pontine and cerebral lesions, suggestive of disease progression. And the investigations were repeated. So again, the full blood count, the inflammatory markers were normal. This time, CSF revealed protein of 25, but with very high lymphocyte count, 100 per high power field, with normal sugars. And this time, the CSF oligoclonal bands came as positive, with 1 to 3 bands with IgG index of 0.7. And that time, the serum AQP4 antibody and the serum anti-MOG antibodies were negative. The VEPs were normal, although there was a history of the visual blurring, and the perimetries were again normal. And because of this high lymphocyte count, we did the TB PCR, critical antigen, as well as the fungal studies, which were negative. So this episode was managed again with high-dose IV methylprednisolone pulsing for 5 days, followed by oral steroids, again with partial recovery. Because of this CSF oligoclonal bands becoming positive, our team decided to initiate him on IV beta interferon 44 micrograms twice weekly regime. With this, he came again after 2 weeks with worsening symptoms and a new onset right abducing nerve palsy, as well as a right-sided intranuclear ophthalmic region. This time, the MRI brain showed, in addition to the previous lesions, a new lesion in the pons on the midline, adjacent to the fourth ventricle, extending inferior to the right medulla, and partial resolution of the contrast enhancement and diffusion restriction, which was there previously. And this time, the spinal cord imaging was also performed, which is normal. And we repeated the NMO screen, which revealed a negative AQP4 antibody, but the serum anti-MOG antibodies became positive in a low titer of 1 in 10. And this time, we managed him again with high-dose IV methylprednisolone pulsing, followed by IV rituximab, 500 milligrams, as a second-line induction therapy. Now, actually, we discontinued the IM beta interferon because of this MOG antibody positivity. And again, he had partial recovery of the symptoms. I would like to go through the MRIs in detail. This is the FLAIR images, the axial views. You can appreciate the right coronary data and the posterior limb of the internal capsular involvement, as well as which extends to the right middle, cerebral peduncle, as well as the pons, and the upper medulla. And that's right the cerebral dentate nucleus involvement as well. This is the coronal section, just for the better appreciation of the lesion. This is the T1 images. So to summarize, the patient had 6 clinical events. So the final, actually after the IV rituximab first dose, again he presented 2 weeks afterwards with again worsening gait unsteadiness with recurrence of the right 6th cranial nerve palsy, which resolved previously, and also new onset dysarthria and dysphagia. This time again we had to pulse him, and anyway we thought of, after discussion, continuing on the IV rituximab therapy. The patient actually responded well to this treatment, and currently the patient is relapse-free after that episode, and there was no residual deficits with the EDSS score of 0. And the patient is currently on steroids, low-dose steroids, as well as isotretinoin maintenance. The repeat MRI brain done on October showed no new lesions, and regression of the plaque sizes was also noted. And all the lesions were non-contrast enhancing. So with this, our problems in this case was, firstly, what's the diagnosis? Initially, we thought that this relapsing remitting MS, because there was oligoclonal band positivity and disseminating in time and space, although the lesions were not typical of MS. And there was an INO as well at one point. But this anti-MOG antibody positivity cannot be explained. We know that in pediatric population, this can coexist, but in adults, is it possible? And the other thing, whether this antibody titer have a bearing, because it was a low titer to begin with. And the next possibility was the MOGAD. So, because there was antibody positivity, and also there was high CSF lymphocytosis. But I wanted to ask from our panel whether these brain lesions are characteristic, and there was at any point there was no involvement of optic nerves or the spine. And other possibility was the seronegative AQP4 disease. If you go to the IPND criteria, whether these core features, the acute brainstem syndrome and the symptomatic cerebral syndrome with NMOSD-specific lesions, such as corticospinal tract involvement, as in this case, and also there was right side optic tract involvement as well. But there was no demonstrable optic nerve lesions like VPs were normal, perimeter was normal, and there was no spinal lesions. And this cortical lesion in the temporal lobe, whether that can be explained. Some other problem was the initial presentation. So it was reported as an encephalitis. So this actually we came across this in the previous lecture. So the prevalence of cortical lesions in the CNS inflammatory demyelinating disorders. That is again, I would like to open the discussion case for the discussion from the expert panel.
Thank you very much, Darin. I think we'll ask Professor Fujihara to comment on this case.
Okay, me now?
Yeah, we can hear you.
Oh, okay. Well, I may not understand fully the details of the cases, but one point I should mention might be that, so did you measure the MOG at Mayo?
Yes.
So, so 1 to 10 seems to be low positive, right?
Low positive, yeah.
Yeah, low positive.
And then compared to the high positive, like 1 to 1,000 or greater, you have to think about the possibility of false positive results. So I did not I was not able to see the details of the MRI, brain MRI lesions, but compared to the typical MOG cases, do you think your patient had what typical MOG lesions?
There were confirmed lesions involving the right corticospinal tracts, starting from the coronal radiator down to the pons medulla level. And the lesions were sort of fluffy, so maybe MOGAD. And also there was temporal horn involvement in the like inferior, like horn of the lateral ventricle area. So that is also described with MOGADs.
I see. Well, fortunately, Professor Darin Okuda is still joining us. Darin, are you there?
Hey, Kazuo, how are you? I'm still here.
Good, thanks. I'm putting you in a hot seat, but any comment on the MRI findings from your perspective?
It does look atypical. When I look at it, it doesn't seem typical of what we see in MOGAD or what we see in multiple sclerosis as well. It has an ominous type of presentation in the brainstem as well, which is somewhat concerning. Perhaps there could be something learned by the treatment response that seemed to have been positive. The titer does seem low, and it's tough. It's tough at times. We don't know where we're catching it on the spectrum. You know, we've seen MOG titers that are, we've collected data for some odd reason. I think earlier in our clinic, there was a belief that it could be used as a means to track success when we're treating patients. And so some of our colleagues have gotten it 5 or 6 times. And so we've seen the key inflection point and have it, you know, come down afterwards. And when you have a view of something that's less than 1 to 100, you know, if you only had that, you may have a different opinion when in fact history has told you that it was much higher previously. But the MRI images are they look different.
Well, thank you very much.
Please
stay in this session.
I will.
I will rely on you. Okay, don't go away. But thank you very much for your comments.
Kazuo, as for a diagnosis in this case, are we to consider this as a MOGAD and treat as such?
Well, well, at this point, I will be reluctant to make a final diagnosis of MOGAD with relatively low antibody titers. But there are MOGAD cases with low antibody titers. So if they have what typical features which are of MOGAD, which are different from MS, well, you may be able to make a diagnosis. But at this point, as Darin mentioned, I'm reluctant to make a definite diagnosis of MOGAD in this case. But I might have missed some part of her presentation, but rituximab has been successful?
Yes, it has been successful in this case. And also, initially, as mentioned, he was treated with beta interferon, which worsened the condition because of the oligoclonal bands and the absence of MOG positivity initially. So that also perhaps indicates that it's unlikely to be MS anyway. But yeah, so anyway, to rituximab, he has responded.
Well, as for the efficacy of rituximab in MOGAD cases, overall, there's a reduction of relapse rate after the treatment is initiated. But I think it was already mentioned in a previous session, but unlike aquaporin 5 Gg positive NMOSD, maybe 60 to 70% of the MOGAD patients who have been treated with rituximab did have relapse, even if the B cells are relatively completely depleted. So, but your patient responded so far quite well to rituximab. We cannot make a final diagnosis of MOGAD at this point. I may be conservative, but yeah, that's my view. Thank you.
Prof. Fujihara, now a case like this, now it doesn't fall into any diagnosis, but clearly there is an inflammatory flavor to it. There are multifocal at different time points and demyelinating sort of inflammatory condition, but we cannot label it. In your experience, you must be seeing many of these patients, and the fact that the patient has responded to rituximab, clearly an inflammatory CNS disease. Do you keep those patients on follow-up to make a diagnosis later? How would you classify them in the interim until you make a diagnosis? How would you follow up these patients on what basis? Because at this point I feel that we are lost for a label to give him, but can we keep open diagnosis like a CNS inflammatory disease and then see how he evolves?
Well, based on my previous experience, to make a distinction between MOGAD and MS, as we previously reported, CSF cytokine profile, acute phase of MOGAD and MS are very different. In MOGAD and AQP4 positive NMOSD, or IL-6, IL-8, and other Th17 related cytokines are very much upregulated. But in MS, compared to those two autoantibody-mediated CNS inflammatory disorders, the levels are very low. So if you have CSF that were collected before the acute phase treatment, that may provide a clue for the diagnosis from the viewpoint of cytokine profiles.
Okay, thank you. Any comments from the...
Do we have an impression that if OCBs are positive, it's unlikely to be NMOG positive?
No, some of them, about, as mentioned earlier in the talk, about 5 to 20% of MOGADs will have oligoclonal bands in the CSF. So I think we can move on to the second case. We'd like to thank Udari for presenting that case.
Thank you
very much. Now I call upon Dr. Dunya Lu to present the second case.
So good evening, everyone. Yeah. So we are going to discuss about another patient whom we encountered during the last year. So I'll move on to my case. This patient is a 34-year-old mother of two who was previously healthy with no other comorbidities. And she presented with a history of sudden onset right side arm leg weakness upon waking up. So kind of a wake up weakness. She was perfectly all right when she was going to bed the previous night at about 10 p.m. So, and there was no mouth deviation or slurred speech, and there was no preceding history of fever, head trauma, history of encephalitis or seizures, or history suggestive of any infection. So upon admission to the initial presentation was to a peripheral hospital where she was evaluated. So these were the examination findings at that time. She was afebrile. GCS was 15 out of 15, and there was a mild weakness in the right upper and lower limbs with a power of 4, and there was an upgoing plant in the right side, and there were no other focal neurological signs, and the fundi were recorded as no papilledema. So they have done the basic investigations, including the serology, initial full blood count, inflammatory markers, which were normal, and they went ahead with the NCCT, which was normal. So she was managed as for a young stroke, and planned on further evaluation as for a young stroke. She was sent home after planning all these evaluation, and 2 days after, she developed gradual worsening of the right side weakness, and then where she presented to the hospital again. So there the powers were noted to be worsened with upper limb power of 3 and a lower limb power of 4. And at this time, she was transferred to a tertiary care hospital for further evaluation and further imaging. So upon presentation to our hospital, the tertiary care center, she had sudden onset complete loss of bilateral vision and gradually worsening weakness, and developed slurred speech with mouth deviation, but there was no encephalitis and there were no seizures. And she had some numbness involving the left upper limb as well. So this was rapidly progressive, now going bilaterally and with visual involvement. So examination, again GCS was normal, and now the powers were 0, upper limb and lower limb powers were 0 with brisk reflexes bilaterally and bilateral upgoing planters. And the cranial nerve examination wise, vision had a light perception only, but pupils were bilateral reactive with no RAPD, and there was no papillitis. The fundi were normal, and apart from the right side upper motor neuron type facial nerve palsy, rest of the cranial nerve examination was normal, and there were no cerebellar signs. So this was the initial MRI. Actually, she was initially sent to a surgical ward after seeing this MRI. So referred from a medical ward to a surgical ward. So they were trying to go ahead with biopsy with this MRI appearance. So these are the contrast images. So the problems we identified when she presented to us was this progressive right side phase arm neck weakness, and with this MRI appearance. And with this appearance, we thought whether it could be a atypical CNS demyelination which was rapidly progressive, and whether it could be a CNS infection, or whether CNS tumors, that it could be a high-grade glioma or a lymphoma. So with the bilateral visual impairment with normal fundi and with reactive pupils, we were thinking whether it could be optic neuritis, or whether it was extensive involvement of the optic radiation or beyond which caused these symptoms. So with the initial MRI appearance, the radiological diagnosis was given very T2 hyperintensities bilaterally, periventricular and juxtacortical. So they would think which was non-specific at that time. So the DDs they had given was ADEM, atypical infection, MS variant, high-grade glioma, or a CNS lymphoma. The risk is huge. So then upon presentation to us, so this was the initial MRI which was first done. So these were serial MRIs after treatment. So these are the contrast images. So initially there were bilateral T2 hyperintensities, as you can appreciate, involving the periventricular, and juxtacortical involvement was there, and there was a brainstem involvement also with the cerebellar peduncle, left cerebellar peduncle involvement at the presentation. So then we have pulsed actually. The second MRI is after pulsing, where you can see some cavitation with periphery T2 hyperintensities, and the lesions, there were no new lesions, and the same lesions were evolving. And serial MRIs showed resolution with time. So initially there was a peripheral contrast ring enhancement in the first MRI, as you can appreciate, and then the lesions resolve with treatment. So this was the MRS where it had a choline peak with slightly low NAA. So the choline to NAA ratio was high, but not very significantly as for a high-grade glioma. So this was the extensive MRI reporting. There are multiple confluent areas with T1 low and T2 high signal intensities in the deep and periventricular white matter involving the right frontal, parietal, temporal, occipital, and genuine splenium of the corpus callosum, and the right middle cerebellar peduncle, pons, left temporal, parietal, and occipital lobes were also involved. And lesions showed new development of multiple areas of suppressed FREA signals with surrounding high signals suggestive of cavitation. And there was a curvilinear ring enhancement, ring restricted diffusion seen in the largest lesion in the left parietal lobe with high DWI and low ADC. And as I already mentioned, there was a ring enhancement in the cavitating lesion in the affected areas. So, as I said, there was a choline peak and reduced NAA. So the impression with the second and third MRIs were persistent disseminated confluent white matter lesions with ring enhancement and perlesion and edema without interval change of the number of lesions, but with new development of multiple areas of cavitation within the lesions. So they suspected whether it could be a post-infective, tumor-infective MS or Marburg variant of MS. So we did the investigations, and the basic investigations, including the bloods and the CSF was normal. CSF OCB was positive with 1 to 3 bands. VEP, initially it was done a bit delayed actually after treating, so it was normal. AQF-B4 and MOG antibodies were negative, and ANA, DSDNA and CUS were negative, and rest of the infection screening, we did extensive screening was negative, and later OCT was normal. So these were her visual field mappings. So initially we managed her with, when she presented to us with the second MRI, we managed her with IV methylprednisolone pulses, to which she had a rapid improvement. The vision improved dramatically, and we have done the therapeutic plasma exchange every other day, 7 cycles, where the limb weakness improved, and actually she was able to stand and walk with support. And then we referred her to physiotherapy and rehabilitation, and we repeated the imaging to closely follow up to decide on the need for brain biopsy for the treatment, or whether we should introduce DMARDs on her. So I would like to open the case for discussion, because initially when she presented to us, we were in a dilemma, because the surgical team wanted to go ahead with the biopsy, and we were also considering whether we should go ahead with the biopsy upon the first presentation. Now, looking retrospectively, since she responded to treatment, it might be really we can look at it retrospectively, but when we got this patient first, we were in a dilemma as to how to come to a particular diagnosis. So I would like to open this case for discussion. Over to you, sir.
Yeah, thank you very much, Dunne. And Kazuo, we would like to hear you on this. While we wait for Professor Fujihara, I think.
You hear me now?
We can hear you now. Yes, go ahead.
Well, connection may not be so good, but so there are multiple large cerebral and other regions, and the tentative diagnosis of tumor-factive demyelinating and disease may be made because she definitely responded to high-dose corticosteroid and plasma exchange. But the cavitation was seen in some of the lesions, and so yeah, this may not be what typical tumor-factive demyelinating lesions, and we have encountered such lesions which are different from the just ordinary inflammatory demyelinating tumefactive lesions. In some of our cases, based on the biopsy findings, not just simple demyelination, some lesions are necrotic and astrocytes were destroyed, although aquaporin 5 IgG was negative. So, in a category of so-called tumefactive demyelinating lesions, there may be some subgroups that we may not fully understand the pathogenesis and pathophysiology of. So this may be such kind of case. That's my view. Darin, could you help me?
So great presentation. I agree. There's a tremendous amount of heterogeneity within the lesions itself, and it looks very aggressive. And it's tough to know if the radiologic appearance is very consistent with what was described back circa 1912 when we talked about Marburg variant of MS. GFAP, astrocytopathy, came to mind, and I'm wondering if a GFAP level was acquired at some point. Just from the earlier pictures, it looks as if the targets are very consistent with what we see in CNS demyelination, which is in part comforting. The other comment I forgot to add to the first example that was presented tonight was, I think that the first case that we saw, that patient was quite young, I think, and I did see a lot of general atrophy present in the brain, not so much for the second experience presented here, but yeah, I think it's more along the spectrum of what we see in our clinic. Oh, Kazuo can't hear.
Can you hear me now?
Yes.
Okay. So in the US, if you encounter this kind of case, do you recommend brain biopsy before moving further in terms of diagnosis and treatment? What's the situation of brain biopsy in this kind of patients in the US?
So fantastic question. Part of the answer is it depends on who you ask. It's like asking a barber if you need a haircut. If you ask a neurosurgeon, what should we do? It'll always be biopsy. So I think history has provided some degree of context where many of these are tumefactive demyelinating, and I think there was more of a push towards more conservative management initially, just to ensure that the medical efforts have not worked before they've gone to biopsy. Primary tumor seems not likely here just because you have multiple large lesions present simultaneously. So I think if and one thing that a question I had was there sustained contrast enhancement over time, because that's always a red flag. And if medical management is unsuccessful, then brain biopsy would be pursued for that patient, just to better characterize what may be going on. So the threshold, Kazuo, is very low here, and it's really region and hospital dependent as well. If you are in an institution that is governed by neurosurgeons, within a very short period of time, a stereotactic biopsy would be performed.
When I visited the Mayo Clinic, and Professor Claudio Lucinetti told me that, well, we have 6,000 brain biopsy cases, and it's beyond our imagination. So probably, as you said, the threshold there was quite low to make a neuropathological diagnosis of those lesions. That was my surprise.
That's very high.
Well, thank you very much.
Thank you.
Back to you, Bim. And
Yeah, thank you so much, both Darin and Kazuo, for those comments, and I would like to thank Dunya for an excellent presentation. We now move on to a Japanese case presented by Professor Fujihara.
Okay.
Thank you.
Thank you very much. Can you still hear me now?
Yeah, can hear you.
Okay. Okay. So let me share my slide. So I will present two cases. Case one is a 44-year-old. Case one is 44-year-old man who had aphasia 5 years after brainstem encephalitis. So this is the history of the first event. The chief complaint was diplopia and unsteady gait. So about 6 years ago, he developed a headache acutely, followed by insomnia, unsteady gait, dysarthria, fatigue, diplopia, and dysphagia. Past medical history and family history were not contributory. General physical examination revealed a bit high blood pressure, tachycardia, a bit tachypnea, and in neurological examination, diplopia, horizontal nystagmus on lateral gaze, dysarthria, and unsteady gait were seen. So it seems that the brainstem dysfunction occurred in this patient. That lab data and MRI in CSF examination, mild pleocytosis, predominantly mononuclear cells, and the protein level was a bit high, but the IgG index was normal. And as for brain MRI, as you see here, multiple brainstem lesions, but cerebral lesions were not seen at all. And at that point, the brainstem encephalitis, the diagnosis of brainstem encephalitis was made, and he was hospitalized for 2 weeks, and he was treated with IV methylprednisolone, and the symptoms resolved. And then oral prednisolone was gradually tapered and eventually tapered off. Now let me talk about the second event. 5 years later, so March 2021, he acutely became unable to understand the meaning of words. And the neuropsychological examination revealed moderate word finding difficulty, phonemic and verbal paraphasia, difficult to recall kanji. Kanji is Chinese characters in Japanese language. And our neuropsychologist's conclusion was that he suffered mild fluent aphasia. But this time, brain MRI was completely normal. No cerebral or brainstem lesions at all. But as for CSF, again, the cell counts were a bit higher, and protein levels are a bit high, but IgG index was normal. And he was, again, hospitalized and treated with high-dose methylprednisolone, and the symptoms resolved. At that point, he was referred to me, and then I tested MOG IgG and NMD receptor IgG, and both were found positive. As you all know, MOG antibody-associated disease forms a clinical spectrum. Probably the commonest phenotype of MOGAD is optic neuritis, and in children, ADEM is also commonly seen. And as we already discussed in a previous session, some MOGAD patients may fulfill the diagnostic criteria of aquaporin 5GG negative NMOSD, and short and long spinal cord lesion may be seen, and brainstem and cerebral cortical encephalitis is also a phenotype of this disease entity. Recently, we published the neuroimaging features of brainstem lesions in MOGAD cases, and it was compared with aquaporin 5GG positive cases. And can you see the distribution of the lesions? If you compare this with the findings in this case, they're very similar. So I think the first event, brainstem encephalitis, was caused by MOG. Then what about the second event, which was a non-fluent fluent aphasia? Is it NMDA receptor antibody encephalitis? Probably, as for the typical clinical feature of NMDA receptor encephalitis, you imagine that a young lady acutely developed psychosis, followed by seizures and unresponsiveness, and the patient may have to be hospitalized for more than a few months. So the mild aphasia that resolved following IV methylprednisolone was quite different from those typical features of NMDA receptor antibody encephalitis. But recently, Professor Sean Pittock's group at Mayo Clinic analyzed coexisting autoantibodies in MOG IgG positive cases, and they found that NMDA receptor IgG was the commonest one, and 7% of MOGAD patients were also positive for NMDA receptor IgG. And although I do not know the details of their clinical features, based on the descriptions, these doubly positive patients were clinically characterized by encephalopathy and seizures. So those symptoms may be explained by NMDA receptor IgG, but I do not know the detail. I searched for case reports that had similar features to my case, and I found at least 3 cases with NMDA receptor encephalitis presenting as isolated aphasia. This case, sudden and isolated broker aphasia, and it was seen in 4-year-old women. And this is a finding of FDG PET, and you can see the left hemispheric hypometabolism, but brain MRI was normal, and left hemispheric slowing was seen on EEG. The second case, adult onset NMDA receptor encephalitis presenting as a non-fluent aphasia. This is an adult lady, NMDA receptor positive in CSF, brain MRI again normal, but she had abdominal teratoma. The third case, NMDA receptor encephalitis presenting as isolated aphasia in a 29-year-old lady, antibody positive in CSF. Again, brain MRI was normal, but EEG showed paroxysmal delta wave. So I suspect that the first event, brainstem encephalitis, was probably caused by MOGAD, but the second event, aphasia, might have been caused by NMDA receptor IgG. That's my guess. I do not have a definite answer, but I would be happy to have your comments and questions.
Kazuo, great fantastic presentation. So I have a question. So are you of the mindset that similar to NMOSD and the myasthenia gravis experience, where myasthenia may precede the development of NMOSD or vice versa, do you think that those with MOGAD, are these individuals who are MOGAD positive and whatever titer, do they have a greater propensity for other autoimmune disease within a given time frame following that?
That's a very practical question. And at least certain percentage of the MOGAD patients do have other coexisting autoimmune disorders or autoantibodies. But the frequency in MOGAD, such a frequency in MOGAD was much lower than that in AQP4 positive NMOSD. So most patients, not many patients may have multiple other coexisting autoimmune disorders. But as I mentioned, among them, it seems that NMDA receptor IgG is the commonest coexisting autoantibody in MOGAD patients, although it's just 7%. But so if we encounter a clinical presentation which may not be commonly seen in typical MOGAD cases, we may need to think about something else. That's my comment.
Do you think there should be a recommendation to start to look for NMDA receptor antibodies when patients who are MOGAD positive with brainstem lesions present? In the absence of clinical symptoms that go along with NMDA encephalitis.
Well, if you study a large number of patients, even if asymptomatic, you may detect some coexisting autoantibodies, so pre-symptomatic phase, so that can happen. As I mentioned in my talk on NMOSD, some myasthenia gravis patients later develop NMOSD, but probably those patients were aquaporin 5 IgG positive long time ago, before the onset of NMOSD. If we can detect aquaporin 5 IgG at that point, we may think about starting another immunosuppressive treatments to prevent the onset of aquaporin 5 IgG positive NMOSD. But for example, as for the frequency of aquaporin 5 IgG in myasthenia gravis, much less than 1%.
That's right.
Very labor intensive. You have to spend a lot of money, but if you are wealthy, you can do that. And you may be able to save patients' life. That may be critically important.
Absolutely. Thank you.
Professor Fujihara, regarding NMDA receptor encephalitis, if you take the encephalitis alone, it is extremely rare for monosymptomatic presentations of NMDA receptor. It's less than 4%, I think, all over the world that they have looked at it. So perhaps this is a completely different entity when it occurs with the MOG antibody, because these patients present with monosymptomatic aphasia. So maybe we are seeing a different entity where there is this overlap of MOG antibodies and NMDA receptor antibody. Because NMDA receptor antibody encephalitis one would expect it to progress and develop other neurological phenomena.
That's a great question. And it's simply because I examined both MOG and the NMDA receptor IgG. And since I thought aphasia without brain MRI abnormality was not typical of MOGAD. So as I said, I searched for similar cases in NMDA receptor IgG positive cases, and I found some cases like that. But actually, isolated aphasia may be attributable to some other autoantibody. So I'm not sure if my guess is correct answer. So.
Okay, thank you. Shall we progress to the next case?
Yeah, may I?
Yes, please.
Okay. The second case, I have only 3-4 slides. So the case 2 is 28-year-old woman who had weakness and hearing impairment. So 1 year ago, she developed weakness in 4 limbs, and now she's weak in both upper extremity and hearing impairment, more severe on the right-hand side than left. And left visual field defect was also seen, and the CSF cells may be a bit higher. Protein levels were high, and the oligoclonal band was negative. And the fundus photograph shows soft exudate, and fluorescence angiography revealed branch retinal artery occlusion and hyperfluorescence of arterial wall. And the audiogram showed bilateral sensory hearing impairment in low-pitched sound region. And this is the MRI. And the MRI shows the multiple hyperintense lesions in corpus callosum, white matter, and pure matter. And the diagnosis was Suzak syndrome. As you all know, this is a very rare syndrome, and the cause is still unknown, but it seems the abnormalities in the microvasculature of the cochlea, retina, and brain. And as for the diagnosis, it is known that this clinical triad, namely the branch retinal artery occlusion, sensory neural hearing loss, and brain lesions on MRI. And as you see here, the lesions in the middle of the corpus callosum strongly suggest Suzak syndrome, especially this, like this, snowball lesion like these. But unfortunately, at presentation, less than 20% of the patients with Suzak syndrome have complete triad. So it may not be easy. And I think that in Japan, Suzak syndrome has been very, very rare. But my colleague, Dr. Ichiro Nakashima, encountered this case recently. So that's why I presented this case here today. Thank you.
Thank you very much, Kazuo. Yeah, thank you.
Kazuo, I wanted to ask, do individuals with Suzak syndrome have MOG antibodies?
Well, I think Ichiro already examined the MOG IgG in this particular case, and I firmly believe that the patient was negative for MOGAD. But thank you for the question.
Kazuo, can I ask you why you did NMDA receptor antibodies in the first case when there was MOG positivity?
Well, because as I said, the second event, aphasia, was not associated with any brain MRI abnormalities. In MOGAD cases, especially the brain manifestations are usually associated with brain MRI abnormalities. And also I had an impression that NMDA receptor IgG is relatively common in MOGAD. That's why I tested both.
Yeah, in the absence of any further questions, I think we can wind up this session. I would like to once again thank Professor Kazuo Fujihara and Professor Okuda for being there throughout this session, and also my co-chair, Professor Chang. And thank you very much once again. And we wind up this session and the academic activities for the day. Thank you so much, Kazuo.
Thank you very much.
Yeah.
Thank you, Darin. I really appreciate it.
Thanks, Kazuo. Thank you, guys. Thank you, everyone.
Thank you. See you.